your consultants do ETV. And I told him, this is not what I do. Actually, all my residents already early on learn ETVs. And to be the shunt placement in infants or prematures is done by a senior consultant, because that is the tricky one. These are not the easy cases, and you can make a lot of mistakes. So
not to underestimate what we consider to be
so-called easy surgery is not. My teacher always told me the only easy surgery is the surgery that somebody else is doing, not yours. Because you should never consider it, this will be an easy thing. That is wrong. Even for a carpal tunnel. You would say, but if that is a piano player and you damage his a branch to the thumb and he can't play anymore, that's severe. Or if they have RSI afterwards or remaining pain. So every surgery needs to be done really carefully and consider this is another human being placing trust in you, that you even the so-called easy surgery, because the most complications come with so-called easy and quick surgeries. There we make mistakes. I have this medical legal case of doing a neuralgia paresthetica.
Oh wow, really?
They cut the femoral nerve.
Oh dear me, really?
Yeah.
The thing is, like they say, the most of the car accidents are actually within 1 mile of the house.
Oh yes, absolutely.
I remember, it's. I think you're absolutely right. I think it's from the beginning to end, any surgery. I think one of the things that I liked about Dr. Lawton's talk was it's the approach and the mindset and that was what. I wish I had, in those days we used to have, you remember the VHS, and when you're a medical student resident, when you look at it, you never understood what was happening, because
but it starts already with the positioning, and therefore if the resident comes in when the dura is just open, they have never seen how the patient is positioned. That is so important. What I like, because I have done 3 of such approaches, that was the contralateral, supracerebellar, and then transnatorial approach to the contralateral ambient cistern, because there you see first the basal vein of Rosenthal, then you find the P2, the P3, you follow the posterior cerebral artery inside the ambient cistern. So that's a roadmap, your vein and your artery. And at the end of that, at the junction to the P2, you are at the pulvinar of the thalamus. And there was this cavernoma. There it bulges into the ambient cistern. So that's beautiful. That's a beautiful approach. I often show that also, such a case, because from the approaches is so nice to do this. Absolutely.
Yeah. And the other thing is that in terms of I think for to be in the old days to hear a lecture, you had to go all the way to the meeting, and I'd honestly tell you, it's for a junior it was expensive enough, but when you become a consultant it becomes impossible, because the registration fee just jumps up and our pay doesn't go up.
Enormously. Yeah, that's I have to say, fortunately in the Netherlands, at least in the academic centers, you have a personal budget to spend for this continuous medical education, which is necessary. Listen, it is nearly, I see Noor is already there.
Oh, good. Excellent.
Very good. I see her on the list. I take another cup of coffee and then we...
brilliant. Hello, Noor.
Yep.
Fantastic. Thank you, Prof. Morning, Noor.
Good morning, sir.
Good morning. Good afternoon, probably in India. Excellent. Welcome, Noor. You are kicking off. I'm just pushing things through into the cyberspace. And hope you had a good day yesterday, and we have another great day today, so God willing. What do you call let me just get this. So we have got how many minutes? 6 minutes to go. Okay.
6 minutes.
Good. Excellent.
So it was an amazing day 1 for the conference.
It was, wasn't it? It was what
What?
you call. It was. It really went. Amazingly well. And I think it's a really hard
It
act
was
to follow today.
magnific.
I know. I mean, to be honest, I was quite. It's really hard to compete with yesterday, and I hope we at least come to the same level. Dr. Professor Grotanius, I was saying that
I heard you. Yeah.
It's honestly after this meeting, I don't know where I go from here, because I might have to just.
And you have still this whole day, and then the Sunday. So this is in. You mentioned it yesterday. This is one of the longest conferences ever.
I hope it was the longest ever day in the history of neurosurgery. I don't think anyone
listen, I think from the webinars, this web conferences, the good thing is that people can pick 2 or 3 hours out of it with the subjects that they are interested in.
Absolutely.
So if somebody really wants to see an update on craniosynostosis, he follows that part of it.
Exactly.
And he will probably not look to this wonderful talk on brainstem cavernomas. But vascular surgeons will only have the evening session, because they say, oh, no, really the interesting things come. I mean, still, I find everything in neurosurgery interesting. So from peripheral nerves, I like that also much. Trauma, functional, we see such much developments there. And so it is very interesting to see. And I'm also looking forward to the 2 lectures of Noor, because Noor has 2 lectures in this session. And very diverse, Noor. That's on the topics. So we will see. So this is quite diverse, and that's nice. It's a mix, Naren, of the
programs.
Absolutely.
Program is very mixed, and my prediction is that Professor Grotanius, that in 10-15 years time, the people who presented this weekend, they will be the people. They will be pretty important. They will be pretty dynamic people in 15 years time. When I started the listserv, I was once I gave something to Dr. Baskaya, and he said, Naren, I'm just a fellow. I said, no, you are going to be big. And I honestly tell you, I think this is kind of a selective process, this conference, because you have to have the dynamism to trust and have faith and put your abstract into this. And you know what I mean? It's and you saw how the juniors did fantastically, I think.
Absolutely.
And I honestly think, mark my word, in 15 years time, we will see
people will remind this special year 2020, where people and they say, at that moment I listened to that and that. So listen, I'm always extremely happy when my former residents, and some of them are already professors and chairmen, and they still send me through WhatsApp sometimes the surgeries that they did, and I'm so proud of them that to see that they have surpassed me way back. They do things that with let's say, indeed, I never did a bypass to the posterior cerebral artery in my life, but they do, and they remove the incredible. But it is so nice to see that your pupils are surpassing. And already my teacher told me, if you will not be better than I am in 10 years, we don't have progress. And I said, should I be better than my professor? No, of course you should. You have more possibilities.
Exactly.
At my time, when he retired, we didn't even have an MRI scan at that time.
No.
So he never have worked with that, and didn't even know the word neuronavigation and intraoperative neuromonitoring and all these things that are now normal. And what we will see with artificial intelligence and with robotics and other developments, I think this will it will completely change. But it's great to just follow.
Brilliant. Okay, I think welcome, Christine. Hello, Christine.
Christine also. That's a long time ago. I think last time was in Malaga.
Yes.
No, in Amsterdam, I think. That was
in Amsterdam.
With the
It was 2018.
Stryker there, the headquarters.
Exactly.
Exactly. Oh, that's My
So-
goodness, that's already some time ago.
It's a pity that we didn't meet in India this year.
Yes, we are.
This year.
Absolutely.
I mean, Mysore would have been great, but I'm sure we will. I'm reading I'm on 2 weeks annual leave, so can't go anywhere. So this is why I'm doing this. And I've been reading the book on the shortest history of Germany. So I'm progressing now to 1,500. So
how many pages does the book have?
it only has about 200 books, 200 pages. It's a really good book.
On site.
Yeah, it's called The Shortest History of Germany. And so yeah, now let's see on time.
Yeah, it is.
Good.
Yeah.
Great. Good morning, everyone. Thank you very much for coming for the second day of the World Neurosurgery Webinar Congress. We have got another exciting program today, and I'm pleased to have Professor Groton Hughes. I keep saying honor and privilege. It is honor and privilege, the people who have been here. And Professor Groton Hughes, again, doesn't need any introduction to the neurosurgical community. Professor is now Emeritus Professor of Neurosurgery at University of Nijmegen, a master surgeon, master educator, president of the former president of the EANS, and I think senior vice chairman, president of the WFNS, and recently in the last month in the EANS Congress, Prof has been appointed as the president of the EANS Foundation, which is the charitable arm, and I'm sure he had taken EANS to a different level in the last 5 to 10 years, and I'm sure the EANS Foundation is going to be another powerhouse and with dynamic ideas, and look forward to that. And I have to say, I will copy what you are doing, Prof. Thank you very much. So the first talk. The first talk is going to be from Dr. Nu. I'm going to leave Professor Groton Hughes to introduce. Prof. Okay?
Yeah, well, it is my pleasure to introduce the first speaker. It's Maria Noor Al Huda from Pakistan. An interesting topic on the body weight as a factor for postoperative COVID-19 infection risk in pediatric patients. Please, Maria.
Thank you so much, sir. It is a matter of deep honor for me to present at this very esteemed platform online and to the webinars. I'm really pleased and deeply obliged to share my very humble work. This was, can't you see my slides?
Yes, yes.
Thank you so much.
Yes.
This is something that is, I thought that may be important in the wake of a pandemic. It was for a general interest, and this was conducted at the pediatric hospital in Pakistan, in Lahore, from where I collected most of the data, and also all those pediatrics that have been referred to us. Actually, it is a side paper of my bigger paper that is on CSF transmission of the COVID-19 SARS-CoV-2. Here, I'm just discussing a very small part of it, the body weight and the postoperative COVID-19 infection in pediatric patients. The objective was to evaluate the link between body weight of the pediatric patients between the ages of 1 year to 8 years and the incidence of acquiring COVID-19 infections postoperatively. So we actually had several factors to be considered in this topic. The background was, while it is generally believed that the incidence of COVID-19, especially symptomatic and severe, is less in pediatric cases, it is prudent to conduct a study to know what is the exact incidence, especially regarding the body weight. There was a very good study from China that all those patients who were born as a low body weight babies severed from most of the complication of COVID-19 as an adult. They collected data from a few adults. It was more a case series, not a big study, but a case series where they just traced them, and 70% of them had a history of being born as a low body weight baby. So we wanted to know that how many patients in our pediatric age group were low body weight, since low body weight is quite related with the infection incidence and also the severity of the infection. So actually we enrolled patient admitted and operated from 15th March till 15th of September. But in Pakistan, the lockdown was imposed on 18th of March, and that was extended twice. But by the 15th September, the lockdown was lifted. In our hospitals, only the emergency surgeries were being performed during 2 months period from 18 March and 2 months onwards. And after that, we were able to perform all the elective lists as well. A total number of 78 patients of both genders were enrolled, and their medical records were gone through thoroughly. The age range was between 1 year to 8 years. Most of them were operated for pediatric intracranial tumors, because it was the one thing that we would not defer even in the lockdown period. Patients were stratified according to weight into below average, average, and above average according to their age group standard weights. That was standardized and matched with the charts in our hospital. What we found was the mean pre-operative admission was 4 days, and the mean post-operative time was 6 days. We tried to keep it as short as possible, but because of many of our patients are being referred from the peripheral areas, so we tend to admit them for a bit longer period, since we know that many of them will not be able to get a lot of medical attention after surgeries. Even if it is a minor one, then we have to look for that and have to consider that, but we have the mean area for that. Mostly the patients were admitted for intracranial brain tumors, with 57% of cerebellar tumors, 18% were craniopharyngiomas, 21% were simple VP shunts, and 4% had surgery for teeth code. A total of 16% of the children were above average weight, and that was matched for their age, charts for the match for their age. 24% were below average weight according to their age specific standards. Patients were kept for shortest possible pre-operative and the post-operative period. Complete precaution against COVID-19 were taken, where we used the level 3 PPE. Patients were asked to follow up first for stress removal and then after 2 weeks. Other follow-up schedules differ according to the patient to patient diagnosis and the state. All patients were told about the likely symptoms for COVID-19 infection and were asked to report in case they come positive. Most of the time, the thing that we have noticed in our pediatric patients were obviously the upper respiratory symptoms and as well as diarrhea, that was very commonly found in the pediatric department, the pediatric medical department. Basically, they notified us that the diarrhea is quite evident. Incident of the diarrhea, presentation of diarrhea is quite high. Average recovery time for overweight was found to be 12 days. For the underweight, it was 14 days. That is, all those patients who suffered from post-operative COVID-19, the average time for those who were overweight was 12 days, and for those who were underweight was 14 days, and for the average weight range of children, the recovery time from COVID-19 was 10 days. So only 9 patients, that is 11% of the patients, were turned positive for COVID-19, with one turning positive preoperatively, for whom the surgery was postponed, because we didn't want to expose that patient to the surgical to surgery. So for him, we postponed the surgery. The other 9 were tested positive for COVID-19 after being operated. 2 of the patients were turned positive on day 2, that is 2 days after the surgery, and the other one was 3rd day post-operatively. 3 patients turned positive on 4th postoperative day, while 1 turned positive on the 7th postoperative day. Out of these 9 patients, 55.5% belonged to below average body weight, while 22.9% were overweight. So if we see from here, the risk of getting infected, the incidence of infection was higher in those who were below average body weight as compared to those who were above average body weight. However, there was not much difference in the recovery time from COVID-19, and all of them recovered without any surgical related complication as well. So these patients have it was a blessing that all of these pediatric patients who were done positive for COVID-19 actually recovered completely from it without any complication, and God forbid, no mortality as well. And they didn't even succumb to any of the surgical complications. So according to this, we can see that the incidence was higher for underweight children, but the incidence of complication was same regardless of the body weight of the pediatric patient. So here we can see this is a percentage of the sample. The 1 to 2 years was about 11%, 3 to 4 years was about 28%, 5 to 6 years was 30%. This is the sample, basically the distribution, the demography of our sample. 5 to 6 years patient were about 32% and 7 to 8 about 37%. So this is the basic look at our sample size. So we can see that most of the patients were between the age of 5 to 6 and 7 to 8, followed by 3 to 4 years, and the least were from 1 to 2 years. So overweight patients were about, you can see, they are about 17%, and underweight from the sample were about 23%. The average recovery time in the average weighted patient was about 10 days, and it was slightly more for those who were underweight, and it reached about 14 to 15 days, while for the overweight patients it was about 12 days. So we conclude from this study, we strongly suspect that the risk of postoperative infection for below average body weight pediatric patient is slightly higher, but we suggest further studies on this topic as well, so that we have that in our mind. And I think that if there is no urgent need for surgery, then we should consider a better circumstances for those patients who are underweight. But most of the time in neurosurgery, we do not have that much of liberty of selection of postponement and deference of the surgeries. The study that actually relates adults who were born low body weight, there was a study that the adult COVID-19 patients who were born with a low body weight suffered with prolonged and complicated infection. We therefore suggest more study on this extremely important topic. The another thing that we wanted to emphasize and we haven't studied is that many of the patients who are being born underweight, and maybe many of them may be preterm and have surfactant issues that might have led to some congenitally, we can say they may have some pulmonary problems that may later manifest in their later life with COVID-19 infection, because COVID-19 basically has a lot to do with the surfactant. So maybe there is some underlying cause in that case, but we need to study that, and we haven't yet started that study at all. Thank you so much. This is a body weight, average body weight chart that I have studied. Thanks a lot. I think it was the whole thing.
Oh, absolutely, and nicely on time. Thank you so much.
Thanks, Ozone.
So this was a very interesting study, and generally I think that we know that, for example, prematures and babies with underweight, we know that from the shunts that they have higher risk of having a shunt infection. But the link that you now brought to the adults is very interesting, because we know in the COVID-19 that overweight, so obese adults, have a higher risk of having a bad outcome of the COVID-19 infection. But there are many studies already showing that low weight at birth is related to obesity in adult life. Some say that is probably a catch-up, but there is also an underdevelopment, apparently, of some of the immune reactions. And as you say, that would be interesting, also still a kind of chronic lack of the surfactant in the lung. So it's very, very interesting. This is a general medical topic, more or less, but
yes,
very nice to relate this to neurosurgery. Any other questions from the chat room? Let's see here. No, not yet. So then I thank you very much.
Thanks a lot, sir.
You stay around because you have another lecture later on. And is Dr. Shaleh Drehem already here? Yeah, I see at least his sign here.
Okay, let me just make him.
Unmute him.
Yeah, unmute him just a second. Dr. SHA, good.
Are you still muted?
Yeah. Dr. Durham, you can unmute, and do you want to share your presentation, please?
Yes, great.
Okay, sorry.
No, well done.
So Dr. Drehem will talk on an hemorrhagic parasagittal meningioma. So please.
Okay, I will share my screen.
Thank you.
Okay, good morning, everyone. So I will sharing my experience about hemorrhagic parasagittal meningioma case in Indonesia, in my hospital. Originally, I'm from the Surabaya, Indonesia, from the Department of Neurosurgery, Faculty of Medicine at Erlangga University. Academic General Hospital, Dr. Sutomo. So the abstract of my case report. Okay, the meningiomas are tumors that are often found and responsible for the 20 to 30% of primary intracranial tumors, and prevalence peaked at the age of the 50 and 70 years, with a ratio between women and men is 3 and 2. And the prevalence rate for meningiomas are varies and range from the 50.4 per 100,000 to 70.7 per 100,000. And annual meningioma incidence rates are reported by several major centers around the world. Meningiomas are the most common brain tumors reported to the U.S. Central Brain Tumor Registry in the United States, or CTBR-US, before glioma, which is 6.0 per 100,000. So this is the case of my patient. She is Mrs. L, female and with 38 years old, with the main complaint is decrease of consciousness. This patient referred from the Sumerep Hospital with main complaints gradually decreased consciousness since 2 days ago. There's a headache since 1 year ago, increasingly aggravating, and weakness of half the side of the body, the left side, since 1 year ago, and decreased vision since January 2019. There is no seizure, nausea and vomiting denied, tingling half of the body is denied. There is no fever, there is no hypertension, there is no diabetes, there is no stroke. This patient also diagnosed with the brain tumor since 1 year ago, never had any surgeries. And there is using birth control injection, but the family member doesn't remember since when they're using the birth control injections. With the Glasgow Coma scale is for eye is 2, for bell is 1, and motoric is 5. There is no meningeal sign. In the cranial nerve examination, the pupil round is occurred with the size of the pupil is 4 millimeter and 4 millimeter. And the lateral flight is decreased, both of the eyes, and there is a lateral lesion in the left side. Okay, after we do the CT scan with the contrast, we can see that there is a lesions with contrast enhanced in the regio-parieto-occipital dextra, suggesting it with extraaxial tumor with the base sagittalis sinus, superior 1/3 medial, and peripheral edema around it, and there is a bleeding intratumoral. And then we perform the craniotomy, tumor frontal resection, and osteoplasty. These are the pictures. And the most common localization in meningiomas are in the parasagittal, lateral convections, venoid wing, anterior fossa close to the olfactory nerve, stellar region, and posterior fossa around the foramen magnum. Therapy for the patient with the meningiomas needs to be done individually because every patient is different, and also the nature of the meningiomas and the potential consequences of different treatment for different patients is very greatly. Surgery has long been the treatment of the choice, and only one, the therapeutic option for the most patients. About the spontaneous bleeding due to intracranial neoplasm is usually rare and only occur is about 1.4 till 10% of the case of the intracranial neoplasm. This bleeding is usually associated with the malignancy such as glioblastoma, oligodendroglioma, and metastatic brain tumors. And the meningiomas with the intratumoral bleeding are very rare. That's why I choose this case, because this case is very rare, and I think it's lucky if we have this case. And the pathophysiology is still not well known. The incidence bleeding in the meningiomas range between 0.5 till 2.4%, with the mortality is 28 till 50% in the last third decade. Nero et al. Described only 6 cases or 2% of the onset of bleeding in 298 patients with intracranial meningiomas. And bleeding in meningioma is still limited to the tumor itself. Intratumoral with the surrounding in parenchyma, in intracerebral, or it might be extension to the subarachnoid space. And it's estimated that less than 2.5% of the meningiomas experience bleeding. However, the mortality due to meningioma bleeding was reported at 21.1% and morbidity at 36%. In cases that have been treated operatively, mortality in meningioma bleeding reaches 9.5%. So this is the evaluation of the CT scan. After we do the craniotomy for the total resection of the tumor and osteoplasty, we can see the tumor is already resected. And also there's a lot of theories about the intratumoral bleeding. However, we have I conclude, there is three theories that have been read. The first theory is about the necrosis theory. Necrosis theory means tumor growth due to the venous thrombosis. In the research of the Kim et al., they state that the case of meningioma with the peritumor bleeding, they found a necrosis and infarction from the histopathological examination. There is no abnormal blood vessel were found, so the bleeding was thought to be purely because of the necrosis. And then the second theory is angiogenesis theory. Angiogenesis occur when the tissue of the tumor is diameter of the tumor is exceed 2 till 3 millimeter. If it is exceed than that, there will be forming of the new blood vessel. There will be angiogenesis. This promoted by vascular endothelial growth factor, platelet derived growth factor, fibroblast growth factor, epidermal growth factor, and transforming growth factor. And the third one is the risk factor of the intratumoral bleeding is the increasing of the risk. The increasing of the risk of bleeding the meningioma is because of the anticoagulant use, pregnancy, age, tumor location, and embolization history. Okay, thank you. That's all.
Thank you very much. This is an interesting case.
Yes.
As you said, because it is very rare that meningiomas bleed. And if they do, it's usually in the subarachnoid space or subdural space. But purely intratumoral hemorrhages, as you showed, that is exceedingly rare. That's indeed. Interestingly, here this lady had been diagnosed already before, so it was known. And sometimes I think because of location, close to the mid-sagittal gives.
Or little means when there's two.
Sorry, there is somebody.
Sorry.
Somebody is.
Oh, sorry. I'll sort it out. Thanks. Sorry. It's the next presenter. Just a second.
Okay. Okay. So then I don't know if there are questions from the floor. I don't see that in the Q&A and chat. So thanks for this interesting case, and we go ahead with the next speaker, Dr. Piromali, with a single center review of endoscopic septum tracheostomy success rate. Are you there? Yeah. Oh, you already unmuted. Good. Please.
Can you hear me?
Yes. We can hear you.
Yeah, sure.
Yeah, you
want to please, thanks.
Mm-hmm. Yes, now we already see something. Please make a presentation of it. Yes, excellent.
Great.
Right.
Excellent. Yeah.
Okay. Hi, a very good day to you all. I know for some of you all it's morning now. Right here now it's almost 6 p.m. right now in Malaysia. I would like to take this opportunity to thank Dr. Naren as the organizer for bringing us all together in this era of COVID-19 pandemic. I am Dr. Vinod, a neurosurgeon from Sabah, Malaysia. My topic today will be a single center review of endoscopic third ventriculostomy ETV success rate in our center. So as we all know, neuroendoscopic surgery is a very popular as a minimally invasive procedure, and endoscopic third ventriculostomy is common in treating pediatric hydrocephalus and is routinely practiced in most centers worldwide. This success rate of ETV in various pathologies actually differ, and the correct choice of patients are very crucial. So the main objective of why we wanted to do this study is to evaluate various etiologies, and it is a retrospective review. And other than that, we wanted to see the surgical indications, patient outcome, and also review the ETV failure and what were the shunt dependency rate. So, and also we also wanted to determine if our local cohort and our patient outcome match the results published by the original ETV success score paper, to see if we were actually doing the right thing with the patients. So what we did, we analyzed all pediatric patients treated for hydrocephalus with ETV done, aged between newborn to 12 years of age over the span of 3 years. We included data of underlying pathology and the post-ETV BP shunt dependency rate. So what we observed was we managed to include 43 patients, and among these patients, highest were in the group of obstructive hydrocephalus secondary to tumors, and the least was observed among the one case of post-traumatic hydrocephalus. We also had 9 post-infective hydrocephalus cases, and others were cases of congenital hydrocephalus. So if you can see, among the failures of 34.8%, majority was seen among the obstructive tumors causing hydrocephalus, and the balance was seen among the congenital hydrocephalus patients. Failures are also commoner with those younger age patients aged less than 2 years old. So this is actually a chart, this is actually a table here comparing the score given by the original score to our results of the ETV success score. So as you can see here, the last third column on your right shows the failures requiring BP shunt by 1 year. And you can see there's almost 90% to 100% failures seen in the poor group with a low success rate. And you can see this high success rate group of more than 80 shows a 100% success rate. Actually, the middle group of moderate, which is colored in the yellow group here, this is actually where the real problem lies, because you can see there's a very variable result that we actually obtained of 22 to 60% success rate. So this is the group where the right choice of patients needs to be chosen, because they can either be okay or the ETV can actually fail. So what we actually observed was the ETV success score, this paper by Kulkarni et al. Actually estimates success by 6-month post-operative period. So the overall success rate of ETV in our cohort is about 65.2% compared to the published data, which is about 59. So our data is actually comparable to the published data. And also the outcome of the procedure is highly dependent on the etiology and age. These are the 2 main variables we observed. So the favorable outcomes were seen in those of congenital cases, about 75.6%, and followed by tumors causing obstructive hydrocephalus. Poor outcomes are seen in those groups of children with infection and lower than age of 1, with almost 63% failure. So with this, we actually managed to gather information, and we concluded that ETV done with the correct indication becomes a valuable asset in reducing requirement of BP shunt in cases of pediatric hydrocephalus. And this ETV success score also proves to be crucial in aiding decision-making, as it has been proven reliable, especially with all the published data. This actually might look like a very simple topic that but most of us overlook the requirement over years, because the ETV success score is actually a very good guide to most of us most of the time. But choosing the correct patient every time becomes a problem, and this is how we can actually audit ourselves to see if we are doing the right thing in addressing these patients' hydrocephalus treatment. Thank you.
Thank you very much, Dr. Virumali. It's indeed interesting. The good thing is that such a study as you have done shows that it is not only a valuable asset in the treatment of hydrocephalus in a few places in the world, but this is a treatment that will and can be and should be performed globally. And that's excellent. The ETV success score, as you rightfully say, it is this moderate score is always difficult. The prediction is unclear.
Yes, now, you're right there.
This is I had that same problem when in my own cohort, let's say the infants with myelomeningocele, when we did initially in all those patients in the early 90s, we did ETV, and only 20% was successful. You would say, oh my goodness, 80% had a surgery that was not successful and needed a shunt afterwards. That is too low, but nevertheless, 1 out of 5 still didn't need the shunt. So if you accept that, also as a parent, maybe that is, that at least there is a chance. And you could say, is 20% too low? Even if in one infected case, you can still prevent becoming a complex hydrocephalus or needing a shunt, could already be worthwhile. The difficulty in this discussion is that ETV is not a surgery completely without risk. So therefore, I hope there are some questions maybe in the chat room. Do you know that, Naren? Do you have some?
I think can I just ask both of you one comment and one question. In terms of the ETV success score, I think they used, I'm sure they used logistic regression to come up with the model, but that was now what 10 years ago, I think, and the thing is that now machine learning and deep machine learning have come in, and logistic regression is still extremely powerful algorithm. So logistic regression is one of the algorithms for machine learning, but there are other machine learnings, and with the input of someone from a bit of first of all, so with machine learning you can even bring the prediction model even to a better precision. And the thing is that machine learning is not now as complex as what it used to be 20 years ago, 10 years ago, 5 years ago. It's really, I mean, there are a couple of softwares which are authenticated, professional softwares on the web that you can download. One is called Orange 3 from Slovenia University. And you can use machine learning to try to see whether your data, when you predict the model with the machine learning compared to the ETV success score, whether these two models are the same. Maybe I should do, but I really tell you. And the thing is that if you, there are many softwares for machine learning. Believe me, doing machine learning nowadays is easier than putting a PowerPoint presentation. That's why I haven't done a machine learning tutorial, because in 5 minutes I'll be completely redundant. The thing is that, so that's number one point. I think it's really well worth it. And if you get a mathematician, okay, to get the algorithm to snugly fit, I think, it's like neurosurgeons, probably a general surgeon can do a burr hole, but a neurosurgeon knows the finesse. And in the same way, if you get mathematicians to help you with the machine learning, I think it will be with everything, things get better. So I think you can improve it. Second is question to both of you, Professor Grotanius. I'm starting to like shunts, to be honest. I used to think ETV is everything. I'm not saying ETV is not, but I think in terms of carefully following the patient up, making sure it's working or not working, all those things, it's an absolute meticulous thing with a lot of resources and time, and the parents being alert. How do you go about, we have got a bit of time, how do you go about ensuring it's a absolutely beginning to end watertight care?
What do you mean with watertight?
I mean, the thing is that with the ETVs, you are not sure it's working. The child's head might be going up, not being picked. Parents are happy that. So my worry is that ETV, not the catastrophic failures, but the chronic failures might go unpicked.
Mm-hmm. Well, yes, I think the acute failures, usually you get a pseudomeningocele, you get a CSF leakage simply because the pressure now finds an easy way out, and that is the channel you created with your endoscope. So that usually points to the fact. Then you can still do lumbar punctures and hope that the CSF absorption will, this adaptation time on at the ETV will help. But these are the acute failures. The chronic, that was more difficult, because we now all know that the ventricular size is not coming down very much in huge hydrocephalus after ETV. We all accept the small ventricles and sometimes slit ventricles after shunting. This has been shown in the infant hydrocephalus international study from Dr. Constantini, that when you follow the infants 5 years, you see that the general outcome is more or less the same, but the development of the child lacks something behind when they have larger ventricles. So there the judge is still out, but I think that's the point. You cannot tell parents or the patients himself that they are cured. They still are hydrocephalic patients that received a treatment. I made that mistake very early on and said, okay, we removed the shunt, we did an ETV, now you are cured, we don't have to see you at control. And then the cases slowly came up of sudden death after many years, simply because we didn't follow them. So it is a treatment like a shunt, and it can fail, and it sometimes can also gradually fail, or just not doing, well, quite right, and more or less like a compensated hydrocephalus state, but not as good as you maybe think the child could go on. These are the difficulties. We still don't have these data, and therefore I think we need to follow that. I'm reluctant certainly to do it in the very young, but depending on a secondary aqueductal stenosis or late onset aqueductal stenosis, that for me is still an ETV. The posterior fossa tumor, it's also an ETV. Initially, usually I first would remove the tumor and then we'll see if it is necessary, yes or no. And then the post-infectious, post-hemorrhagic, some of the so-called congenital without any clear reason or no aqueductal stenosis, it's insecure. The big advantage, and now I make it quickly, is the lack of hardware inside, because you all know that when you have a young child, it receives a shunt, the parents, and later on the child also, when they grow up, they know that their life is dependent on that hardware in their body. So if something happening, if they have something, they rush into the hospital because they know there must be something with the shunt. And we all know the patient with 25 plus revisions of the shunt. That's a difficulty here, why also neurosurgeons are so happy when they can avoid a shunt. But to be honest, you see, it's not 100%, as Dr. Perumali also showed. It is 2/3 of them do well and have no shunt, and 1/3 needs an additional surgery. That means afterwards a shunt. So it's something we have to keep in mind. Do you agree, Dr. Perumali?
Yes, I do. And also one more thing for Dr. Naren, actually regarding you becoming a fan of shunt these days, right? Actually, the question here is mainly about whether there's implant or not. So actually, we have also started moving away from shunts, and we have found that ventricular subgaleal shunt actually give a very good temporary diversion, and most of them actually get away from shunt dependency as well if ETV fails. I think that's another thing that we should look into in the future.
Good. Thank you very much. Thanks a lot. So I think if Dr. Karthik is there, Dr. Multan is there, please let me know. Shall we just go to the next, Dr. Noor's talk, Dr. Professor Grattan Hughes?
It's okay, because Dr. Karthik is not yet in.
I can't see him. He wasn't.
Then please, because Noor is here.
No.
Again, Noor Huda from Pakistan, on maternal care of a quadriplegic patient. Please.
Thanks a lot, sir. I'm keeping the screen now. Thanks a lot, sir. I'm again deeply honored to present my Hubble work. Can you see my slides?
Yes.
Thank you. So it is basically an important topic, and we came about this when we received a patient a couple of years ago. It is the title of my topic is the maternity care of a traumatic quadriplegic pregnant patient. Actually, basically, like I said before, we selected this topic because it was an important issue back then, as we have never received such a patient before. Like it was a couple of years ago when this patient was received by us, and we didn't even know how to manage this in a very good manner. There was no history, and even many of our seniors have never dealt with such a case before. So here we want to emphasize that fetal well-being needs to be assessed, and the residents should have an idea of how to assess it. The residents should be well versed with it, and they should know how to get along with that. You have to look for spontaneous labor and miscarriages in these patients, and a CTG and an immediate ultrasound is important to order. And we also want to emphasize that the multidisciplinary care of these patients for a safe course of events to follow. Our case was a simple one. A 28 years old primary gravida presented to us in the emergency room after MVA, a motor vehicle accident. She was the front seater in her car. That was a small car. In Pakistan, we have a smaller car that is a bit cheaper and quite much in use. It is known as a Mehran car, and it is much like a Beetle, a Bug, a small Chevy. But Chevy is a very strong car. It isn't that much strong. She was on the front seat, and she was waiting in the parking lot when a big truck hit her from the rear side. So she felt head on and suffered from this injury. When she was presented to us, she was totally quadriplegic with 0.5 power, and she was primary at 36 weeks of gestation, as she told us, and she was actually referred to us from another city that is about a couple of hours away from Lahore. The ER management had to, obviously the ER management starts from the ABC guidelines and stabilization, and according to our neurosurgical management of spinal injury, but it has to be extended, and in our case it has to involve the gynae specialty, and the fetal being was to be assured. We ordered an immediate ultrasound and a CTG, and patient had to be admitted in our HD, where we admitted her in the female HDU. In our female ward, they have an HDU that they are quite well versed with everything, and with experienced staff nurses, and they have everything if in case any of the complication arise, then they can wheel the patient everywhere. So she was otherwise okay, and we also managed to stabilize her. After 1 week, patient's attending mother noticed that she has undergoing contractions, and she notified the doctor on duty. It was evening, about 6 p.m., and only one doctor was on duty, and another one was an intern. When the patient was examined, she was fully dilated, and a healthy baby was delivered safely. We even didn't use any forceps assistance, and the doctor on duty and the nurses assisted in full complete delivery. Baby's Epcot score was 9 at 1 and 5 minutes, and patient went in eventful delivery as well as a postpartum period, which we followed her. So our major concern in this patient that should be that this patient can suffer from autonomic hyperreflexia during labor, which may result in potentially lethal sequelae that includes intracerebral hemorrhage. In this note, I want to also state that those patients who are quadriplegic, they tend to have lower blood pressures at the baseline. So in such patients, autonomic hyperreflexia means a rise of about 20 millimeter of mercury systolic or 10 mm of mercury diastolic blood pressure. So it doesn't mean that if we take the blood pressure of this patient and it comes out to be 120 by 80, then she's not in hyperreflexia, because her baseline blood pressure would be say 100 by 80. So for her, 120 by 80 might indicate autonomic hyperreflexia because it is a rise of more than 20 systolic and more than 10 diastolic. So in this case, we have to be really vigilant that even a normal blood pressure can indicate autonomic hyperreflexia in these patients. And the very other important thing is that this is asymptomatic in these patients. They cannot tell you, they do not have any symptoms regarding any headache or anything like that. They do not have, so attending doctor should have this in mind, that even a normal blood pressure for us, it's not a normal blood pressure for these patients. It is actually a comparison with the baseline blood pressure of these patients. There's a lot of risk of UTI in these patients. Obviously, we know that, and they do have intervalling catheters. The other thing is that the bladder should be always kept empty. It should be made sure that the catheter has not been kinked, because dilated and full bladder may also potentiate autonomic dysreflexia in such patients. Similarly, in constipated patients, rectal infection can lead to autonomic dysreflexia. While theoretically, the risk of miscarriage and infertility are higher among quadriplegic and paraplegics, it's has been observed that pregnancy is usually uneventful in these cases, and the indications for C-section are similar to those being applied for normal non-paralytic normal patients. So when we reviewed the literature, however, there's lack of literature regarding the management of these cases, and there are only a few handful of reports of these cases. But what we found was only this, like those indications for C-section that are absolute for the normal patients, such as the CPT, the disproportion, the cephalopelvic disproportion. It is the same for the quadriplegic patients. They can undergo normal delivery very easily, and it's very feasible, and that's very miraculous and quite unbelievable, but we have seen that. There is a lack of data regarding the management of pregnant quadriplegic patients, and more research is indeed needed. I would like to refer to a few literature papers that should be noticed. They are very notable. At the time we referred the literature to get more information, there's past data. And other thing that I want to say is that we should have an electronic database where patients should be registered by the doctors. Like we receive some patient who is some of interest of other surgeons and other dealing health personnel. We should enter that patient and how we manage it in the database, so that in case such a patient presents to any other center, that doctor should go to that database and collect all the record that has been put by the other doctors of the same specialty. So I think that we should have a database. I came to like I thought it when we had this patient, and we wanted to know how this patient should be adequately and nicely managed. So in that case, I just resorted to Google, and I tried to look for all the cases that were being managed by the other neurosurgeons. So if we have a database for such patients or other patients of interest, like case reports, the doctor only needs to enter that patient and how they managed it, so that any other doctor who came across such case, they could just go through that database and know how the patient was managed by the other centers and the other doctors. There is an important paper. Yes.
Noor, you have got 2 minutes. I think it might be my timing, but if you can, please. Thank you. I'm sure you're doing right.
Thank you so much. Thanks a lot, sir. So this is just a literature paper I want to go through by Professor Hardy, and the other two papers that refer to the same thing, the 24 years old Gravida 3 and 32 years old Gravida 2 para 0. So this is just, I think I have discussed that before. It is just about how things went normal with that, and autonomic apraxia, and how to treat autonomic hyperreflexia by sitting up and loosening any tight clothing, monitoring BP, check bowel and systolic blood pressure. And if it is more than 150, then we should go with the 10 milligrams fatapine, sublingual GT and sprays. An individual with the spinal cord digit of T6 has a normal systolic. The thing I think discussed before in detail. Medical care is very important regarding bed sores, UTI, respiratory complication, and rehab is of very is of utmost importance. The patient should be followed up very closely. So we conclude that normal delivery is possible, and there may be an increased risk of urological sepsis. Some authors suggest the use of forceps resistance, but in our case it is not needed. The indications of section remain same for the normal ones, and the need for multidisciplinary care should be emphasized. Thank you so much. I think I've tried my best.
No, you did very well. Thank you very much. I think it's an important topic. I'm sure Professor Grotenius will agree. I think we have got a lecture, particularly the control of blood pressure in quadriplegic patients is a very hot topic and controversial. Exactly. And we will have a lecture today from Professor Failings on acute spinal cord injury. So, I hope you will be there as well. And so thank you very much. Professor Grotenius, do you have any?
Of course, these are absolutely rare cases.
Yeah.
So it would be good to have a kind of database where people can put this in. I have never seen it in 40 years of practice. I have seen, let's say, comatose pregnant patients who deliver the baby. For example, after intracerebral hemorrhage and staying comatose, or after a trauma. So this is not absolutely the same as with quadriplegia, because as you said, the autonomic hyperreflexia can set in. So thank you for such a report. And Naren, please introduce the next speaker, because Dr. Karthik is not here.
Thanks. Thank you.
Our key lecturer.
Thank you very much, Professor Dufu. Thank you very much, Professor Grotenius. Noor, would you be able to stop the screen share. Have you already done?
Sir, I'm just logging back in.
Okay, great, thanks. It's a pleasure, privilege, honor to introduce Professor Hoos Dufu, who is one of the closest friends of the listserv, and we have over the years benefited from his experience, expertise in our courses and conferences. Professor Hoos Dufu doesn't need introduction. He's transformed the management of low-grade gliomas. If you haven't by any chance not read his papers, it's absolutely fantastic to read. This is a paper, when you read it, you realize this is an operation that is done with hands, mind, and also with absolute science. And I have had the privilege of visiting Professor Dufu, and it was an amazing experience. It was like a scientific surgeon operating. And his experience is vast. I think pretty much every tumor surgeon would have either been to Montpellier or closely followed his work. So it's with great honor to ask Professor Dufu to share with us this important presentation and the connectomes base of it. Thank you, sir.
Thank you so much, Naren, for your kind invitation. Good morning, everyone. Good afternoon for some of you. Thank you for giving me this opportunity again to show my experience with now more patients, but also new concepts. And especially I would like today to introduce the concept at the end of this talk of meta-networking brain, even if I would like to illustrate thanks to movies in order for young people to show that neuroscience can be applied to neurosurgery, and especially for the resection of gliomas. You know that the goal for many years, many decades in low-grade glioma was to improve both survival and quality of life. With more than 20 years of follow-up, I can really say that we reached this goal. Of course, we're not going to cure these patients, unfortunately, but you will see that we increase very significantly their overall survival, and also we preserve the quality of life by doing early surgery. So we stopped totally the wait-and-see attitude, and we pruned the performance of maximal resection. You will see that if you can take a margin in comparison with the preoperative flare, namely the concept of supratotal resection, please do that. But we have then to do resection according to functional boundaries, and then to know the connectome for this patient at that time, and to do intraoperative mapping, of course, but also monitoring and to introduce these concepts of neuroplasticity, connectome, and meta-networking brain. And then we can start to anticipate the strategy more than 10 years in advance. I will go very fast regarding the natural history of low-grade glioma. I'm sure that you know that this tumor involves, in the vast majority of cases, young patients between 20 and 40 or 50, enjoying normal life, and they have a seizure, and finally we can discover in the vast majority also of cases a big tumor, and nonetheless the patient is well. Be careful, because this tumor will grow, this tumor will become malignant, this tumor will induce deficit, this tumor will kill the patient. And in approximately, as you can see, within a median of 5 to 6 years, a malignant transformation, and median survival less than 7 years in the classical literature. First of all, you have to understand that these patients are not so well. So I will reinsist, as usual, on the fact that we have to perform a systematic cognitive assessment before any treatment, and of course after each treatment, not only surgery, but also chemotherapy, radiotherapy. And then maybe you could be surprised, but in more than 80% cases, you will see that patients are not so well, which is finally full of common sense. I mean, neuroplasticity exists beyond our imagination, but this plasticity has nonetheless some limitations. You can tell me, you see, finally, localizationism exists because these patients have already a deficit. And I will answer you no. The deficit is not related to the lobar location of the tumor. The deficit is related to the involvement of the connectivity, especially the white matter tract. For example, if you have already an invasion of the inferior fronto-occipital fascicle, then the preoperative assessment will demonstrate in the vast majority of cases that the patient already experienced some semantic deficit. Of course, if you do not perform the cognitive assessment, you don't know that, and you do not pre-plan optimally your surgery because you have to understand that the brain said, be careful, I'm not able to compensate specifically the ventral semantic pathway in this example. You know that the risk of malignant transformation is directly correlated to the volume. This is the reason why the goal is to reduce the volume, and we have nonetheless to understand before surgery that beyond this concept of volume, we have to calculate the growth rate. You will see something very simple. If you do 2 MRIs, you calculate objectively the volume, not in 2D, but in 3D. It's a tumor in 3D. Then you will see that if the tumor is growing faster, the prognosis is worse. You don't need to be an oncologist to understand that. All my patients can understand that. Nonetheless, it's not mandatory today in the classical recommendations to calculate the volume and the growth rate. That's totally crazy. Indeed, this growth rate is not correlated to the molecular pattern of the tumor. We demonstrated that you can have a tumor growing very slowly, even if they are IDH1 wild type. And that means that in the vast majority of cases, everywhere in the world, if you have today a wild type, then you will have a Stur protocol, at least a radiotherapy. We published recently, 2 years ago in Journal of Neurosurgery, our series, prospective series regarding the wild type. You can see that we have almost 95% of survival with a long-term follow-up between 7 to 10 years now. Nonetheless, we did not perform postoperative radiotherapy and or chemotherapy, except in 15% cases because the growth rate was rapid before surgery. And of course, you need just to wait 1 month. And in this month, before to go to the operating theater, you have to do the cognitive assessment, you have to do fMRI, DTI, and so on. And the patient will be ready in order to go to the OR in awake conditions. In other words, the molecular pattern is only a part of the story. And I say that on behalf of the European low-grade glioma network, and we published that in Lancet Oncology a few years ago. You know also that if we are doing just biopsy followed by chemoradiotherapy, the classical wait and see, don't operate, is too dangerous, blah, blah, then median survival is 7 years maximally. In our experience, now the median survival is around 15 to 16 years. So you will see the last paper we published with my colleague Luc Taliandier 2 weeks ago. About 1,000 cases. That means that we change radically the natural history of the disease by doing also resection and reoperation. And more you will reoperate, more you will reduce the volume, more you will avoid, at least postpone, significantly malignant transformation, and then more you will increase the median survival, whatever the molecular pattern. And that means also that the question will be, are you sure that you will preserve the quality of life? Because more or less now we reached 16 to 17 years in the last publications. So to preserve the quality of life, first of all, of course, I will not perform any biopsy because we know that it's a low-grade glioma, because the tumor is growing and because a low-grade glioma is never stable. Second, because the biopsy is dangerous, approximately 1 to 2% of risk in the classical literature, even in recent papers, while you will see that in my experience, when you operate, the risk to induce a severe permanent deficit is less than 1%. And third, because we will preserve the quality of life, because we will adapt to the connectome of this patient at that time. And the goal is not for me to remove a tumor, because the tumor does not exist. This is a diffuse tumoral disease, which is totally different. So you have to remove a part of the brain according to the understanding of the reorganization of the networks within an inter-system reorganization before and during surgery, but also after surgery, in order to prepare a second surgery 5 to 10 years later. And now I will submit this weekend, very likely, a paper about third surgery, and now 15 years of median survival while preserving the quality of life of the patient thanks to mechanisms of neuroplasticity, modification of the map occurring within the same patient over years. Indeed, this kind of tumor, as you know, are very frequently located within what we call eloquent areas according to localizationist view: Broca's area, Wernicke's area, central area, SMA, insula, and so on. In fact, you have to understand that localizationism does not exist. I made recently a keynote lecture in a meeting dedicated to cognitive neuroscience and connectome itself. And for this neuroscientist in the world today, it's just an evidence that we have to speak about networks, dynamics between networks and not just within networks, modification of the connectome and so on. So please burn the classical book related to Broca's area, Wernicke's area, because it does not exist, and everyone knows that, except maybe in your surgery today or in neurology also. So we have to change radically the history of the brain processing. And thanks to that, we have the chance today to have an access to functional imaging. And as I like to say, I am PhD in functional imaging. So I can tell you that functional imaging does not work at the individual level because there is a neurovascular decoupling, because this is just purely neurostatistics, biostatistics, and because the sensitivity and specificity is too low in order to select the good indications and to do the pre-planning in this patient at a time. And everyone knows that, especially the specialists in this field, because this is true also for DTI. You remember that DTI is just a movement of water molecule, not the function of the fibers. Everyone knows that. And nonetheless, we continue to use DTI, fMRI to put in your navigation despite the shift and to say, I can operate the brain according to functional boundaries. No, this is not the truth. If you do not believe me, please read the paper by specialists in this world. And in a recent publication in Nature Communication, about 20 research groups, they say that the tractograms contain many more invalid than valid bundles. It's not my imagination. Everyone knows that, except neurosurgeons. They don't want to admit that. Why? Because in the vast majority of cases, they don't know the functional anatomy, especially of the connectome, of the white matter tract, of the connectivity. So we have to, first of all, know the anatomy by doing dissection. And second, to use, if you want, DTI and fMRI as a didactic tool and research tool, of course. And third, to go to the OR by doing a wake mapping, because you will see that we have so many things to learn from the brain if you want really to preserve the quality of life of the patient. Of course, if you don't want to preserve the cognition and the emotion and the behavior, you can do that under general anesthesia. I did not have any hemiplegia for 15 years. So the problem is solved. So it's not enough in order to say, oh, I did not induce hemiplegia, my patients are well. If you were the patient, and I received so many patients from 5 continents, especially medical doctors, because when they have a problem, what they want is to continue to have the same personality and the same cognition. So to do that, I have the regret to tell you that you have to await the patient in all cases. If the patient is not already, of course, aphasic before surgery, but the goal is to arrive earlier, as I told you. And then you will do a cortical and subcortical mapping. And then you will see the full picture of the connector. And then you will have the cognitive monitoring in real time into the operating theater, thanks to speech therapists and neuropsychologists, neurologists, and neuroscientists, what you want, but a team dedicated to this kind of brain monitoring. And it's not complex, it's not expensive. We have just to be neuroscientists. It's our job, we are brain surgeons. And then we have to adapt the tasks into the OR according to the wishes of the patient. What is your quality of life according to the job, hobby, habits, and so on. And then you will adapt, and not just to avoid aphasia, hemiplegia, which is just an evidence. Of course, I can have a problem in 2 days, but it will be less than 0.05%. The risk zero does not exist. But in 99%, you control what you do. And the patient, if he's now able to live 15 to 20 years, wants to enjoy a perfect normal life, especially between 20 and 40. So we have also to take into account the environment. I mean, I have the habit to operate patients also coming from US. And in US, I know that they have problems to be rehabilitated because it's not reimbursed. Or if you induce an hemianoptia, then you cannot drive in France, but you can drive in North Africa, according to the law, and so on and so on. So many factors explaining why it's impossible to have a specific battery according to the lobar location of the tumor, because as I told you during my third slide, in fact, the deficit before surgery is not related to the lobar location of the tumor, except if you are still in a localizationist view of brain processing, but which is now totally wrong and admitted as an error or mistake by the neuroscientific community. So please, into the OR, see the limitation of the neuroplasticity, namely input, output, connectivity, projection fibers, association fibers. And then you will do a resection according to functional boundaries into the OR. That means that the robot, the intraoperative MRI, the DTI, the fMRI, and so on, cannot help you in essence because they don't know this kind of information, which could be provided only by the patient himself or herself in real time, thanks to the cognitive monitoring, which is much more important rather than the mapping by itself. So this is the reason why Naren can tell you after the talk, but I have the habit to operate with a fork and a knife into my operating theater. I don't need technology because technology today is a limitation of your thought. The concept cannot continue to evolve because the technology is pre-programmed by people still believing in localizationism. So in essence, this is wrong. For instance, typically today, you know that so many neurosurgeons are doing awake surgery, but in the left dominant hemisphere for language, blah, blah. So the right non-dominant hemisphere is still the dogma. I can tell you that in 2 days, I will not be able to operate the right frontotemporal insular tumor I have pre-planned without both hemispheres. I need my brain because I know that in the right non-dominant hemisphere, where I am right-handed, I have the control of movement. It's not just I am hemiplegic or not. I need bimanual coordination to operate like you, spatial cognition in order to navigate because I don't need your navigation because I know where I am in the brain. It's normal. I am a brain surgeon. Social cognition is exactly what I'm doing now through a screen, which is totally incompatible with the principle of mentalizing. Non-verbal semantics. You don't need to talk in order to understand the concept. The world around us is giving us so many signals with non-verbal semantics. Executive control, working memory, attentional processing, allowing you to make a decision online if you have a multitasking, and so on and so on. How do you want to be a human being without this kind of function? And you will tell me, but you cannot monitor this kind of function into the operating theater. Of course we can. We are doing that for more than 10 years by asking the patient to do many tasks simultaneously, by introducing tasks allowing to know if the patient can understand beyond language. mentalizing in order to know if the patient is able to perceive the emotion of people in front of him, and so on and so on. And finally, what was the result that we demonstrated already many years ago, that Broca's area does not exist, and it was published in Brain because even neurologists were obliged to accept the fact that there is no one area corresponding to one function. So we need to see the networks. That means that if you cut the fibers in the depth, don't think that you cut 3 more millimeters. Think that you disconnected 2/3 of the hemisphere, and then the patient will not recover. This is the limitation of neuroplasticity. And this is true for movement, language, but many other functions according to the definition of the quality of life by the patient himself. So a lawyer, judgment, mathematician, calculation, dancer, spatial cognition in the right so-called non-dominant hemisphere, writer, syntax, and so on. But in all cases, we are human beings and we are emotion, we are empathy, we are personality, we have behavior. So that means that we need to monitor these kind of functions, especially in patients who will live almost 2 decades, so 1 generation, in order to make plan like, is it possible for me to have a baby, to buy a house, what about my work, and so on and so on. Your questions for many people now in front of me through the screen. So how do you want to have this metacognition just with, I am not hemiplegic? So please monitor and map also. In the end of surgery, you don't need to stimulate every 2 millimeters within the brain, otherwise that means that you are lost. You have to stimulate in the end just in order to confirm your pre-planning in your mental imagery, namely if you are into the contact of the internal limb of the posterior capsule, of course, you will induce movement, but also somatosensory tingling, because you know that you have to know that the thalamocortical pathways are laterally located in comparison with the pyramidal pathways. Okay, everyone can understand that, of course, but this is not enough. If the patient told you, I am a golfer, I am a musician, I am a surgeon, I need a perfect bimanual coordination, then you need to identify the pathways, and especially the cortical areas, involved in the control of movement when the patient will be stimulated in the end, then it will block. And this is true at the level of the cortical level, but also at the level of the white matter tract, especially preservation of the frontostriatal tract and the frontal ascent tract, or not. According to the patient told you, I want to have a supratutorization. I know you will not cure me, but you can avoid malignant transformation. I don't need a perfect bimanual coordination. I am a mathematician. I need a perfect cognition, preserve the executive function, and then push a little bit more the resection posteriorly. I will adapt to each patient in agreement with a guy, remember, called Hippocrates, the informed consent of the patient. But if you say, don't worry, you will not be hemiplegic. Yes, but now I cannot run anymore. I can walk, but I cannot run. And I was very good in sport. So my life is not the same. And to do that, you have to preserve the feedback. If you operate within the parietal lobe, which is more or less never done in the literature, I operate the right parietal lobe, I can do that under general anesthesia, no problem. You sure they have no problem? Please do postoperative cognitive assessment. You will see that they have problem of protopathy. They have sometimes problem of awareness of their body shape. You say, we don't care. There was a tumor, you don't care. But what about your patient? So you have to explain before surgery, like visual pathway, in order to avoid any myelopia. Otherwise, if the patient cannot drive, in the vast majority of cases, they cannot work anymore. So they are not happy. You're happy, but they are not. What about the spatial awareness? You have to introduce the line bisection task into the OR, even in the so-called right non-dominant hemisphere, so under wake mapping, allowing the patient to drive without any problem. What about language? If you still believe on the fact that the so-called Broca's area, pars opercularis plus minus triangularis, and the Wernicke's area, superior temporal gyrus in the posterior part are connected, please don't operate the brain. The ventral premotor cortex, so the lateral part of the precentral gyrus, is connected to Wernicke's area. anatomically speaking. The so-called Broca's area is connected to the posterior part of the middle temporal gyrus and the posterior part of the inferior temporal gyrus. Everyone knows that in your science. So now, if you know that, if you stimulate the lateral part of the superior longitudinal fascicle, you will induce anatria, even by stimulating posteriorly at the level of the supramarginal gyrus and or the vernicus area. If you stimulate the arcuate fascicle, you will induce conduction aphasia with repetition disorders and phonological disorders. So you know where you are. And now you are going to say, I need intraoperative MRI just to check if there is a residue in the depth or not. But there is a residue. You will not cut the SLF or the arcuate. And you expected that just by looking at the first MRI before surgery, by telling, okay, I can remove 95% of in the flare in your case because there is already an invasion of the dorsal phonological pathway. I hope you can do that. This is the same thing regarding the inferior fronto-occipital fascicle plus the incinate fascicle, namely the ventral semantic pathway. If you stimulate, you will induce semantic paraphasia, whatever the lobar location of the tumor. If you stimulate at the level of a frontal tumor or at the end of insular tumor, when you are into the contact of the temporal stem in the depth, or the temporal tumor, and so on and so on. So now the question is it possible, so for a pathway, to compensate another pathway? And the answer is yes. You can cut the inferior longitudinal fascicle in its anterior part, and you will have a compensation thanks to the inferior fronto-occipital fascicle, explaining why it's possible to do an anterior temporal lobectomy, but knowing that the price to pay will be for the patient to have an increase of reaction time for lexical access, especially proper name, but also sometimes for just naming. So that means that the scores will be okay, but with an increase of reaction time. Is it acceptable for the patient? You have to tell him, her before surgery. And then we started to understand that it's not one area compensating another one, but one pathway compensated by another one. And according to that, we have to apply the same concepts regarding not only language, but other functions like nonverbal semantics, as I told you just before at the cortical level. I have the regret to tell you now that at the subcortical level, the right eye fourth is critical for the nonverbal semantics. And of course, you can show me 10,000 patients able to do that following surgery on beautiful pictures by telling my patients is well, I will not believe you without seeing the postoperative cognitive assessment and the quality of life of the patient with 10 to 15 to 20 years of follow-up, expressed subjectively by the patient himself. And this is exactly what we did. And this is the reason why some patients told me, I have the regret to tell you that I'm not happy because I changed my personality. And I understood that only 10 years ago. So this is the reason why we introduced this task into the operating theater, including the so-called right non-dominant hemisphere, which is so critical for social cognition and affect, by asking the patient to tell us the emotion expressed by the face and especially the ears during surgery and during stimulation, during mapping, during monitoring. So in fact, the mask we have in this period is a good rehabilitation for the social cognition because we try to compensate by looking finally at the ears of people in front of us. And what we understood, once again, I have the regret to tell you that the right inferior fronto-occipital fascicle is critical for that. In other words, when you do a beautiful insular resection, when you see great neurosurgeons in meetings with microscope and cavitron, CUSA, between the lenticular straight arteries, that means that they have no awareness about the fact that if they are so in the depth, they already cut the right eye fourth. And of course, maybe the patient will not be hemiplegic if they have no stroke, but I can tell you that the patient will not be the same following surgery. So recently, we modeled the so-called right non-dominant hemisphere, including all these functions, but each arrow corresponds to a specific pathway with the structure behind. I mean, remember what I said initially, you are young, you have to do dissection into the operating, into the lab of anatomy and into the operating theater, then you will do the simulation and you will also put the function, if I can say, to the structure. And when we put everything all together, the results. More than now 800 diffuse low-grade glioma, more than 2,000, in fact, awake surgery, because I did reoperation in more than 1/3 of my patients, speaking about low-grade glioma, within, of course, the so-called eloquent areas according to wrong localizationist view, including the Wernicke's area behind the labia vein, including Broca's area, including the corpus callosum, the central area, blah, blah. Results, mortality 0. I have good team. You need to have good anesthesiologist. It's not expensive in comparison with intraoperative MRI. Less than 1% of severe permanent deficit. The reserve does not exist. I was young also, and I pushed too much at the level of the anterior perforating substance when I was younger, because I did not understand at that time that the temporal stem, functionally speaking, even in the right hemisphere, namely the IFOF, could protect me if I did the good task at the good moment, namely the semantic association task and or the mentalizing task, explaining why. Now I stop, I will leave, you will see on the short movies in the end, approximately 1 to 2 cc in the depth, but all my patients are well. 30% of improvements. The vast majority of neurosurgeons cannot understand that, especially if it's an incidental discovery. Or the patient is well before. No. The cognitive assessment demonstrated that the patient was not so well because there is already a tumor. Now we will do not only a preservation of the connectivity, but also post-operative cognitive rehabilitation. In all cases, 100% of patients. 3 months later, despite an extensive lobectomy, they have a better score in 1/3 of patients, independently of the control of epilepsy, 80%. So that means that plasticity exists and we can push it. But we have to believe on that and to do mapping. You remember probably the meta-analysis we did with my friend and my master, Mitch Berger. If we can do that in San Francisco, and if we can do that in Montpellier, you can do that everywhere in the world. You have to do that everywhere in the world, I would say today, because we have the results with 20 years of follow-up. And we started to understand the mechanisms underlying plasticity. Recently, I published a paper for young people because it's just a review explaining the use of fMRI, of course, before and after surgery in order to understand how the brain is able to remap itself, to reorganize, thanks to post-operative cognitive rehabilitation, especially after SMS syndrome. And here you can see that it's a bilateral network and not just one area corresponding to one function. We demonstrated that when you have the classical SMS syndrome, then it's related, correlated at least, because we have not fully understood all mechanisms, a decline of the interhemispheric connectivity with the contralateral homologous area. And when the patient recovers, then you have a re-increase of this homotopic connectivity. It's very important to understand that, because that means that you can reoperate. Remember, the goal is now to reoperate not only a second time, but a third time it's done, but also a fourth time now I start 15 to 20 years later in patients who are still alive, but enjoy a normal life, thanks to mechanisms of neuroplasticity under control. And we started to anticipate how the brain will reshape following your surgery. Here, for instance, to remove 5 years later, and the knob of the hand in the patient able to play a guitar. Recently, we did exactly the same thing with language, not only movement, but before and after surgery. And it's much more complex. It's not just a reorganization within the language network, in fact, also constituted by different subnetworks involved in syntax, in phonology, in semantics, in prosody, as we have seen, but also reinforcement between systems and a recruitment of the attentional network in the so-called right non-dominant hemisphere in order to give the opportunity for the patient following a very extensive resection in the so-called left dominant hemisphere, allowing a complete recovery of language. And this is the reason why we can do a second surgery by removing the so-called vernicus area, which was still eloquent during the first surgery, thanks to the preservation of the, you have understood now, the posterior part of the ILF, the IFOF, the arcuate, and so on. Or to do that for Broca's area, if you cannot remove completely it during the first surgery, because it could be nonetheless a hub in this patient at that time, please come back 5 to 10 years later, and then you will be able to remove more according to this reorganization, not only within the system, but between systems. And this is the reason why we can also sometimes be very provocative by doing this bilateral frontal lobectomy. And I can tell you that this patient is enjoying normal life, driving, working, taking care of his family. And I cannot lie because he was published in Brain and Cognition. And I can tell you that referee are asking for 3 hours of cognitive assessment after surgery. You will tell me so many tasks. So you cannot remove enough tumor. Wrong. We change radically median survival. I have now 25% of my patients still alive with more than 20 years of follow-up. And the median survival will be, in a few months now, 17 years. Remember, initially it was between 6 to 7. Why? Because I did more and more supratotal, because everyone knows, I hope, that what you can see on the preoperative MRI is not the disease. So you have to remove more in order not to cure the patient, but to avoid malignant transformation, what we demonstrated with now 11 plus 4, 15 years of follow-up, no death in this subgroup. So please take a margin. And you will tell me, yes, but where to stop? According to the functional boundaries. But what functional boundaries? Please do semantic association task, mentalizing task, multitask, and so on and so on. And you will identify where you have to stop. And you will change radically in the natural history of the disease, but you will tell me in the vast majority of cases, it's not possible because the patient have already a so big tumor. Please do surgery earlier, even in incidental low-grade glioma. We recently reported many papers about that. I mean, more than 100 patients with incidental discovery of low-grade glioma, so smaller tumor in a sense, so more supratotal resection, 30% plus 30% of complete resection, no partial resection, no epilepsy, recovery in all cases, and nonetheless already 30% of malignant foci. You'll tell me what means the real quality of life. It's very clear for me. First of all, the subjectivity of the patient in addition to the cognitive scores, of course, but second, the return to work. We recently published that 97% of our patients resumed their employment. So it's very easy to say that to the patient before surgery. And this is the reason why more and more I started to operate patients with intentional discovery of possible low-grade glioma by doing a screening in the general population between 20 to 40, which was accepted by the National Academy of Medicine in France. You can do that only if you know the limitation of neuroplasticity. So we published an atlas in the DTI template in Brain 4 years ago for younger people in order to avoid for you to waste time by telling you, you can predict before surgery if the patient will recover or not according to the extent of resection in different places and especially in the depth, the limitation of neuroplasticity at the level of the connectivity. And this is the reason why sometimes you know that you will not be able to remove completely the tumor. And in these cases, please do preoperative neoadjuvant chemotherapy. You will see a shrinkage and you will operate knowing that the risk, if there is a diffusion within this minimal common brain, I mean, whatever the patient, if you cut the arcuate fascicle or the I4 or a fortiori both, your patient will never recover. And this is what I would like also to explain not only to neurosurgeons, but to radiotherapists. I published a paper about that this year by telling, okay, you increased your technology, you can focus your radiotherapy, but if you do radiotherapy after my surgery performed according to functional boundaries, in essence, you will irradiate the minimal common brain. And I can tell you, because you demonstrated by yourself, if you're honest as a radiotherapist, that you will induce a decline of cognitive function because this is the limitation of neuroplasticity. And we are speaking about patients who should live now 15 to 20 years. So this is the reason why, please, when you are in front faced to a patient with low-grade glioma, and you know that, and once again, thanks to 2 MRIs with 1 month of delay just in between, please do surgery according to functional boundaries. Please do postoperative cognitive rehabilitation. Please push the patient to return to normal life, including to work, because this is the best rehabilitation. Please come back thanks to mechanisms of neuroplasticity to reduce the volume while the patient is still with a low-grade glioma enjoying normal life. Please do that again and again. If you cannot, please use chemotherapy regardless the molecular pattern. Guys who are telling us what we have to do are not neuroscientists. They don't know the brain processing. They are just treating a tumor. They are not treating human beings, and are still waiting for their median survival compared to our median survival, because we published recently, 2 weeks ago, in Frontiers of Oncology, thanks to my colleague in Nancy, Luc Taillandier, that not only the median survival is over 16 years, but the median time with a normal life, active life, is over 20 years. And this is probably the most important, because what they want is to continue to live longer. And this is not enough, of course. And this is the reason why we will continue to reoperate them. But to keep the radiotherapy in case of, typically this year in Neurology, we published a paper about low-grade glioma with foci of malignant transformation. And what we do, if the growth rate is slow before surgery, and if you remove the tumor, according to the postoperative MRI, of course, the patients are not cured. Even if there is one focus of malignant transformation in the middle, please don't perform chemoradiotherapy. And you can see that we are not criminal, because the 5-year survival rate is over 95%. And we keep the possibility to do radiotherapy for long-term follow-up, because my patients are living longer. We have to anticipate more than 10 years in advance. Typically here, announcement, you see, it's not my imagination. I did just complete resection in 22, and I said, no chemoradiotherapy. If you agree, of course, this is a proposal to the patient. You have a recommendation, guidelines, protocols, blah, blah, and you have you prefer personalized medicine. Yes, I did a second surgery 15 years after the first one, 3 years ago. And at that time, the lab told me this is a low-grade glioma, while it was a high-grade glioma during the first surgery. Of course, I removed the focus of high-grade. No chemoradiotherapy. You will tell me just one case. No. We published a series about that in Neurology this year. But it's possible, once again, only if you know the functional anatomy, or even more, if you propose new model of cognition to neuroscientists, because we are neuroscientists. So as a neurosurgeon, you should publish in Nature. You should also elaborate new atlas. It's exactly what we did for younger people this year in Neuroimage, the sole atlas of the literature regarding the critical cortical hubs and functional subcortical white matter pathways regarding 16 functional domains, language, semantics, mentalizing, blah, blah, you have understood, about almost 2,000 stimulation sites. And of course, it's free access in order to help you to build this mental imagery. And when you will start to have this in your brain, you will see that your navigation, intraoperative MRI, is just for resident, a didactic tool, but you have to go beyond. And this is the reason why we published, so this year also, in Physiological Reviews, which is the Bible of physiology, human physiology, so beyond the glioma surgery, the connectivity and interactions between networks and between hemispheres in order to better predict this dynamic reorganization within across networks when you will do a surgery, but also in order to give the opportunity for a human being to have an adapted behavior according to the environment online. That means that you can use different networks instantaneously because there is fire, for instance, or because you have a rupture of an aneurysm into the operating theater. And then you change your network. Please understand that the brain is unstable. This is a perpetual modification of different equilibrium states in physiology. So a fortiori when you are into the operating theater, and especially when you stimulate, do not think that one area, because you stimulated and patient stopped to speak, correspond to the area of speech. This is just an entry door, not only to a network, but to interactions between networks. For instance, if you stimulate some areas, especially hubs like the dorsolateral prefrontal cortex, which is the junction between, structurally speaking, the SLF and the IFOF, you will see that the patient is still able to move, still able to speak, but not able to do both simultaneously. But normally, as a human being, we have to enjoy normal life to be able to do multitasking every day. So the take-home message is that talk to the brain into the ear, forget the tumor, because there is no tumor. This is a diffuse disease. Intraoperative cortical subcortical mapping and cognitive monitoring a la carte, it will be my next paper in neurosurgery, are more sensitive and reliable than neuroimaging today, which is very exciting before and after surgery because non-invasive, but not so reliable. Technical aspects are not an issue. I can do that with a fork and a knife. So I would like to see your median survival and technology in the young generation. I can start to see that more and more young neurosurgeons don't know where they are into the brain because they need technology because they are addicted, which is very dangerous. I don't know if I have 5 minutes to show movies, or otherwise I will show the last slide.
No, absolutely, Professor. You have got time as you want. Thank you.
So just an illustrative case how I do it in practice. A 32-year-old man, medical doctor. Once again, they have a bias in recruitment. So medical doctor who like to preserve language, cognition, and movement, of course, but also personality, behavior, and so on. Incidental discovery, normal clinical examination, and you see a typical left paralimbic, so-called paralimbic tumor. I will not insist about that, but now to show you what I did as a cortical mapping, because I have the habit to put all my patients in lateral position. And I do a big bone flap. I continue also to need to benefit from a positive mapping, and a big bone flap is really a nightmare for me to open and to close, but never for a patient. About more than 1,000 patients, never they complain about the size of the scar, especially because I do not shave, so you see nothing, especially for a young girl. So this is not an issue, except for you. I hate to close, probably like you. So I have to suffer for giving them the opportunity to enjoy a normal life. The Sylvian Fisher, of course, the ventral premotor cortex, the lateral part of the precentral gyrus, the Rolandic operculum, you can call as you want. And you have seen that I put nonetheless 5 at the level of the dorsolateral prefrontal cortex because semantic paraphasia. Here it was speech arrest, here semantic paraphasia. But at the level of the so-called Broca's area, nothing as usual, and especially because in this case there was a tumor. So that means that the goal now for me is to remove very quickly the left inferior frontal gyrus in this case, and you will see that except the cortical surface after a true negative mapping, never I will use again the bipolar coagulation. My goal is to avoid to coagulate. And I can succeed even in high-grade glioma because I will take a margin around the enhancement, so I will remove more or less monoblock. And you see that my goal is to avoid to be into the contact of the vessels, and I am protected by the pia mater. That means that I have no spasm, and definitely I had no stroke since now 15 years, because I really learned to use this methodology, which is not very complex to learn, and which is coming from the epilepsy surgery. And you see that you have no bleeding. I mean, in the end, you started to see the insula. So that means that I was at the level of the surface of the insula in approximately 10 to 15 minutes. It's very quick. Of course, in the meantime, the patient is still awake. You cannot see him on these movies, but he's doing movement plus language with semantic association task plus naming and so on, every 4 seconds without any rest in order to have sustained attention, which is monitored and so on. And don't worry, my colleagues will benefit into the lab from a very big amount of tumor in order to do also the neuropathological examination, also the molecular examination, also the research, because I have a lab of INSERM of research dedicated to the study of glioma themselves, and not only neuroplasticity, but this is research. And now what I will do is to remove the insula. You can see the surface of the insula with the vessels here. And I will put my retractor just to retract the superior insular sulcus in order to remove the insula from inside. So no bleeding. I am never into the contact of the sylvian arteries or branches, never. And then I will do that thanks to the retractor without microscope. You can put microscope if you want, but for me, it's better to have no microscope. Why? Because you should see the danger in your mental imagery now. The danger is the inferior fronto-occipital fascicle running in the temporal stem and running to the, of course, frontopolar, but also dorsolateral prefrontal cortex. And now I am in the insula. And now I have to identify where will be the IFOF, which will be the limitation functional boundary in the depth, even if I know that I will not remove the anterior perforating substance because I'm not really a surgeon. I am a neuroscientist able to operate the brain, which is not the same thing. And now, of course, I will stimulate, but you see that I do not stimulate very regularly because I don't need it, because the patient is still able to move, to speak, to understand, and so on. I will do the same thing at the level of the temporal lobe with the use again of the bipolar. And now I will stimulate, and you can believe me or not, but the speech therapist told me, semantic paraphasia. Okay, I know where I am. I don't need intraoperative MRI. I will stop, and you have seen that I have the hemostasis. So very quickly, the postoperative MRI now. I removed the so-called Broca's area. Of course, it does not exist. I removed the insular lobe until the contact of the lateral part of the lentiform nucleus. I was into the contact of the IFOF, I'm sorry. And of course, I left voluntarily a small but objective amount at the level of the anterior perforating substance because I'm not able to deal with perforating arteries with 99% of reliability. And what would like this colleague, which now is a senior because it was many years ago, was to enjoy a perfect normal life, and he never had any chemoradiotherapy from now. So the conclusion is we have definitely developed a preemptive and individualized functional surgical and medical neuro-oncology. You have now the choice to use all technology in order to treat a tumor, to remove a tumor according to the imaging, or to take care of a human being. Thank you very much.
Thank you very much, Professor Dufour. I have been attending your lectures since around 2012, and every year I'm just absolutely fascinated and learned, and my appreciation has matured. It's for the young neurosurgeons here, I will really advise for you to review this video again and again. It's on the YouTube. What I am trying to say that I have seen surgery from every surgeon and great surgeons, But when we are usually neurosurgeons, we are surgical neurologist, but with Professor Dufu, you will see yourself as a surgical neuroscientist. You are a surgeon with neuroscience. I mean, going through the things just jotted from, looking at the volume of the tumor rather than AP diameter and height, or, the thing is that it's a three-dimensional structure, as Prof. Dufu mentioned long ago. And even a small increase in a diameter in one dimension in terms of volume increases largely. Once again, many people still just keep measuring the AP diameter or lateral diameter. And I think that's why you will see Professor Dufu in terms of his passion, how we all know what we should do, but we do something differently. And the supramarginal resection, once again, as he said, the tumor is not what you see, it's more than that. And the connectomes in neuroscience, it's now well established, the connectomes, and understanding the neuroscience in terms of operating is absolutely important. The thing is that we are operating. The question once a surgeon asked me, he said, Aaron, are you doing an operation for you, or are you doing it for the patient? And it's the same thing. Are you doing for the tumor, or are you doing for the brain? And so Professor Dufu's the thought process, it's a very high level thought process. But as he said, I have been to his theater, and you have to see the speech therapist, the psychologist, it's a very thorough examination while he's doing, and the technology, as he said, could be done anywhere. So I think everything that Prof mentioned for every 5 minutes is deep philosophical aspect, and I thank Prof for it. But I'm going to take the questions because I think this is a very important lecture for many people. First of all, can I get Francisco Signorelli? Do you want to ask your question, Francisco?
Oh, hi. Good morning, everybody. Hi, Hugo. Salut, Hugo. Just I was thinking, should we really abandon the preoperative mapping, or there is a room for improving it, for adopting, for example, correct protocols, correct technique, or even the significability threshold, for example, for the fMRI or the MEG? What do you think, Hugo?
I think we have not to abandon. As you know, you have probably the more extensive data bank of fMRI, resting state, DTI, not MEG, to be honest, because we have not in Montpellier. Before and after surgery, I mean, we have now accumulated approximately 500 patients. So do not think for young people that we do not use that. I just say, do not rely on, in order to pre-plan your surgery and to say, I will really, like if I was blind, apply the pre-planning based only on the fMRI and DTI or MEG. That means that first of all, you have to rely on your knowledge of the functional anatomy based on the models you have proposed. And of course, fMRI will be a validation, but the most extensive validation will be, of course, intraoperative cognitive monitoring. As you know, now we are accumulated more and more correlating the results of pre and post-operative fMRI with intraoperative mapping too. And this is the reason why we can show the critical areas by desynchronizing during surgery and stimulation, while fMRI is showing the full network, including the contralateral hemisphere, the thalamus, the cerebellum, and so on. So that means that we need to use both. It's not incompatible. But the problem is that today, the vast majority of neurosurgeons would like just to believe on the fact that technology, and especially neuroimaging, is the truth, why this is not.
Thank you.
Dr. Harshad Parak, do you want to ask your question, please?
Yes, Professor. When you are doing a cortical mapping and you are operating, and when you during the mapping, you realize that this is a cortical area, which is a very important to may lead to the paralysis. Do you stop there, or you still go further?
Of course I stop. the goal is to stop according to the functional boundaries. I don't know how to explain that.
Yeah.
The flare, imagine, I don't care. I do not operate a glioma. The mass of the tumor does not exist. It's a diffuse disease. So please, of course, stop according to the functional boundaries, even if maybe you will have the chance to come back many years later, but at that time into the OR, you don't know if you cut more, if the patient would be able to recover or not. And in my philosophy, first of all, do not be harmful for the patient.
Do you advise any adjuvant radiotherapy or chemotherapy if there is a residual tumor?
But as I told you, the radiotherapy will burn the connectivity. So of course, one day we will use the radiotherapy, but because my patients are living almost 20 years, I will not use it too early, while chemotherapy is able to diffuse within the connectivity without damaging the brain. We know that because we performed cognitive assessment more than 10 years following temozolomide, especially because the tolerance is better. So of course, I will start by temozolomide if I cannot operate or reoperate due to a too migratory pattern into this minimal common brain, the connectivity, which is the limitation of neuroplasticity to give the opportunity for the patient to enjoy normal life. And finally, we will irradiate. I have the habit to irradiate more and more now my patients, but because we have more than 10 to 15 years of follow-up, and at that time, we are also very happy to be still able to irradiate, because if it was done 10 years before, the vast majority of radiotherapists will tell you, no, I don't want to irradiate. And so what? What we are doing now.
What about the corpus callosal tumors, which are going across the midline to the opposite side? What do you advise?
Yes, as I show you, it's not really an issue to remove the corpus callosum. Here, for instance, this patient was a pianist and able to play the work from Rachmaninoff 3 months following surgery in concert. And the impresario told me that she's playing better in comparison with before surgery. I think that, in fact, I disinhibited her emotional processing, but you can see that we are really speaking about not callosotomy, but callosectomy, which is not an issue in my experience. I did that in approximately 300 patients.
Thank you. Thank you, Doctor. Thank you, Dr. Bragg. Can I bring Dr. Gulwar? Dr. Gulwar, do you want to introduce yourself and ask a question? Thanks. While Dr. Gulwar is coming, can I get Professor Atul Goel? Prof. Goel, do you want to ask a question, sir?
Yeah.
Hello.
Dr. Dufault, nice to hear you again. And that was, of course, a fantastic, wonderful teaching session. I want to ask you one very basic question. In the title of your book says diffuse low-grade glioma. Do you think they are diffuse? Do you think they are invasive? Do you think they are, they have some kind of confinement? Or do you think they invade into the tracts? I want you to a little bit answer this question. Do you think, you see, all the gliomas, particularly in the more important areas, you say everything is important, all right, but they are in vicinity of important tracts. Are they invasive? Are they diffuse? Are they well-defined? Are they radically, totally removable? What is your concept on this?
It's not my concept. It has been accepted by the new WHO classification of the World Health Organization, now speaking for 3 years about diffuse gliomas, because of course it has been demonstrated for many decades that you have tumoral cells far well beyond what we can see on the preoperative FLAIR MRI. And now it has been clearly demonstrated, since we benefit, unfortunately, if I can say, of course, from IDH. And you know that the vast majority of lower grade glioma, so 2-3, are in 80% cases IDH1 positive. And then it's very easy to know if you have tumoral cells by doing biopsy beyond what we removed according to the FLAIR MRI. And we published many papers, and not only by ourselves, but also in Switzerland, in Norway, in Norway, demonstrating that you have tumoral cells approximately 1 to 2 centimeters beyond the flare imagine. So there is no tumor mass. It's not my imagination, because after 20 years, I cured no patients. If you have a longer follow-up, in all cases, despite the beautiful imaging, even if I did supratotalization, you will unfortunately see finally a flare rim around the cavity occurring again 10, 15, 20 years after.
So do you agree that they are invasive? Do you say they are invasive?
But it's not that I agree. It has been demonstrated for 50 years.
No, I agree it is demonstrated. You say yes or you say no. They are invasive.
Yes.
You say yes or you say no. Yes?
Yes.
Thanks. Thank you.
People who telling that we have to stop according to the field, the tumor mass, are just neurosurgeons. They understood nothing about neuro-oncology. Yes, I hope very clear now.
Thank you. And I've got thank you. I've got another question. The one I've asked for Dr. Gulwar is that does low-grade gliomas in different parts of the brain, do they grow at different rates? Are we able to say that, Dr. Dufault, Professor Dufault?
We made some correlations between the location, especially by telling that the insular gliomas, lower grade gliomas have a tendency to have a different molecular pattern, so growing maybe a little bit faster. But as I told you, finally, everything was not clear at the individual level. So that means, in other words, that it's not the location which will make the prognosis. But we're sure about one thing: there are preferential locations like the insula, the SMA, the anterior part of the brain, because in my experience, for instance, I have operated on only 10 patients with an occipital low-grade glioma. And the question is why? And the answer is probably interactions between networks, neuronal networks, and glial networks. And maybe we will know more about that by doing earlier and earlier MRI, especially in the concept of a screening, because we will discover very small tumor, and then we will have an idea of their origin. Is really our hope.
Thank you. I've got another question from Professor Christine Jung from Heidelberg. Dr. Jung, do you want to please put your question to Professor Dufault? Thank you.
Yeah, good morning, Hugues, and thank you very much for this very impressive talk and your work as always. Good morning. I've got two questions. First question is, since this is also an educative talk, you have a very sophisticated setup, and this is work of your lifetime, actually, which you presented. But if you start doing awake surgery, what would you recommend as I would say, minimal set of tasks you should perform?
First, to know the functional anatomy. I'm sorry about that. So I will really push you to do a PhD for 2 to 3 years in neuroscience. And then you will come back, and then you will start to understand where you are into the brain. And there is no price about that. Second, a good team, good anesthesiologist able to do asleep, awake, asleep, awake, awake, awake. What you want, finally, we don't care. The practical issues is not really a problem for me because I tried so many things. In fact, you need to have good guys around you. And of course, very good neuropsychologist, if possible, also involved in neuroscience. So neuropsychologist, speech therapist, neurologist, and so on. Third, to avoid to be addict of technology, as I told you, because if you start to be dependent on fMRI, DTI, your navigation, robot, intraoperative MRI, a microscope, what you want, then you will finally have problems in order to remove them. And I can really tell you that the best way to have the full picture is to remove any microscope, DTI, fMRI, but to have a direct communication to the brain itself. So to avoid to have also fourth dogmas in your mental imagery, I mean, definitely localizationism should be burnt. And finally, to be objective, to have systematically cognitive assessment before and after, and not just to say, oh, I did the job. No, no, no. You have to continue to follow your patient until the death. Their death, but maybe my death also, because I have 23 years of follow-up regarding the first patient nurse still alive and enjoying a perfect normal life. So I don't know where we will go. And the goal is really to try to push the limits, and then since the beginning to do a prospective collection of data, multimodally speaking. And in this setting, of course, if you can benefit from pre-post operative resting state fMRI, DTI, MEG, in addition to cognitive assessment, and to have a lab of research dedicated to the connectome and or to the glioma invasiveness, because definitely this is a migratory tumor, then I think that you can do that more or less with nothing, because there was nothing when I arrived here in Montpellier in this field.
Yeah, but it's a concept of doing surgery, actually. It's like Naren said, it's also philosophy. Yeah.
Of course.
But may I ask?
The question will be, do you want to preserve, first of all, the quality of life of the patient, or to remove whatever the price, the tumor visible on the pre and post-operative MRI? This is philosophy. But you have just to discuss and to adapt to each patient. Philosophy, please come back to Hippocrates.
You're perfectly right, yes. Thank you very much. May I just ask one more specialized question, maybe, how to proceed in SMA gliomas? What's your advice there?
First of all, to wake all patients. I totally disagree with Mitch Berger. He knows that. We had recently this kind of discussion, because the goal is not only to see the posterior boundary, but the lateral boundaries, because at this level, you have the anterior part of the SLF2, very involved in executive functions. And as I said, the cortical termination, posterior cortical termination of the dorsolateral prefrontal cortex. So the junction between the dorsal and ventral semantic pathway. So the goal is really laterally and in the depth. But posteriorly speaking, it will be in agreement with my previous answer. It will depend on the needs of the patient. If the patient is telling you, I am a surgeon, I am a pianist, I need to preserve a perfect bimanual coordination, I will also stop according to the frontostriatal tract, namely the arrest of movement, bimanual movement into the OR, and so on and so on. And then I will leave a small but objective tissue, amount of tissue in front of the corticospinal pathways. If the patient is telling me, I can have an SMA syndrome, I know I will recover, but not completely in order to play Rachmaninoff, but it's not an issue for me, then I will push according to the positive and not negative answer. So definitely my protocol is that I have no protocol.
That's a good answer. Thank you very much.
Welcome.
Before I ask Professor Grottenhuis to reflect on the lecture, just to re-emphasize, as I think almost all, I like to think that neurosurgeons went into neurosurgery because we wanted to operate on the brain, but then as we seduced by the imaging, etc., and life making easy, we then become surgeons of the tumor rather than surgeons of the brain. We spend a lot of time learning our techniques, we spend a lot of time learning anatomy, but the amount of neuroscience that we learn, we are not operating on a tumor in a liver, we are operating on a tumor in a brain. And I think the emphasis of the next 10, 20 years will be with more information about neurosciences, is for a neurosurgeon to become a surgical neuroscientist. Professor Grottenhuis, could I please ask you to give your thoughts on Professor Dufour's lecture as well as your reflection? Thank you.
Yeah, thank you, Naren. And just to add what you were saying, what I have learned already many years from the lectures of Professor Dufault, and he has taught during the training courses of the ENS, and so many young residents already know this work. It is not that we are not operating on the tumor, that we are not operating on the brain, we are operating on patients. I think that's the essence of what Dr. Dufault was saying. It is so individual, but to be able to do that, to operate on the patient and the wishes of the patient with a tumorous disease of the brain, means that you have to understand the neuroscience behind the brain. And that's not an easy task. Professor Dufault just mentioned that you should have a PhD for 2-3 years in neuroscience. Not many of my residents will do that. But I think if you devote yourself to this specialty, as Professor Dufault is doing, then this is a necessity to understand that. That's the same in vascular. You need to understand different things in pediatrics and functional neurosurgery, DBS. It is not just by placing a stimulator. It is knowing what you are doing and changing in the connectivity of the brain. So what I love always in these talks is the deep thinking process about the brain, and also taking a step back from technology. We often learn that neurosurgery is a very technological specialty. Everyone is looking, when will we have robots, and well, even improving the navigation, and we have better fMRIs, and so we are fully technology. Well, Professor Dufault called it addicted, and I think that's completely right. That many of my residents can't even operate on a anterior clinoid meningioma without navigation. So they have simply more or less no idea where they are inside, unless the navigation image shows it. And so that we made a wrong step, because the basis is still not anatomy, it is function of the brain. And therefore it's an amazing keynote lecture, certainly the highlight of today. And I only can thank you, congratulate you, and hope to, and look forward to your next lecture.
Thank you, Professor Grottenius. Just one final word. I think, Professor Dufault is very passionate about his patients, his tumor, but you have to see, when we had our courses, the amount of passion that he has for young doctors and, most senior doctors, we do sit with our juniors, but most of them will sit with all the other seniors. And I have all the courses that he had come, he's with the residents, and they are all around him like a bee, and trying to get residents and him out of the night discussing about that and this. And I have called taxis, and Professor has just ignored the taxis and spent time talking to the residents. So I think it's a fully passionate man. Thank you very much. Thank you, sir.
I would like to thank you, and just to conclude by telling, in fact, low-grade glioma in this kind of talk is a paradigm. I mean, you can apply this knowledge of the brain, functional anatomy and its dynamics, to high grade, to surgical approach, to the ventricle, to a cavernoma in the depth, to epilepsy surgery, to DBS, when we spoke about the networks involved in the control of movement, is also functional neurosurgery. And my dream would have been, but now I'm afraid I am a little bit too old, to restore the brain. And for younger people, in fact, I'm telling you have to invent a new specialty now in neurosurgery, the restorative brain surgery, based on stimulation, of course, but also BCI, what do you want? It's just a start now. And if you are not a neuroscientist, you will miss the action in the field of brain surgery itself. And this is the reason why, I don't know if it's a good place to say that, but because André is there, I think that for the next future, we have probably, since the beginning, more or less, to separate two fields. Some surgeons who would like really to be involved in brain surgery in general, oncology, epilepsy, because finally to do an anterior temporal lobectomy is not so complex when you are a brain surgeon in your oncology. And people who finally will not make this involvement, this effort in order to better understand neurosynaptic dynamic processing. And I think that if we accepted, but I don't know, it's just, of course, a proposal for the next future to have this dichotomy, then we will increase the chance to have brain surgeons, I would say, a little bit more creative. And I think it's absolutely now mandatory to continue to write new history in the field of neural system surgery.
Thank you. Thank you very much, Professor Du. I look forward to having you, your thoughts in the next meeting. Thank you, sir. Thank you very much. So we have our next lecture is from Professor Atul Goel. Professor Goel, sorry that we are running slightly over the time, but I think it was well worth it. Professor Goel is another paradigm shifter, and I honestly, don't know any other neurosurgeon in as with Professor Dufu has shifted paradigms so often in modern neurosurgery, in operative neurosurgery and thinking. And he has given many lectures in our talks, in our series on craniocervical spine. But I'm bringing him back to the fine cavernous sinus surgery here, which is extremely complex. But it's, I'm sure Professor Goel will illuminate us in his usual insightful way. Professor Goel, if you could please share your presentation. I will just,
Okay, Naren, you can see my slide?
Yes, sir.
Okay, my dear friends, I will now take you to my world and my world of cavernous sinus. Cavernous sinus surgery is indeed absolutely complex. It is a science, it is a technique, it is anatomy, it is performance, it is dealing with blood and bleeding situation. You have to be master of bleeding. When it bleeds, you should be absolutely able to handle that situation. You should not be running away from the field. More than anything else, you have to be absolutely understanding the concepts and philosophical about the entire story. So I want to take you through my world of cavernous sinus. Over the last 35, 40 years, I have been involved in this field. And anatomy is the key, we all know. And there is, unless we go in the lab, unless we work on cadavers, unless we dissect repeatedly and repeatedly and repeatedly, there is no way we can understand this complex area. And also when there is a tumor, the anatomy is different. So you have to know how the nerves will be displaced, how the carotid artery will be displaced, how the fifth nerve will be displaced, how much to remove, what to remove, when to stop. More important, as Dr. Dufour has said, that patient matters. If the patient worsens after your surgery, you have done a wrong operation. So essentially, it is a complex issue. But the majority of tumors in this location are benign. Like low-grade gliomas, the surgery is evolving. Cavernous sinus surgery has already evolved. And when I started, I must say that it was almost non-existent. 35 years ago, before the era of MRI, before the era of CT scan, these tumors were not only not operated, they were not diagnosed. MRI introduced a new shift in the understanding of these tumors. So in the year 1996, I wrote this book on complex brain tumors. And I must say that this was one of my very popular books, which was reprinted thrice. And you can see the cover page of this book where the entire Peter's bone has been removed, carotid is displaced, trigeminal nerve has been displaced, fifth nerve has been displaced, and these kind of complex operations. I must tell you that during those years, 25, 30, 35 years ago, these things were not very commonly performed, and they were enigma. They were like, kind stories, but they have actually evolved to a great extent. Many of my initial works, and some of you and many of you, because I have given these kind of lectures on several occasions, know this work of mine, philosophical basis of cavernous sinus. What is cavernous sinus? Does it have any role in the human body? What is the function in relationship to the eye movements? What is the relationship in function in relationship to vision? In relationship to temperature control, in relationship to managing what pituitary gland is doing, in relationship to what the temperature of brain should be, and all those kind of speculations I have discussed in some of these papers, and I wish you can read, because these are not in the literature and these are speculations, all right, but beautiful speculations. Eyeball is a very complex hydrodynamic system, aqueous humor, vitreous humor, the lens, which is also fluid. Behind the eyeball, there is huge number of veins and retrobulbar fat. You press your eye like this, how there will be temporary diplopia and how it recovers, we all know. But the role of cavernous sinus in this situation is absolutely critical. I must say that if you press your eyeball like this, and if it was not for cavernous sinus, you would have ruptured your retinal artery, which is devoid of muscular layer. Cavernous sinus is a unique buffer system of the brain, and it manages the hydrodynamic system of the eyeball. So it has a great role in eye movements. You see, we know sixth nerve has a role. We know third nerve has a role. We know fourth nerve has a role, but we do not know that the cavernous sinus has a role. We know that the optic nerve has a role in the vision. We don't know that cavernous sinus has a role in vision, and you will like to read some of this work. Why the eye is located lateral side of the head in a deer, and why it is located in front of the head in a lion. Why the cavernous sinus is bigger in a deer and why it is much smaller in a lion. My speculation is because when the deer runs, it has to see in front, it has to see behind. The eyeball moves in a very rapid movement. Because of the it has to see how far the lion is and how far the next ditch is and bushes are, when it has to take a jump and things like that. So the eye movements are very quick. On the other hand, this lion has to just handle the deer's tail and nothing else, and get hold of, he does not bother about what is happening in the sides and what is coming from behind. He's not bothered. So the eye movements are limited. So we speculated that the movements of eye determine the size of the cavernous sinus. The fish's cavernous sinus is much bigger in relative terms because the eye is not only there for balance and for vision, but also for balance and for swimming. You puncture the eye of a fish, the fish cannot swim, and the fish instantly dies. So the cavernous sinus, as Professor Hakuba had said, is much bigger in a fish. There are fat lobules even in human beings, but much bigger in case of a fish. So what is in the eye and what is behind the eye is very important. We say brain is important, but I say cavernous sinus is equally important, and there is no question about the beauty of the eye. Cavernous sinus and its relationship to pituitary gland. Pituitary gland is neither intracranial nor extracranial. Its relationship with cavernous sinus, with paranasal sinuses, is not just arbitrary. It has huge functional implications. The relationship with the air conditioner of the body, that is mucosal sinuses. When the air goes, the temperature here may be hot or cold, but as soon as it traverses near the trachea, the temperature becomes normal. As soon as you drink hot or cold, as the mucosa manages the temperature, it goes in the esophagus in a normal temperature. So this air conditioner of the body influences the cavernous sinus, and it relays information to pituitary gland. And it gets information from the body from the carotid, gives information to the master gland. So these are at speculation level. This is just small introduction to these speculation, but I wish you will be able to read many of these things in my papers. Alam al-Dimag, you see, this is from Arabic literature. Arabic literature has a huge number of sentences which have neurosurgical implications. And this is for the first time I said that Alum al-Dimag means the meninges are mother of brain. And Professor El-Mefti was very happy when I said about this sentence. And it is indeed the mother of brain, but it is terribly important for neurosurgeons to understand the implications of dura, implications and messages that dura gives, and the relationship of dura to the tumor, how these things are interrelated. And I want to discuss this issue with you. Dura is indeed durable, and dura is a mother. Dura mater, mater means mother. It encloses the cavity of the skull, and it protects the brain. It protects to the extent that it does not allow any bacteria, any virus, any corona, anything from the nose, which is a zoo of animals in the paranasal sinus, esophagus, ear. The animals inhabit in this area like absolutely nobody can imagine. But this brain, this spiritual compartment is protected by the dura, and it does not allow anything. Similarly, my concept is, over the period, that dura even protects the tumors. And this understanding is absolutely critical if you are going to operate on the cavernous sinus. So for several years, 22 years ago, 25 years ago, several of these papers, maybe they have become redundant now, but the concepts in my imagination, can never go redundant in this situation. And some of these are very highly cited articles. Impact of arterial displacement. You see, when I talk of arterial displacement, these arteries can be seen only on MRI. These were not seen on a CT scan. Now we know MRI, we know arteries, but 25, 30, 35 years ago, this information was not there. So cavernous sinus surgery was born and brought up by MRI, and now it is completely there and thriving to the extent that everybody wants to do it. But I must say, we can want to do it, that is different, but whether we can do it good, we can do it beautiful, that is the question. Even now, it is not easy, but the concepts are there and they are well established. So you see the artery, how it is displaced. In 1998, I wrote this paper, Impact of Arterial Displacement, Arteries Encased and Squeezed, Arteries Encased and Not Squeezed, Arteries Displaced. This means different tumor, this means different tumor, this means hard tumor, soft tumor, meningioma. So the concept came that we are not operating on cavernous sinus tumors, we are operating on meningioma involving cavernous sinus, pituitary tumor involving. So the pathology could be diagnosed on the basis of the location, on the basis of clinical symptoms, on the basis of arterial relationships. So I have been involved I work in a public institution in Mumbai, which is a charitable free hospital for government of India. It is a teaching institution, and I have been involved in this kind of complex cases. In this patient, I operated in 1993, and you can imagine basilar encased, carotid encased. I did this case, and this patient is still alive, a meningioma. The patient came blind, still blind, but active and working at house. This lady, a little bit older now, little bit graying, but she does not allow repeat scan. This is another tumor I operated in 1995. This patient was quite well for quite a number of years, but then I lost for follow-up. This is another case I did in 1995, 25 years ago. Small tumor was left, whether to give radiation and all, gamma knife and all those things. These were not very, it was not important to give radiation for this. Even today, I don't think radiation should be given for small residual, but controversies have been raised and controversies have survived and they have thrived. and they will remain. But in my mind, it is very clear that radiation should not be used unless you cannot take your knife towards the tumor. If you can remove knife with knife, no gamma knife should be of any implication. This is another tumor I operated on 23 years ago, and this patient, I removed it quite radically, as you can see, but this patient developed hemiplegia after operation. Till this day, this patient comes to me with a hemiparetic gait. He's alive, well, thriving, wonderful, fantastic, but with hemiparetic gait. So now my question is whether I should have been a little bit more conservative. In those days, I was much more aggressive than what I am today. But today also I am aggressive, you can see from my tone. But you have to be controlled aggression. You have to be patient for the patient, by the patient, and always for the patient. That should be our motto when we are operating on, whether we are operating for gliomas or we are operating for cavernous sinus tumors. If we damage the sixth nerve, we have damaged something. You cannot say I have damaged because it is a part of game. It is not like that. So in the year 1997, on the basis of several cases, I described extradural approach to intracavernous sinus tumor. So this was the first time in the literature where an extradural approach was described for tumors. Of course, we know the work of Vinko Dollens, who described for aneurysms and for other things like even for trigeminal neuronomas. But intracavernous sinus, this was the first article based on dural confinements of cavernous sinus. Cavernous sinus is an extradural entity. An extradural approach is a viable, better, beautiful, fantastic option for these tumors. Over the years, you see, this is one tumor. I will now discuss several tumors and their dural relationship. So you tighten your seatbelts. You see, this is a tumor. I must say, this is the most vascular tumor of the brain. This is the most benign tumor of the brain. This is the most difficult neurosurgical problem. This is not pituitary tumor. This is not meningioma. This is cavernous hemangioma of cavernous sinus. It has got very characteristic dural relationship. If you misdiagnose it, take it for pituitary because it is going towards the sella and come from the nose, you will lead into torrential bleeding, which you may not be able to control. So you have to know this tumor on the basis of radiology. It is intracavernous sinus tumor. It displaces the dura. It goes towards the orbit, goes towards the Meckel cave, goes towards the intercavernous sinus, towards the intercavernous dural connection. Never transgresses the dura, respects the mother irrespective of the size. No matter how big it becomes, this dural relationship will remain. It encases the internal carotid artery. Sixth nerve is the most critical location that we have to understand. This in 1991, I did this tumor and published this. My feeling is this was the first report in the literature where preoperative and postoperative scan was shown for this complex cavernous hemangioma, which are difficult. And more important is the sixth nerve is within the confines. Fifth nerve and third and fourth nerves are on the dome of the tumor. No matter how big it becomes, goes towards the Meckel cave, goes towards the orbit, goes towards the intercavernous sinus, displaces the dura. Mother is protecting this beautiful tumor. Patient comes with severe headaches. Patient comes with visual eye movement disturbance, sometimes with visual disturbance, angiographically occult, but you touch and it bleeds. So most important thing in neurosurgery for these tumors is learn to operate in a bleeding situation. Learn to handle bleeding in a massive way. You cannot say, I want a dry field, I want a clean field. If you want a dry field, only cadaveric dissections are dry. If you work on this kind of, it will bleed furiously. You have to learn operate in a bleeding situation. Cavernous hemangiomas are extradural tumors. Cavernous sinus are intracavernous only tumor, primary intracavernous sinus tumor. For the first time in the literature, we described extradural approach to these tumors. And now several people in the world are doing extradural operations for these tumors. And this paper was published on the basis of 13 cases, which was the largest number at that time. Now my series is about 40 cases, which is also the largest series in the world on this subject. So this is a case of cavernous hemangioma of cavernous sinus. And I will just like to show you few images of this. So extradural approach, don't go intradural, that is not good. Take these tumors are long, you see how it is bleeding. Of course, it may not be good to have such a bleeding, but if it bleeds, you cannot go on coagulating. If you go on coagulating, you cannot ever operate these kind of tumors, or any kind of tumor for that matter. Acoustic, you go on coagulating, you never finish that operation. If you want to operate beautifully, you have to learn when to coagulate, when not to coagulate, particularly in cavernous sinus. So here you saw V2 and V1 that enter into cavernous sinus. It is bleeding. This will bleed furiously, and this is just nothing bleeding. Sometimes it will bleed more furiously. First and foremost is you have to identify the sixth nerve, save the sixth nerve. You see, I'm going towards the sixth nerve first. I'm not sure if you can see properly, but just try to imagine. You see the sixth nerve has come into picture. During surgery, you cannot say, I will imagine. You have to be very, very sure. You have to go towards the petrous apex, get the sixth nerve out of the picture, and then go and remove this tumor. And then, of course, you remove this is the carotid artery. These are benign tumors. Once you remove, once you protect the sixth nerve, you give new life to these patients. You give not only new life, you give a new smile to these patients. They come with severe headache. They come with devastating headache. They come with eye movement disturbance. There's third nerve paralysis here, sixth nerve palsy here. And you see now everything has returned. So if you want to do this, there is no gamma knife and all these knives will work here. There will be philosophical surgery that has to work. This is another tumor. I will rapidly show you a video where I did extradural approach, transgastrian. You see, I opened the gastrian ganglion, worked within the fibers of the gastrian ganglion, got towards the tumor, and then worked in a vascular tumor, bleeding. Don't go on coagulating. These tumors have to be circumscribed. They have to we have to go around the tumor. There are arteria inferior cavernous sinus, which will, one artery which will feed the tumor. Middle meningeal artery can sometimes feed. Arteria Mecanol's capsular artery can sometimes feed. But you get into a demolish the tumor as quickly as possible, get control of the bleeding. Sometimes carotid artery will bleed, and that you have to control. You cannot say, I will come transnasal, I will use endoscope and all those things. If you do that, I must say you have a very high chance of losing this patient. You have to have a very circumferential control. You have to do transcranial extradural approach, have entire thing under your control, and then remove this vascular tumor beautifully, fantastically, because the thing is, if you do a good job, you give new life to these patients. This is benign tumor. They will never recur. And you see that kind of thing is possible in this tumor. This is the internal carotid artery inside the cavernous sinus. That is the posterior clinoid process that was under vision. And once you pack it with Surgicel, you hardly any coagulation, and about 25. The whole video was unedited. I had moved a little bit, but the operation is not more than 25 minutes long. So this is preoperative and postoperative. Now I go to a very common subject of pituitary tumor and give you the dura and its relationship with pituitary. And I hope you see, these things were not known earlier, and many of these articles you will like to read if you want to go in details, but I will like to give you a gist of my concept. So many of these tumors can be big and large, but essentially they are completely benign. And if you remove them properly, you give new life. That is the beauty of pituitary tumor surgery and beauty of neurosurgery. You do a good job, give new life. Do a bad job, you devastate. So that depends on our training, on our understanding of these tumors. So even these huge tumors, on the basis of radiology, on the basis of clinical features, you should understand what is this tumor. So my concept is, and which changed the face of pituitary tumor surgery. I have no hesitation to say that I revolutionized pituitary tumor surgery. You will ask me how. And I will say that first time in the literature we said that as these tumors grow up, they take the dura along the dome of the tumor. So the tumor, this part of the tumor, which the earlier concept was that it is subarachnoid in space and all those kind of things, that concept was completely changed. The concept is now the dura is elevated like this. This concept has revolutionized. So whether you operate with microscope or with endoscope, those are very flimsy kind of issues. The concept philosophy is that the dura is elevated on the dome in a large percentage of these cases. You see clearly the dura is elevated like this. This concept was non-existent 25 years ago. We described this for the first time in the literature. And then, of course, the concept has further matured. So these kind of nubbins that you see here, this is not intracranial, this is of course intracranial, but this is under the dura. This is under the dura. So this mother dura does not allow these benign tumors to transgress. Even this kind of a huge nubbin which goes towards the brainstem is not, it is of course intracranial, but subdural. Dura is protecting. That is a very huge concept. You see, going in the brainstem, if you have this concept that the dura is going to protect, you can rather easily remove this tumor. If you do not have this concept, you go transcranial, you go subcranial, you go whichever cranial, but you can never remove this tumor. But this tumor is a philosophical, very fantastic dural-based tumor. Another fantastic concept that was existent, and we re-emphasize that concept, that these tumors, when they go into cavernous sinus, the diagnosis is when the artery is encased, it is intracavernous. The dura remains intact. The diaphragm celli dura remains intact. So the dura remains intact here, dura remains intact here. What is this medial wall? Why it allows tumor is a little bit controversial issue. I don't want to go into detail in this lecture. So this tumor, when they encase the carotid, it is intracavernous, lateral wall is intact, diaphragm is intact, and these tumors are grade 2 tumors when it goes into cavernous sinus. Now you see this is lateral wall is intact, diaphragm is intact, lateral wall is stretched, diaphragm is stretched, but not transgressed. You have this concept, you can remove. This is the beauty of this. You see now this very carefully, this slide. This tumor has gone, this is grade 2 tumor. When it goes in cavernous sinus, I call it grade 2. Elevation of dural roof of cavernous sinus. This entity we described 25 years ago is a beautiful concept and very frequently seen anatomical situation. Diaphragm intact, dural roof is intact and elevated. Now you see the dural roof is intact. Believe me, and you can really clearly understand, if you have this concept that the dura is going to protect you, you can remove it from the nose quite rather safely. And if you think that it is subarachnoid and it is encasing the arteries of circle of Willis, then it is, believe me or not, impossible to remove this tumor. So diaphragm is intact, dural roof is elevated, grade 3 tumor. Clearly see this beautiful slide. Diaphragm is elevated, dural roof of cavernous sinus is elevated by this tumor. This dural roof elevation is quite a common thing. So dural roof of cavernous sinus, diaphragm. So what I'm trying to say is these tumors go, you see there is some method in this growth. I don't want to say method in this madness, but there is a method in the growth of this benign tumor. It is very rare that these tumors encase the arteries of circle of Willis, and when the child stops respecting the mother, I call that child an aggressive and malignant child. Similarly, when the tumor stops behaving with the mother properly and goes beyond its trajectory, I call it an aggressive or malignant tumor. The surgical strategy for this is different. So this is my classification. Grade 1 is when the diaphragm celli is elevated. You see it is beyond the corpus callosum. Grade 2 is when it is going in the cavernous sinus on both sides here. Grade 3 is when it elevates the roof of cavernous sinus, that is grade 3. Grade 4 is when it transgresses the diaphragm celli. Transgresses what? I'm not saying diaphragm celli. Transgresses the dura. Whether it is from the roof of the cavernous sinus, it can also transgress from this direction. I call it grade 4. So this is my classification. And my feeling is, and my complete conviction is, that this concept, this dural concept, has completely revolutionized pituitary tumor surgery over the last 25 years. So these tumors are, you see, you don't have to remove. These tumors were invariably operated transcranially, invariably. But now there is no question that these tumors should be operated transnasally. You just remove the anterior wall, learn the concept, learn the art of demolishing the tumor, remove the tumor, remove the tumor, remove the tumor, and very soon, within 15 or 20 minutes, you will find the whole diaphragm coming and the matter is closed. I removed this tumor in 1997. So the diaphragm celli is like uterus. Uterus is the strongest muscle of the body. It pushes the baby down. Natural course of birth is from vaginal route this kind of trans-abdominal routes are not good. Similarly, for pituitary tumors, you don't say I will remove it from the transcranial route. This is a big belly tumor. Remove the tumor, and the whole diaphragm celli. There is necrosis in this tumor in quick time. And if you say I will remove in 5 hours, you should not be attempting this tumor. This should be removed in 20 minutes, or 25 minutes at most. So in 2001, I removed this tumor. This is another tumor, diaphragm elevated, some kind of blood in this tumor, very safe and simple tumor. Patient will improve immediately after surgery, new vision. When you go to the patient, say, doctor, fantastic, I can see you better. You are very, very fantastic. On the other hand, you do biopsy, you do partial removal, this will bleed and the patient will never be able to see and never will be able to see the world. To that extent. So we can give new life. We can give wonders to this patient if we have concepts, if we have the art of handling the tumor, art of demolishing the tumor, work within bleeding situation. This frontal approach, this extension, I did this tumor in quick time from the nose. These were the classical tumors which were operated, and you read the books at that time, they were frontal exposure and transcranial were the common routes 25 years ago. This is another tumor, you see, pituitary tumor. Just remove this wall and I removed this tumor from the nose in very good and quick time. This is another tumor I operated 20 years ago from the nose. You see this kind of extension. I'm not sure if you have this concept that the dura is going to be present. You don't have to deal with these arteries or perforators or anterior circulation, posterior circulation. If you think that they are encased in this tumor and all, then you cannot remove it. So you just demolish the tumor, If you start coagulating and say, I will have clean bloodless field, and you will never be able to even reach the tip of the iceberg. If you have to remove the whole tumor, you have to know how to demolish in a bleeding territory. This is another tumor. You see, 1999, 21 years ago, I removed this tumor from the nose, and this kind of extension, like putting your hand, doing a tumor here, and I did this tumor and benign tumors, and this patient, of course, recurred. Tumor involving the cavernous sinus is a different entity. When to remove this tumor, when not to remove is a complex issue, but transnasal approach for pituitary tumors involving cavernous sinus is the option. When the roof of cavernous sinus is elevated, these are more aggressive tumors. And you see, if you know that the dural roof is elevated, you can do transnasal approach and go towards the roof of cavernous sinus. Third nerve has to be protected, and this is the thing I did. But when the tumor residue is there in the roof of cavernous sinus, it is more aggressive. When the tumor encases the arteries of circle of Willis, they are malignant tumors. The surgical strategy for these tumors is absolutely different from other tumors. Now I go to the world of trigeminal neurinoma. So now better look at this. I published this series in 2003 of 73 cases, which was the largest series at that time. Now my series is 300 cases, which is also the largest at this time. In this beautiful article, which is a very highly cited article, I published for the first time in the literature that you can save the fibers of the fifth nerve and you can improve the sensations of the face. I also mentioned in this article that the trigeminal neurinoma arises from the Meckel's cave. We mentioned that these tumors are interdural tumor within the dura. They are very benign tumor. They respect the mother. They displace the fibers of the fifth nerve. You learn to break this tumor and the fifth nerve should be saved. In this article, I mentioned that this part of the tumor is subdural or subarachnoid-like acoustic, but in subsequent article I mentioned that large number of even this posterior fossa component is interdural in location. So work within the dura, respect the dura, and you can remove these tumors. So in 1995, I described this infratemporal interdural approach. What we did is just remove the zygomatic arch, open the Meckel's cave, and remove the tumor without craniotomy. 25 years ago, 28 years ago, these tumors were difficult. These kind of tumors without craniotomy. You see now, also they are not easy even at this time, but at that time they were quite impossible. You see this tumor going in the posterior cranial fossa, trigeminal neuronoma, diagnosed on the basis of clinical features. Just open the Meckel's cave, foramen ovale has to be widened, and I removed this tumor in 1994 without a craniotomy. So this was one beautiful, this in that article of mine, which was removed without respecting the dura, respecting the mother dura, and learning the art of demolishing the tumor without demolishing the, you see the fifth nerve, without demolishing or charring or burning of the nerves. You can do, if you know this anatomical information, that this is within the dural confines. This tumor can be an absolutely beauty of a tumor to be resected. Now my concept is that even the posterior fossa component can be quite interdural. So earlier in my series in 1991, we were doing two-stage operation. But when you see two-stage, which is larger come from here, then smaller come from here. Similarly, in 1992, I removed this tumor first, then this tumor. You can see this. But of course, as we learned the anatomy, larger tumors in 1996, we used to do for large tumors this kind of operation: basal craniotomy, removal of roof of condyle, roof of external ear, some mastoidectomy, basal subtemporal craniotomy, and this was the exposure that we described. As we matured further in this business of trigeminal neuronoma, my exposures are much smaller. They are just splitting of the temporalis muscle, basal temporal, no zygomatic osteotomy, and tumors of dumbbell shape can be removed beautifully. And of course, we have got several hundred, 300, more than 300 cases of such tumors, and beautiful. This is a beautiful chapter of our subject of neurosurgery in general, of skull-based surgery in particular. So you can have this kind of tumor removal, respecting the dura, and you can improve the cranial nerve function. So this kind of nubbin is not intracavernous. This will not be stuck to the carotid or something. There will be mother dura protecting it. Demolish the tumor and you will remove this tumor. When the tumor goes extracranial, there is a dural continuity, and you must know that the dura will protect even the extradural trigeminal neuronoma. I published this series of 28 cases, and it can go along the V1, along V2, along V3, and I described transcranial route to remove this extracranial component of this tumor, and which is a very fantastic, retract the brain to remove tumor. Skull-based surgeries avoid retraction to remove the tumor. So this is a reverse skull-based approach. Even when the tumor recurs in an trigeminal neuronoma, we said that these recurrence is also interdural in location. Now I want to show you third nerve tumor. You see, this is third nerve tumor. It grows like this, but the dura remains intact. If you have this information that this is not the capsule of the tumor, it is dura. So you remove the tumor, demolish the tumor. These are necrotic tumor, and respect the nerve. You see here, this is, we describe interdural approach for oculomotor. They arrive from the oculomotor cistern and they grow like this. And there is a dural cover. So you remove this tumor, you can preserve the third nerve function, which is never described earlier. Similar, you see that there is a dural cover to the third nerve neuronoma, dural cover. This is not capsule. This concept is absolutely critical. Sixth nerve is a little bit complex intracavernous sinus tumor. I am working on the dural relationship of this tumor. Maybe I come out with my concept very soon. Seventh nerve tumor. You see, this is geniculate ganglion tumor. This is a complex skull-based tumor. If you have this tumor, you will start operating. You will decide this mastectomy, that pituitary, this approach, that approach. But believe me, if you have this concept that this is completely interdural, 7-nerve neurinoma, interdural, you come from here, break into the tumor, demolish the tumor, save the fibers of the 7-nerve along the petrous apex, and you can improve the sensation of the function of the 7-nerve. I'm not saying I improved in all cases, but there is a possibility of improvement. But the concept is the entire 7-nerve neurinoma is interdural in location. Similarly, we said about lower cranial nerve neurinomas are interdural, so very critical. You see this tumor, there is a dura, mother dura protects this tumor, goes along in the petrous bone, extracranial, but the dura is completely in cover. So if you want to improve the sensation function of the lower cranial, which are absolutely critical, you have to work within the dural confines. Do not remove the dura, do not demolish the dura, do not coagulate heavily, work within the tumor, whether they're extracranial and intracranial and in the petrous bone, the dura mother protects. So this is a beautiful concept which we have published, and you will be happy to read this article. C2 neurinomas, you see these are C2 is behind atlantoaxial joint. They are like trigeminal neurinomas. Trigeminal neurinoma is surrounded by carotid artery and venous plexus. C2 is surrounded by vertebral artery and venous plexus. They are completely interdural in location. Like trigeminal neurinoma, we had earlier described that this part is intradural, means subdural, and this is interdural. But in the year 2008, I discussed 60 cases where I described that this part is intradural or subdural, and this part is interdural. In 2018, I published additional 60 cases where I said, you see, the anatomy has changed. The whole thing is interdural. And if you have this concept clearly ingrained in your mind, demolish the tumor, retain the dura, you can do beautiful dissection without worrying about the carotid artery. So this is C2, this is trigeminal, absolutely parallel imaging, absolutely parallel surgical strategy, C2 and trigeminal. So this is the thing. Now I want to give you a very favorite tumor of skull-based surgeon, chordomas. Chordomas are extradural tumor. They just cannot transgress the dura. Very rare occasion. They demolish the bone, displace the soft tissue. They displace the carotid artery anteriorly, displace the gastric ganglion superiorly, displace the dura. So this concept that the carotid will be anterior, if you have this, you can diagnose these tumors on a very regular basis. So these tumors displace the soft tissue, demolish the bone. In this was my paper published in chordoma and chondrosarcoma relationship with internal carotid artery, a very favorite article of mine. The carotid artery normally should be here, but it is displaced on the anterior face of the tumor. If you have this understanding that this tumor does not have carotid artery here in its vicinity, you can do a beautiful dissection by coming from lateral perspective. You see the petrous apex is demolished, Cavernous is demolished. So you can come from lateral, petrous carotid is anterior, dura is posterior, and these tumors can be removed in a beautiful fashion by a middle fossa approach. So the dura is intact. Believe me, this understanding will be very, very critical if you are going to remove this tumor. Carotid artery is anterior face of this tumor, and you can remove this tumor beautifully. So this is preoperative and this is postoperative. I want to just quickly show you some images. I know that I may be, Naren, you please stop me whenever you think, but I'm a little bit excited when I talk about this subject. You see intracavernous carotid completely under control. Clivus is being, so my feeling is, of course, endoscopy is a big and wonderful approach for these kind of tumors, but transcranial approach for a large number of tumors is very, very fantastic in many situations. I want to show you supracerebellar approach to clival chordoma. Beautiful approach. You see this tumor? If you come from here, it is quite behind. If you come from the nose, this part is quite behind. You have no control of the sixth nerve. So what I did was supracerebellar approach to this tumor. Identify the sixth nerve early in the operation, outside the confines of the tumor and then demolish this tumor, and you can do a beautiful job. You see this tumor, it goes in the clivus, that is diagnostic of chordoma, and then you come supracerebellar, remove this tumor, identify the sixth nerve early in the operation. This kind of a huge tumor you cannot remove from the nose. This will be too behind, and lateral is not such a, of course lateral is a good option which we have been doing for a long time, but this approach for the safety of the sixth nerve is quite a viable option. So these tumors, extracranial tumors, can be, you see, they are not only extracranial and extracavernous, but they have to be identified on a very fantastic nasopharyngeal angiofibromas. We described transcranial approach, I described in the year 1994, but they are extracranial and extradural. Transnasal midfacial gloving, degloving operation is a fantastic operation for these tumors. There can be epidermoids involving cavernous sinus. There can be aspergillomas involving cavernous sinus. There can be tuberculomas involving cavernous sinus. Few sentences about meningiomas involving cavernous sinus. Complex subject. You see, this meningioma is involving this, not involving the superior striatal sinus. This is little bit involving the superior striatal sinus. This is quite a bit involving the superior striatal sinus. When they involve the superior striatal sinus, they are more aggressive. This is involving the paranasal sinus. They are more aggressive in their behavior. And when they involve only paranasal sinus, it is meningioma. They are inherently aggressive. Similarly, when the meningiomas are inside the cavernous sinus, they are in, meningioma means tumor of the meninges, tumor of the mother. They can be on both sides of the dura. When it is entirely intracavernous, it is more aggressive. When it's intra and extra, it is less aggressive. When it is, you see, when it is involving just the lateral wall of cavernous sinus, it is less aggressive. When it goes in cavernous sinus, it is more aggressive. When it goes in the paranasal sinus, it is inherently more aggressive. When it is entirely within the cavernous sinus, there are huge chances of recurrence. It is inherently more aggressive. So that understanding is very critical when we are going to operate on tumors involving meningiomas involving cavernous sinus. You see, it is going in the nares. This is a malignancy, and you operate like a malignant tumor. When it is from the lateral wall, it is a benign tumor like a convexity meningioma. When it is from the posterior wall, it is a benign tumor like a convexity meningioma. You see, from the posterior wall, this has been beautifully resected. Earlier in my business of skull-based surgery, I was highly, you see, my petrosectomy, my facial mobilization, my carotid artery mobilization was on a regular basis. But now my approaches have become little bit, see, this one magical operation I described, which is very popular now, supracerebellar approach for petroclival meningiomas. This is many neurosurgeons are very, they like this approach, and this is quite a beautiful approach. Of course, Sammy had described retrosigmoid approach. So this is another tumor where I left some tumor behind. How much to leave, when to leave are very critical. You have to be not only a technically master, you have to philosophical master. You have to know the patient. You have to know the needs of the patient. So meningioma series, this is my tuberculum celli meningioma series in 2002 with 70 cases. Now this is the largest series in the world. Olfactory group, this is personal series, also largest in the world. Anterior clinoid meningioma. You see, my power is my numbers and my, you see, my hospital. I work in a KM hospital, which is one of the most fantastic hospitals in the world. In meningiomas, curing is not the issue. Recurrence of meningioma is independent of extent of tumor resection. It is not the treatment, but the cellular behavior that decides the outcome. So thank you very much, my dear Naren, and all the young and old people, not old, nobody is old, all who are interested in our magical subject of neurosurgery. Thank you very much, Naren.
Thank you very much, Professor Goel, for a tour de force of this very complex area. And just, I think we have got one question, and it's a complex area, but just some observation is that the I think in terms of what you said about age and old, I think the definition I use is that you are young until you are still learning, and I hope that I will always learn until the last day. And in terms of the complex operation, this is absolutely fantastic, and probably I'm sure Prof. Gaul will say you have to spend time in the labs, anatomy labs, to really understand the nuances of anatomy, to feel confident when we go into theater. And but in the same time, before the talk started, I was talking to Professor Grotenius. After seeing all these big operations, I'm just starting to think my small operations are small. And Prof. Grotenius said, look, Naren, every operation is big, and you can cause as much problem with a shunt as much as a big meningioma. So I think every operation is important. So please to consider what you are doing is still hard, complex, and needs all the attention. So I think there's one question here. I will just bring. I think so. It's from Dr. Parak. Dr. Parak, do you want to ask the question yourself, sir?
Hi, Atul, Professor Atul.
Yes.
I'm very delighted to listen to your lectures. Very fascinating. You not only demolish the tumor, but you demolish everyone who is around. It's an amazing talks. Always you are in all of us. Although we have grown together much ahead of anybody else. I compliment you for that. I just had a query when you were describing about grade 3 and grade 4 pituitaries. Do you still advocate we should go transnasally or transcranially?
You see, for grade 3 tumors, where the roof of cavernous sinus is elevated, that I call grade 3. Grade 3 tumor is a transnasal surgery. Grade 3 tumor, always transnasal. Yeah. Grade 4 is an enigma. Grade 4 is completely a different entity. How much to remove, whether to remove radically, whether not to remove radically, whether to rely on radiation. Because, I have burnt my fingers on radical resection as well. Because these tumors encase the circle of Willis, they encase the perforators. And to remove these tumors, the post-operative bleeding situation is much more than a regular meningioma bleeding. You see, meningioma will not bleed. Meningioma displaces the artery. But giant pituitary tumor, which encases the artery of circle of Willis, also encases the perforator. So to remove these tumors radically, so I'm still, working on this concept as to how much to remove. Grade 4 tumor is still an enigma for me. I will not be able to confidently give you a complete, clear picture.
Thank you. Thank you very much, Professor Atul Goel. I think I think we have
one more question.
It has to be quick because I think we are running slightly late. Please go on. Thank you. Please.
Sure. Thank you.
Please go on, sir. Dr. Parak, do you want to ask that question?
Yeah, one more question.
Sure.
Whether when there is hourglass deformity, you feel that
yes.
There is a hourglass deformity
yes,
in the
yes.
tumor.
Harsha, I
part
got
is going supracellular, retrocellular, anterior.
I understand your point. So that is the concept. That is the concept that we changed. That is the, I call it, I use little bit aggressive terms like revolution and all those things. But that is indeed, you see, this hourglass appearance, the concept that exists, and even in Hardy's paper, Jules Hardy's paper, you will see that this hourglass means the cellar part was intradural. That was the concept. And then there is a hole in the diaphragm celli, and the upper part of the hourglass is subarachnoid. That was the concept even in Jules Hardy's paper you read. But that is the concept that we changed. We said that the tumor does not go through the hole in the diaphragm celli. The diaphragm celli is elevated by the tumor. And I have a feeling that this concept is absolutely has changed the face of pituitary tumor surgery. This is my feeling.
Thank you. Thank you very much. Thank
you. Good. Excellent.
Thank you.
Excellent.
Thank you.
Your talk was
Professor Gaul, there are many comments for you on the chat box. Thank you very much again. As I said, it's a lifetime work, and it really is a privilege to have it for us. And I'm sure we will have you again to go through this for us to get it into our deep brain. So thank you.
Thank you, Naren. And I can only compliment you, Naren, for this organizing this conference. It is for the young people, for the people who want to learn. And I see so many people in the audience being relayed on YouTube, as you said, on Facebook. I think this kind of opportunity which you are giving, you see, earlier the opportunity was only to people who could afford travel. Suppose I can go to America, go to Germany, go to England, I could watch this. Otherwise, I was not able to do. Now what you are doing is you are disseminating this information to every small village of the world. And that is a big contribution. I think during this COVID times, when we are more relying on this web-based information and web-based lectures, we have made the whole world of neurosurgery equal. Those who are able to imbibe the ideas, those who are able to suck the ideas, those are superior people. It is not that if we are technologically advanced countries, then you see, I think I will only congratulate you, Naren, for this huge Herculean task. And I wish you have more strength on your shoulders to be able to do things, to able to show things, and able to teach various people of the world. Thank you very much for your contribution, Naren.
Thank you very much, Professor Gaul. Thank you very much for your support, the support of all the seniors. And as you said, I think what we can say is that the knowledge is there. Who wants to suck and learn from it, they can prosper. So I think I'm really glad that the webinar has really made the knowledge flow freely. Thank you. So we'll now go to our papers, and the first paper now is from Ancona, from Professor Maurizio Iconelangeli's team. And as generous as he is, I know he's a very generous teacher. So he's going to get his resident, Dr. Rosella Fasanella, to give this talk. It's a complex area, so Professor Iconelangeli is there for any questions to support Rosella. Rosella, do you want to share your presentation, please?
She is still muted.
Good.
Mm-hmm. Quindi ingrandisco. Okay, can you hear me?
Yes, very clearly. Thanks. Thank you.
Okay. Good morning to everyone. I am Dr. Fasinella, and I am a neurosurgery resident of Professor Iconelangeli School. Today, I'm going to speak about the surgical approaches to the craniovertebral junction. Let's start. In the last 30 years, a lot of neurosurgeons all over the world, starting from Secker and Spetzler and so on, developed new technical improvements to increase the maneuvering space and the working angle in order to minimize the manipulation of the neurovascular structures. So in our case series, we collected the clinical records of 35 patients undergone surgery for the CVJ disorders from January 2011 to January 2019. And all patients were stratified by clinical features pre and post-operatively. The post-surgical instability was assessed by CT and MRI imaging, and the mean follow-up was at 6 and 12 months. So in the table below, you can see summarized the data. How to select the best and the least invasive approach in the skull-based surgery, as well as all over the neurosurgery. You have to behave as you were in a bank robbery, as is funnily reported in this image. You have to enter as smoothly as possible to select the best approach, and then you have to take away as much as you can to address the lesion and the disease, and always thinking about the reconstruction phase when you have to erase all the traces, of course. This is why the best approach to the CVJ should be chosen case by case and tailored on the patient's anatomy. So the first illustrative case is about 41 years old patient with sudden onset of headache, nuchal headache, and dizziness in the previous days. And a non-enhanced CT scan shows subarachnoid hemorrhage of the basal cisterns, and the following angiographic and angio-CT studies detected a left PICA aneurysm just at its origin from the vertebral artery, as you can see also in the 3D reconstruction. So a lateral approach was adopted with a transcondylar extension in order to allow a more lateral approach and to gain access to the lower clivus and to the premedullary area. In the following images, you can see the preservation of the jugular tubercle, the extension of the condylectomy together with the clipping of the aneurysm, of course, and the postoperative angiographic study showed no residual of the aneurysm. So the lateral approach recognized three variants: the transcondylar one that we have just seen. The supracondylar approach instead provides access to the region of the hypoglossal canal and the jugular tubercle, as evidenced in the green area of the figure D. And the paracondylar approach that provides an access to the posterior part of the jugular foramen and the posterior aspect of the fascial nerves and mastoid on the lateral side of the jugular foramen. So this is a 60 years old male with a fracture of the odontoid process, initially treated with a conservative treatment, but a pseudoarthrosis occurred in the following months, so he was subjected to a surgical treatment, an endoscopic endonasal approach to better ensure the synthesis of the bone. This is not the common way that we treat the odontoid fracture, but we wanted to focus on this peculiar case to emphasize the potentiality of the endoscopy. Of course, an anterior transcervical approach was required in combination for the C1 C2 screw fixation. So as you can see in the video, is the drilling. It is thinned lower down to expose the rhinopharynx mucosa, which is incised on the medial line in order to expose the anterior C1 arch. The pseudoarthrosis tissue is removed by drilling and dissecting. And in this case, we were able to transpose the principle of the arthrodesis, the common arthrodesis that we perform on all the kind of spine fractures in such a delicate and critical area like the craniovertebral junction is. Then in here, you can see the positioning of the screw through the transcervical anterior root and the simultaneous assessment under endoscopic guidance of the screw positioning into the odontoid process. We then collected the fragments of the iliac crest and melted it with the bone marrow to fill in the gap of where the pseudoarthrosis was. Besides, the bony edges were drilled to make them bleed and encourage the healing process in the future. And the reconstruction phase is ensured by the position of course, the fibrin glue and the juxtaposition of the mucosal flaps by the stitches. They were tied out the mucosa. And then in the end, of course, the hemostasis phase. So in this slide, we can see the postoperative CT scan in coronal, axial, and sagittal projection. The extended endoscopic endonasal approach offer a minimal invasiveness thanks to the endoscopic guidance, and contemporarily the possibility to preserve the anterior C1 arch and ensure the biomechanical stability of the CVJ. It also avoids the eventuality of a posterior fixation and its related risk of a subaxial instability. To conclude, the CVJ is a complex area to approach, both for its anatomic configuration and the inherent pathology, of course. The CVJ approach is to be tailored always and designed according to the disorder and the patient's anatomy, and to address the lesion in the best way possible. The bilateral approach and its variants, its extensions allows to handle most of the CVJ's disease. And the goal is to achieve an appropriate surgical exposure with the best working angle and the minimal manipulation of nerves, arteries, veins, and the bone demolition. This is the real matter of the reconstructive phase. The bone demolition is essential for selected cases, but a more invasive bone removal should always require a specific reconstruction technique. So I thank you all for your attention.
Thank you very much, Dr. Fasanella. Dr. Professor Goel, can I just ask you to reflect on, can I please ask you to reflect on the talk of Dr. Fasanella and Professor Yekananjali? Thanks.
Just a minute.
Sure.
Naren.
Thanks.
Yeah. So I enjoyed this lecture. There is no question. You see, anterior approaches are good, and even instrumentation, as shown by her, are reasonable and solid technique. But you see, if we are doing stabilization from front, you must, I just want to give a concept. I am very happy with the presentation, just a different kind of concept. You see, all our muscles are located behind. The nape of neck is loaded with muscle. Anteriorly, there are no muscles as such. In front of the vertebral body, it is a very flimsy, thin, longus colli, which is very thin muscle. So if we have to stabilize this craniocervical junction, we have to, we have to work and demolish the muscles which are going to move your spine. We have to demolish the muscles which are attached to the C2 spinous process, which is the largest spinous process of the body. My feeling is fixation from behind is always better. Although can be done from front, and although can be done from transnasal route, from transoral route, from transcervical route, but posterior is the best way of fixation. This is my concept. This is apart from what she has said.
In terms of why would you say demolishing the muscles would be useful, Prof? I might have just missed the.
Yeah, you see, if you put a fixation device and you have retained the muscles attached to the C2 spinous process, believe me, those muscles are so strong that they will keep moving and they will dismantle the implant. So if you are fixing from front and you have retained the muscles which are going to go on moving and doing that function from behind, they have the potential to demolish the implant. That is what I mean to say, Naren.
Thanks, thank you. Professor Aikananjali, do you want to?
No, the concern that Atul give, of course, are based on the biomechanical point of view, and I agree with him. Even when I visited this department and we were engaged in this discussion, we just want to propose the potentiality of this in order to treat this disease, because this is the way the orthopedic surgeon treat the long bone fracture. So in some way is something that can be considered, but all the concerns that Professor Golatul said are right, because all the stress, the force or the dynamic force are from behind. So if there is something really there is no question that the anterior fixation is not so strong as the posterior fixation. But in this case, the one episodarthrosis, all the muscle behind were preserved. So if we will be able to reconstruct the fracture and repair the not dislocated the fracture, like the long bone fracture, this is something that can restore the mobility, the cervical motion, and preserve the functionality. This is an idea, but of course we use the C2, C1 fixation, all the posterior stuff. This is just an experience in a few cases, of course.
Thank you, Professor Aikananjali. Professor Goel, just to go back to you about the posterior side. That, you know, obviously I'm not talking with any of the experience and expertise of both of you, but you know, in terms of although biomechanically it might be useful, but doesn't destroying the muscles cause quality of life, pain, etc. because of them? Because remember, you know, when I put that patient of mine with a Chiaria, you know, on the hard collar, the patient's symptoms got better, but the Chiari didn't. But isn't the actual damage to the posterior muscle mass will cause quality of life to be worse? I'm asking you, not that I am saying it.
No, you see, you know, what happens is, it is a very basic issue. Issue is if the region becomes unstable, you have to stabilize and fuse, and that segment has to be forgotten. Means if there is atlantoaxial instability, you have to stabilize and fuse that segment. To fuse that segment, you have to have bone fusion and arthrodesis of that area. And arthrodesis can be achieved only when the movements of that region are completely stopped. We use cervical collar, we use external braces, we use these things to stop the movement. So to stop the movement, if you can do internally, you can remove the muscles of that area, you have stopped the movement directly. So if you can completely remove the movement, the arthrodesis will be you can achieve arthrodesis. Of course, if you are removing the muscles of that segment, you are losing that segmental movement. And if you are achieving arthrodesis of atlantoaxial joint, you are losing that movement, and that is the price you pay for the unstable spine. But rest of the neck is there. You see the rest, C2, 3, C4, the whole neck is there. And the movements apart from minor movement restriction, there is no limitation in no real problem with the patient.
Thank you very much. Thank you. Much obliged. So the next presentation from Ancona as well. Professor Aikananjali, is it you presenting, or is it one of your residents? Thanks.
No, it's one of my former resident. Now is the young neurosurgeon that developed this job with the laser. Is Dr. Colasanti. Is I would say not a younger. He is younger, but quite expert in this field. Should be online.
How do I spell?
Maurizio, it is my great pleasure to see your face and see your smile after a long time.
This is the philosophy of the life. Even in the disgrace, you must smile, because smiling permits you to face the difficulties with more habit. So it has no sense to be depressed. Only everyone happened to me. No.
Professor, shall I just? I have to bring back. Sorry, I just want to let your colleague share his presentation. What's the name?
Roberto Colasanti.
Okay, Roberto. I'll just go to Roberto.
Roberto Colasanti. Ciao Roberto, ci sei?
Oh God, I got it. Thank you. Yes.
Okay.
Dr. Roberto Colasanti is going to present to us on application of novel scanner-assisted carbon dioxide laser system. Dr. Colasanti, do you want to share your presentation, please? Hello? You have to unmute yourself. Good. We can't hear you, Dr. Colasanti. I can't hear. Can anyone else hear Dr. Colasanti?
No, can't hear anything either, Naren.
Thanks, George. Dr. Colasanti, we can't hear you.
Naren, we can move on and then
come back.
After the next presentation. We will present after the next presentation. Thanks. So we try to solve the technical problem.
No problem at all. Thank you very much.
Thank you.
So this brings me to invite Dr. Noor Ul Huda Maria from Pakistan to present to us on the comparison of surgical versus intradiscal ozone treatment of sciatica due to lumbar disc herniation. Can it be an ideal option to consider during COVID-19 pandemic? Thank you very much, Dr. Huda Maria. Look forward to your talk.
Hello, sir. Thank you again. Can you see my slides? And
absolutely. Yeah, absolutely.
Thank you so much. Thanks a lot, sir. Again, I'm really honored to present my work for this. Yes, is it fine, I guess, no?
Yes, everything is fine. Yeah.
Thank you so much. It is on ozone nucleolysis versus surgical management.
Oh, sorry, we are not seeing your slide. We are just seeing your photo.
Exactly. From my side, I can just see that too. I'm sharing that again.
Sorry, I have to make you co-host. It might be just my fault. Sorry. Okay. Okay. Okay, you should be able to share your presentation now.
Yes, sir. Sir, can you see my
you can see
now?
it. Yeah.
Thank you. Sir, it is basically on the topic of ozone nucleolysis versus surgical management of lumbar disc herniation, with a special reference to application in pandemic and epidemic circumstances, potentially which are infective outbreaks that may lead to certain problems. So again, we'd like to share that it is easy to get 1,000 prescriptions, but it is hard to get a single remedy. So basically, we have a lot of options for lumbar disc herniation. Many of the patients just want a surgical option. Many of them just resort to a non-surgical one, but there are other options as well. The advent in spinal disc surgeries and interventional modalities. So first of all, I would like to just share a few lines about the mechanism of action of ozone. And we all know that it causes a lot of redox reaction. Basically, the mechanism of disc herniation includes there is in the nucleus purposes some sort of how you can say that it is the nucleus that has been expanded, or you can say that it has been like 80 meters because the interdiscal pressure has been raised. So it is like that because of that, all these things that are taking place with degeneration and aging. So redox reaction with the proteoglycans of the nucleus pulposus caused by the O3, that is ozone, cause matrix dehydration and degeneration. The larger proteoglycan molecules that are found in the nucleus pulposus are broken down into smaller ones. That leads to the seeping out of the water molecules from them and that leads to dehydration of the disc. And that ultimately causes volume reduction of the disc, which causes drop in the interdiscal pressure that elevates compression on the nerve roots and surrounding vessels. That leads to reduction of the venous stasis as well, and the nerve root edema is being decreased, and hypoxia is also changed to balance towards a better oxygenation of the tissue from a hypoxia to the other way. The other mechanism of managing the hypoxia includes increased tissue oxygenation, as also increase the concentration of 2,3-BPG, that is diphosphoglycerate, within the red blood cell, that is basic carrier that shifts the balance towards oxygen delivery. And the third mechanism includes the inhibition of synthesis and the release of pro-inflammatory cytokines, prostaglandin 2, bradykinin stimulation of release of anti-inflammatory cytokines. That is the balance between the pro-inflammatory and the anti-inflammatory. It decreases the level of pro-inflammatory and increases the level of anti-inflammatory prostaglandins and prostaglandins and other cytokines. So in that way, it causes an analgesic and anti-inflammatory effect. So it acts from 3 different ways. Ozone has got 3 different ways, like O3, like a molecule, it's a 3, and also 3 mechanism of actions. The technique is much easy and can be easily learned by a neurological surgeon. It is done under local anesthesia, and fluoroscopic guidance, of course, is important. Intradiscal injection of an O2-O3 mixture at concentration of 27 to 30 microgram per ml, which is freshly produced by a specialized ozone generator. About 5 to 10 ml is given usually, and ferroradicular injection of the same mixture, about 10 ml, and a steroid of 1 ml and local anesthetic of 1 ml has also been injected, so that it leads to its analgesic effect. Here are the pictures. It is, as you can see, it is being introduced through the SAP, the superior articular process level, that reaches the middle third of the disc, middle half later on, and that's how after that you introduce that mixture. And just say that who is an ideal candidate for the procedure? Anyone who has got a failed conservative management for at least 4 weeks, and anyone with a contained disc. However, Marco Lunardi had just introduced a method that he says that an extruded fragment can also be a potential candidate for the ozone treatment. Absence of red flags is very important, especially regarding Kodak Venous syndrome. You cannot proceed in that case with this remedy, of course. In that case, you have to go directly to the surgery. Any absence of local infection is very prudent, and absence of bleeding disorders as well, although it is considered to be a relative contraindication. With reference to the current scenario of COVID-19, when we were doing this research, we could have never even thought of it, that there could be anything like that in our setup. So at that time, it was something like radical and very minimally invasive, especially in those patients who fall in the gray area where you are not going to opt directly for the surgical option, and you are not really satisfied with the conservative, with the conservative management. So in that case, we thought that it is a very attractive management plan for all those patients who fall in that gray area, and also for those elderly who should not be exposed to general anesthesia and longer procedures. But with the current scenario, we thought that it could be something that we could consider during the COVID-19 pandemic, when much of the surgeries, the spinal surgeries, except those which were emergent, were largely suspended. This is a reference from the very famous movie, which was the Back to the Future, where he said to Marty, whatever happens, Todo will go to 2020. So in that case, we've been joking like that we were never going to the Back to the Future, but we were writing something that would ultimately lead to its implication during the COVID-19 pandemic. So what I can defend of this procedure for the COVID-19 pandemic, it is because it is a day case without any admission required. Patient just admit in the morning and they get operated and they stay for a few hours in the street and then leave for home. There is no need for general anesthesia. So you do not have to do that ETT and etc. And that is, obviously we all know that performing anesthesia is very risky for transmission of the COVID-19 infection. In these cases, which are under local anesthesia, you can just take a level 3 PPE and obviously proceed with surgery. So in that case, it inhibits the transmission. Short procedure, it does not occupy OTs as well as doctors for long. So you don't have a long duration exposure, and obviously the doctors can easily just perform it and do not need much time during their very busy schedule, especially during the pandemic. The learning curve is not that much steep. It is a quite easy procedure for every doctor who has been working for quite long. Doctors can be easily trained. It does not involve much resources and equipment as well. Economical, yeah, it is very budget friendly on hospital, and there's no need for long medication as well on the part of the patient. Patient resumed their normal activity quite quickly. So our work was to evaluate the ozone therapy for the group of patients that should avoid the hazard of surgical exposure, and to compare the surgical and ozone nuclear lysis treatment of sciatica so that it can be treated more precisely at local on the level of the basis of literature available after the study. We enrolled 72 patients from both genders and divided them equally into 36. And patients before surgery ozone nuclear lysis management for sciatica were confirmed to have a lumbar disc herniation by MRI. Ozone nuclear, like I mentioned before, the surgical management was in our setting before the standard laminectomy and discectomy. The exclusion criteria: low back pain with positive signs of nerve root involvement and resistance to conservative management for 6 weeks. Neurological contained disc, again, like I've said before, exclusion of all those patients who have a fragment, a fragment that was a free fragment, or also those with the Queller syndrome. Outcome was assessed using the VAS score, and all those were considered. The satisfactory outcome was considered to be a VAS score of less than 2. The patient were assessed before surgery, immediately after surgery, after the surgery or the procedure, after 1 week of the procedure or the surgery, and then monthly for 3 months to just look for that. This is a variable. These are our sample demography. The age 42 quite matched. You can see that we have matched them quite well, so that we do not have any problem later. So the VAS score is given here in mm, although it is in the usually centimeters. So it was 4.1 before surgery, 4.1 before ozone nuclear lysis, and 4.2 before surgery, and after ozone nuclear lysis was 1.4, and after surgery it was 1.6. So what we thought that satisfactory outcome was observed in 66.7% of the patients who were treated with ozone nuclear lysis. For the surgically treated patient, it was 36.1, and this was statistically significant. It is a p-value of 0.001, where the p-value significant is less than 0.05. For ozone nuclear lysis, the pre and the post-operative procedure, the VAS score was 4.1 and 1.4 respectively. That is, pre-procedure it was 4.1 and post-procedure it was 1.4. For surgically treated arm it was 4.2 pre-surgery, and post-surgery it was 1.6. So we conclude that in selected patients with contained disc without severe myelopathic sinus symptoms, ozone nuclear lysis is better than surgical treatment, especially in the early course of the disease. Again, I would like to emphasize that it depends on the proper patient selection and also upon one's own expertise. So in those patients, I will again say the gray area of of patient selection is that all those patients who actually qualify, who fail on conservative management, but surgery could be a bit more invasive and aggressive management plan for them, they should be considered for this treatment easily. And obviously, in the COVID-19 pandemic, it is very useful to consider this procedure. This therapy is especially useful in patients who are at high risk for surgery and anesthesia. Also, nuclear treatment is safe and useful option for providing early relief sciatica due to lumbar disc herniation, and this intervention should be considered before surgical options. In this pandemic, this option should be considered because of the safer profile regarding disease transmission, cost effectiveness, and for being minimally invasive. I thank you so much for your kind attention and for listening to me. Thank you again.
Thank you very much, Dr. Huda. Can I please ask Professor Grotonius to reflect, and once again, Dr. Gold to give his opinion. Thank you, if that's okay. If Professor Grotonius there. Dr. Gold, could you please reflect on the talk, please? Thanks.
Hello.
Hello, sir.
Yeah. So this is an interesting, you see, this ozone business is has been existing for a long time. It has seen its high days and low days. But to tell you the truth, I have no real experience on this. My recent concept on herniated disc are a little bit different. My understanding is that herniated disc indicates herniation of disc is secondary to instability, or herniated disc causes instability. Did you get my point?
Sure.
Herniated disc is either a cause of instability, or it is a result of instability, either a cause or a result. Basically, my feeling is that instability is a huge issue in a herniated disc when I'm working on this concept. Now, when you put ozone, my feeling is that you are introducing a kind of a, some kind of fibrosis or some kind of scarring or things like that, which results in fusion of that area. Maybe that is the thing that works here. I'm not exactly convinced about its utility. And as you know, nobody in the world is really convinced about the utility of ozone. But my feeling is that the factor of instability has to be considered in a very strong way.
Thanks. Thank you very much, Professor Gold. Dr. Nuro Huda, congratulations on a very useful technique, and look forward to more results from you and your colleagues. I think sometimes it's the symptomatic improvement is good enough, and I know that I did some spine myself, not in the same league of the big spine people, but number of times with large disc herniation, even well after 6 months, with giving epidural injections, patients were absolutely well, pretty long term. And so sometimes what do you call it doesn't necessarily that you have to do everything to make a patient absolutely better. So thank you very much. Congratulations again on your work. Well done.
Thanks a lot.
Thank you. So I'll now go back to Dr. Roberto Colasanti. Just a second. Dr. Colasanti, could you share your presentation, and let's see whether we can get your voice as well. And you have to unmute yourself. Let's see. We can't hear you. No problem, Dr. Colasanti. What we can do is that we can go to Dr. Jallo's talk, and then we can come back to you again. Is that okay, Maurizio?
Yes, yes, of course, Naren. Move on, and then
we'll come back.
Yeah, thank you.
Dr. Jallo, let me see.
Can you hear me now?
Yes, we can hear you. Great, fantastic. So, we'll go ahead with you. Then we'll go to Dr. Jallo. Is that okay with Dr. Jallo? Thank you, Dr. Colasanti. Do you want to?
Yes, thank you.
Thanks, George. Dr. Colasanti, so he's going to present us on application of a novel scan-assisted carbon dioxide laser system for minimally invasive neurosurgery. I'm very keen. Thank you.
Thank you for this opportunity. Well, the topic of my lecture is the application of a novel scanner-assisted CO2 laser system for minimally invasive neurosurgery. The first use of a CO2 laser for the surgical resection of a glioblastoma multiforme was in 1969 by Professor Stellar. Since then, CO2 laser was used for dealing with different neurosurgical conditions, but different operative limitations precluded its broad diffusion despite potential advantages. For example, CO2 laser may be very useful when dealing with some hypervascular lesions, like it's the case of this sphenoid wing meningioma, when the control of the bleeding is difficult using bipolar forceps or also standard hemostatic agents, as we can see in the surgical video of this case. In the last decades, significant technological improvements, as well as better ergonomics and quality of accessories, have made CO2 laser surgery easier and safer. On the other hand, the flexible hollow fiber CO2 laser may represent a different surgical solution. The flexible fiber CO2 laser has specific features like the possibility to wield the laser via a handpiece, just like any other surgical instruments. Moreover, it is useful for lesions difficult to reach under a straight line, as well as in endoscopic cases. On the other hand, the fiber CO2 laser has a low precision because of the freehand control. Moreover, it has a longer leaning curve and it is quite expensive. This is because we started to use this system, Smart Side 2 CO2 laser system. It's a CO2 laser with a radio frequency excited laser source with a great versatility of the pulses, a micromanipulator and a surgical scanning device covered with a surgical microscope. Moreover, different scanning shapes are available with different sizes and models of emissions according to the treatment needs. Finally, a micro switch is used usually to remote control all the main scanning function without taking the eyes of the operating microscope, and the foot pedal is used to activate the laser emission. We use this laser system for dealing with 6 different neurosurgical conditions in 6 patients. Lab training sessions were used to define the optimal laser settings. Lab as well as surgical tissue samples were taken for histological analysis that always showed minimal thermal injury. The hexagon figure was used for ablation, the line for incision, and the cubal scanning shape for tissue coagulation. I like to present some illustrative cases in order to underline the potential indication of this system, as well as its utility when dealing with different neurosurgical conditions. This is the case of an 8-year-old lady presenting with left-sided hemiparesis, memory disturbance, and depression. Preoperative CT scan showed right-sided fax meningioma. Preoperative angio-CT showed a very extensive tumor blood supply from both the external and internal carotid arteries. As we can see from the video, the lesion was removed using an interhemispheric approach, and the laser was used in every step of the procedure and allowed to reach a precise ablation of the lesion while minimizing intraoperative bleeding from the feeding vessels. Indeed, one of the most important features of the laser is its ability to perform different surgical tasks at the same time. Indeed, the laser may coagulate as well as ablate the lesion at the same time, or incise the lesion, thus potentially increasing the intraoperative visualization of the structures because it reduces the blood loss, and in some way increasing the efficiency of the surgical procedures by avoiding the need to switch from surgical instruments to another to perform different surgical tasks. We can see one of the at the end of the procedure that we put anyway the hemostatic agents to control the bleeding after the removal of the lesions. This is another case, a 62-year-old lady presenting with the progressive left-sided hearing loss, tinnitus, and balancesis. Brain MRI showed a left-sided vestibular schwannoma extending into the internal acoustic meatus. As we can see from the operative video as well as from the post-operative CT scan, the lesion was approached through a presigmoid retrolabyrinthine approach. The laser, after the initial incision of the lesion for histological analysis, was used to debulk the lesion. Well, we believe, we agree that when possible, it's obviously to be preferred an external dissection of the lesions in order to avoid unnecessary coagulation of the lesion itself. But in some cases, when you need to debulk the lesion, as in this case, the laser can be an useful adjunct, an useful tool to coagulate and progressively dissect the lesions while working safely close to important structures like the seminate complex and the lower cranial nerves, and finally achieve a complete removal of the lesions. The brain, the post-operative, the immediate post-operative brain MRI showed the complete removal of the lesions without any cerebellar contusions. The following case is about a 64-year-old gentleman who presented with headache, personality changes, irritability, and memory disturbance. Preparative MRI showed a right frontal lesion that was removed using, again, the laser that was used from the initial PL incision of the cortex, and then the lesion was, the cortex was coagulated, as we can see using the cue ball technique. Then we used a second tool to ablate the cortex. Once we defined the borders of the lesions, we used, as we will see, a scalpel to gently remove the internal portion of the lesions. And finally, we just incised the external portion of the lesions that was removed. This is one of the last phases of the removal of the lesions. Post-operative, and then now we can see the use of the cue ball scanning shapes to coagulate the operative bed of the lesions. The post-operative brain MRI showed a marked reduction of the preoperative cerebral edema, and no brain contusion was evident. The last case is about a recurrent spinal schwannoma in a 40-year-old man presenting with bilateral lower limb weakness. In this case, the laser was useful to progressively dissect the scar from the previous surgery as well as the fibrosis. Then once the dura mater was opened and the borders of the lesions defined, the laser was used again to incise, dissect, and remove progressively the lesions. The patients did very well after the surgery, and no posterior fixation was needed. We can see the final coagulation and removal of the lesions. To conclude, the system, the laser system we use at the Smart Side 2 CO2 laser may represent a suitable and effective and precise tool for the resection of different cerebral and spinal lesions, because it may represent in some cases an elegant solution to some of the ergonomic limitation of the laser systems while maintaining the advantages of the lasers, no touch dissection, the ability to perform an accurate hemostasis, cutting and or ablation of the tissue at the same time, with minimal lateral thermal spread, thus preserving the surrounding neurovascular structures. Thank you for your attention.
Thank you very much. That's very good tool. And I always say, they say that tools don't make the man, but I think tools in the right hand does make the difference. Doctor, has anyone else in the meeting used this system? George, do you have any experience, or what do you? I think it's more skull-based, but what do you think?
No, thanks, Aaron. I've used a laser before. The concerns I've always had was with the freehand systems, the accuracy, and the concern that if there's a mismatch between the pointing laser and the laser energy source itself. In your experience, did you ever have any errors in the delivery of the laser energy to the resection of the tumor?
Yeah, this is the point. Well, we didn't use a flexible fiber, but it was a laser that was delivered through an articulated arm. So, as you said, the flexible fiber, it's obviously much easier to use, but it may lack of control because its effect it's dependent from the distance from the tissue as well as from the orientation, and so we are in favor of the use of a scanning system as the one we use because you can control all the main features of the laser that you are delivering, and so you can perform the surgical task that you want to perform to coagulate the tissue, to incise or to ablate the lesion, just checking before the parameters, the different parameters that you will use during the procedure. So yeah, I completely agree that the system that we use probably it's in some way most difficult because some ergonomics problems that we were able to overcome using this new laser system, but is obviously more precise than flexible fiber CO2 laser.
Excellent.
Thank you.
Excellent. Thank you very much. So before we go to the next session, just a quick observation looking at the beautiful slide that you have posted. I think the webinars are fantastic. I think we are learning a lot. We are learning across from the globe, and as Professor Gall earlier said, that it allows even the smallest village to have the access to the toppest of neurosurgical knowledge. But in the same time, in the long run, if we don't meet and spend time together, I think that will be a shame. I think we should start to think about the future, and I hope that we will have a hybrid system where all the senior presenters have to come to a city to present, and anyone wants to come in person can come, but whatever the proceedings are free on the webinar. That's just a thought, but that way we can have best of both worlds, have our soup and the mustache. So in that note, in terms of beautiful places, it's really as we go to the next session, it's a pleasure and privilege to introduce our next chair. It's Mr. Richard Edwards. He's the clinical lead of pediatric neurosurgery and the training program director in Bristol. He was the former chairman of the British Pediatric Neurosurgery group, and so he will moderate the next session. Mr. Richard Edwards, and it's beautiful, and Bristol is such a beautiful place, and that's another place that we could hold something like this. Mr. Edwards, may I please hand over the baton to you?
Thank you very much, Naren, and it's a fantastic webinar you've organised for everybody. It's a great pleasure to introduce Professor George Jallow, who's the Medical Director of the Institute for Brain Protection Sciences at Johns Hopkins Children's Hospital and based in Florida, and is also the Chief of Pediatric Neurosurgery there, and is internationally respected and renowned for his work on both spinal cord tumors and on brainstem tumors, and has really pioneered and many of the advanced techniques that are being used today. And so I'm sure everyone is looking forward to hearing his words on the subject of brainstem tumor surgery.
Richard, thank you, Naren. It is, as you said, it is always pleasurable to be in person, just presenting, as well as having the opportunity to socialize with one another. But I think, given our COVID crisis and pandemic, webinars have filled that gap and the need for us to continue to learn from each other and to socialize. I do hope that next year, 2020, pans out. So I do want to speak about brainstem tumors as was presented. And I think, to start, I would like to share a case of a young 3-year-old boy who presented with several weeks of a gait imbalance and a 6th nerve palsy, a very subtle lateral gaze palsy that was noted by the ophthalmologist. An MRI was obtained, and you see this this imaging. There's the contrast MR on the sagittal, as well as the axial and the T2 and flare sequences. And it looks to be a tumor that appears to be well defined in the pons. And the question is what to do for this child. Is this your diffuse midline glioma or your DIPG? Is this a focal pontine tumor? And what are the next steps that one should take? I mean, one can recommend observation. One can also perform a biopsy, whether it be a stereotactic needle biopsy or an open biopsy. Should one consider a resection, or should just one treat it empirically with chemoradiation? And the dilemma came up is, what is the best approach for this child? And I think, as he presented to our emergency room from his ophthalmologist, those were all the thoughts that were going on with our neuro-oncology team. Looking at this, I think, I don't think this is your classic DIPG or your diffuse midline glioma. This appears to be more of a focal tumor. And in terms of the histology, could it be an astrocytoma? Or could it be one of the other rarer entities of the brainstem? So I think, just to share, I did recommend surgery and did approach this through the cerebellar peduncle with a tube, rather than proceeding with the open midline fourth ventricular approach to this. I felt that similar to one would performing a needle biopsy, if I was able to insert a tube down the middle cerebellar peduncle, would be able to access and achieve a resection of this tumor. And we did that with neurophysiological monitoring. And postoperatively, there was some worsening of his 6th nerve palsy, but really no facial palsy and no other new deficits. You could see the postoperative MRI. His gait did improve after the resection of this tumor, and I think we did achieve a near total resection, as one would expect in this location. So his gait improved within about a month, and his 6th nerve palsy actually improved 1 month as well. And he was back to his baseline, if not better than his preoperative condition. And this pathology returned as an ETMR, an embryonal tumor with multi-layered rosettes. It's a primitive, highly aggressive embryonal tumor in the family. Previously, prior to 2016, a classification would have fallen into the PNET or the medulloblastoma family. So, he is going on to receive chemotherapy as well with a combination of systemic as well as intrathecal high dose chemotherapy. And we'll stay tuned. So I think, again, those are the issues that can arise in the brainstem. And when we talk about it, I think, we really do need to mention about the anatomy. What is the brainstem? I would consider it's that area that measures 6 by 3.5 centimeters that comprises the midbrain, pons, and the medulla. It's really only 20% of the entire brain volume. However, it's a highly complex neural circuitry that goes through this, and more of an anatomical representation. And really, in terms of the vascular anatomy, you had an excellent lecture by Mike Lawton yesterday about the brainstem cavernomas. But I think what really recognizes that this brainstem is a highly complex and busy thoroughput. Looking at the CEPTRUS database, the brainstem tumors really comprise only 4% of all brain tumors in children less than 19 years of age. And looking at this, when you look at all the brain tumors, it's really 13% of younger children. 80% are in the pons, and the majority of which are going to be your DIPG or your diffuse midline glioma, and that accounts to about 200 plus cases in North America each year. There's a second peak in the fourth decade, and there's a slight male predilection for these. I think, looking at the history for brainstem surgery, this is a chapter by Jim Goodrich, who, did pass away from COVID earlier this year as a casualty. I was fortunate enough to have him write the opening chapter in this textbook on brainstem tumors. And you can see he actually shared his personal collection of images of brainstem tumors that were described as early as Vesalius and some of the other anatomists and lecturers early in our 19th century. Well, if you look at this, the first description really was in the 1880s. The first surgical treatment attempted was in the early 1900s, and radiation therapy was recommended in the 1950s. I think in terms of your DIPGs or diffuse midline tumors, the first report was of an autopsy in Berlin in 1880 that described it as a sarcoma with no sharp boundaries. Again, noting the difference between a diffuse tumor, infiltrative tumor versus the focal tumors. More thoughts, I think as early as 1930s, it was recognized that unless some effective treatment other than surgery, gliomas of the brainstem will be hopeless problems for treatment. And then as, again, as late as 1970s, the location in itself obviates the possibility of surgical removal. Regardless of the histology, they should all be classified as malignant tumors, since the location, this eloquent location, renders them inoperable. And they really did not make a distinction between the different parts of the brainstem, nor whether it was a focal versus an infiltrative tumor. And they, the early survival, it was somewhere between 4 to 15 months. I don't think we've made much progress with our DIPGs, but they did recognize that if a patient's alive longer than 18 months with or without radiation treatment, one should consider surgery, as it may be something different than a tumor. So, I think the surgery was first in the early 60s. However, it wasn't until the advent of CT in the mid to late 70s and MRI in the mid 80s that helped and better defined these tumors. So I think, when we look at the differential diagnosis for brainstem tumor, is it a low-grade tumor, high-grade tumor, is it midline diffuse tumor, is it an ATRT, could be an embryonal related tumor, as in that example that I shared, could it be a vascular lesion, inflammation, or could it be other non-specific lesions that can be associated with neurofibromatosis or even abscesses in this location. And I think, there's been multiple classification schemes for these tumors, but what we do recognize is that not all brainstem tumors are alike. I think, you know, the best classification I've seen really, you know, has looked at them, whether it's, you know, was it a focal, intrinsic, exophytic tumor from Epstein, Hoffman, and then in 1991 by Barkovich, looking at the location, the focality, the extent and direction of growth, the degree of brainstem enlargement, presence or absence of hydrocephalus or necrosis. I think, you know, we defined, the early pioneers defined the anatomic and radiographic classification of brainstem tumors, but it was the WHO who gave us the histological classifications, and that they were tended to be in a bad real estate and thus a grade 2 WHO. Looking at this, when we look at the midbrain tumors, you've got your tectal tumors, your aqueductal tumors, and then in the tegmental tumors in the body of the midbrain. Your pontine tumors, they could be focal, isolated. They could have an extension into the middle cerebral peduncle, or they could be your midline, diffuse midline gliomas, or your DIPGs. Your medullary tumors could be dorsal exophytic. They could be a component of a cervical medullary. They could also be a focal intrinsic medullary tumor and or a diffuse medullary tumor. And that, you know, what we do know is that your low-grade tumors typically behave much more in an indolent fashion than as compared to your diffuse or malignant tumors. And it was, you know, the WHO reclassification or supplement in 2016 modified the 2007 classification and really changed what we know as DIPGs, your diffuse intrinsic pontine gliomas, to your diffuse midline glioma that was the H3 K27M mutant type. I think, you know, this is, you know, so what is this diffuse tumor? It's really, it is what's comprised your diffuse pontine tumor. They can also be found in other midline locations in the thalamus, spinal cord, and that 75% of them have mutation on the histone H3, encoding the H3.3 isoform, and there's a less common forms as in 3.1. And what we do know is that the patients that harbor this mutation have a less favorable prognosis, regardless of what the histology of the tumor may be. And you can see, you know, where this K27 mutation does occur as compared to the hemispheric components. So going back to the signs and symptoms, I think for the malignant tumors, regardless of what it is, as seen here, I think, you know, they typically have a much more aggressive and rapid course of onset of symptoms, about 3 months. They can have cranial nerve deficits, pyramidal, and less common to have obstructive hydrocephalus. Your focal tumors, more likely to have, can present with headaches, vomiting, focal neurological deficits. They can be a longer prodrome, have a failure to thrive, and typically can have an extensive medical evaluation in these children prior to imaging. The standard, I think, is the MRI with the triplanar sequences when we look at sagittal, coronal, and axial images. I think, you know, what is classic for your diffuse midline tumors are they're iso-intense or slightly hypo-intense. They're bright on T2, and they typically don't enhance with gadolinium, and typically located in the pons, less likely to be seen in medulla or the midbrain. Looking at these, you know, we are going to talk about pediatric brainstem tumors. However, one should recognize that these tumors can occur in adults, although they tend to be more focal in adults than they do as the infiltrative tumors. So just to show some images of your tectal tumors, these are, you know, this is what your classic tectal tumor appears to be. There's a tectal midbrain tumor with some extension into the thalami bilaterally. This is an aqueductal tumor. This is, you can see, this was predominantly in the aqueduct. The tectal plate and tegmentum appear to be intact, and postoperatively, you can see that there's preservation of the tectal plate as well as the midbrain, and this was indeed an ependymoma after resection. And another focal, this is a focal midbrain tumor. This is a low-grade grade 1 juvenile polycystic astrocytoma that was resected with a tube. This is your classic diffuse midline tumor, or your DIPG, T2, the expansion of the pons, the wrapping of the basilar artery, and the minimal to no enhancement as seen on this image here. Your focal medullary tumors, this is a focal medullary ganglioma that was resected and proven on histological analysis, and within a near total resection achieved a very good progression-free survival. So I think in terms of treatment considerations, the question is, do you need to sample CSF, MRI, biopsy? Do we need other studies? Do they need CSF diversion, as mentioned earlier? And then the direct treatment options: is it a biopsy? Is it a resection? Is it radiation? Is there chemotherapy, immunotherapy? Is it local delivery? And with the new technology, a laser interstitial therapy in this. I think this is a paper. Recent paper that was published looking at CSF sampling, and that there is genetic alterations in the CSF that can help guide or help diagnose the tumor. I think this is, these are the liquid biopsies, and I think this may be the future for these. And then the question is, to biopsy or not. There's still a lot of issue for debate, especially for the diffuse tumors. For the exophytic tumors, a biopsy is not going to change much. The recommendation should still be a maximal safe resection. For focal tumors, if the tumor is accessible, no need for the biopsy, but rather go straight for the resection. Otherwise, a biopsy may help tailor the treatment course. And for DI, for your diffuse midline tumors, I think we as neuroscientists are always thriving to get more tissue and to help advance the care. I think unless it is mandatory for getting into a specific trial or a study, the biopsy is not going to change the therapy for this current patient. It will help, hopefully will help us in the future as we get a better understanding of these tumors. When we talk about biopsies, I think, what we do know is that it's a more complex area and less than your straightforward biopsies, but there's been several papers looking at this, the safety for brainstem biopsies in children. There's a meta-analysis of 735 cases with a diagnostic yield of close to 96%. Morbidity is about 7%. Permanent morbidity is less than 1%, and mortality is about 0.6%. And there's a more recent paper at a single institution just published this month from the St. Jude's group. There are several approaches. One can do a frontal via the cerebral peduncle. It is a long trajectory, but easily attainable with a frame-based system or even a frameless based system. This is the contralateral approach that was published about 15 years ago from Hopkins. And then you can always do the middle cerebellar peduncle approach from the suboccipital approach. It is the trajectory is, the length is shorter. However, it does have involves the opening of the suboccipital muscles and may be associated with some postoperative pain. A CSF diversion for these focal tumors, the recommendation is an endoscopic third ventriculostomy, and then one may consider a tumor biopsy at the same time for certain tumors. With the advent of imaging, one can use diffusion tensor DTI to help plan the best surgical approach for the trajectory or for the resection. So I do want to talk a little about monitoring if one's going to proceed with surgery. And the question is, can we really do brainstem surgery without neuromonitoring? And I think, when you look at the minefield here and, do we want to walk around there blindly, or do we want to be able to help navigate the approach? Looking at the monitoring, you've got both, one can monitor the cranial nerves as well as the cranial nerve nuclei, as well as the motor and sensory evoked potentials. And looking at this tumor here, when you look at the tumor, the location, you've got your cranial nerves nuclei as seen here that are actually being displaced dorsally from this tumor. And using the mapping with the nerve, one can map the cranial nerve nuclei and find a safe entry zone to proceed with the resection. With this dorsal exophytic tumor, as seen here, your cranial nerve nuclei are actually going to be displaced ventrally. And again, with the stimulation, during the resection of the tumor, one can map the location of this cranial nerve nuclei, and one can try to achieve a near total resection, ensuring protection and preservation of the cranial nerves. I think based upon the location of midbrain, ocular nerve, you've got the third nerve, you got motor evoked potentials for your midbrain. For the pons, one's going to identify the facial colliculus, as well as do some free run EMGs and some facial MEPs. Medulla, one's going to map the lower cranial nerves 9, 10, 11, and 12, as well as the cortical bulbar MEPs. Others, you've got your trigeminal sensory somatosensory and your bears during the resection of these tumors. And one also can do some direct stimulation of the cerebral peduncle for the resection of these tumors that are located in the tegmentum of the midbrain, as seen here. So I think, looking at this, one also has to consider where are the safe entry zones for the resection of these tumors, and this is quite evident in this, looking at the suprafascial corridor or the infrafascial corridor and identifying these cranial nerve nuclei and pathways. I think we did look at this in one of the in the second chapter of that book, looking at the safe entry zones for the midbrain, the pons, and the medulla. I think looking at the midbrain, you've got a ventral approach, an anterolateral, and a posterior approach. And I'm not going to spend as much time in this, but they are, looking at the papers, you can see all the entry zones that one can enter into the midbrain. And again, this is a paper out of Roten's group looking at approaches for brainstem tumors in children. Other approaches for the pons, again, you can see this in the illustration here, looking at the safe entry zones to enter the pons, both from the dorsal approach or from a more of a posterolateral approach. And then one also can consider the endoscopic anterior approach for the pons, as seen here. And then finally, for the medulla, in terms of the approaches, you've got your anterolateral safe zones as well as your dorsal safe zones for the medulla to approach all these tumors that can arise. So, I mean, really, I think the question comes in, what is the best approach? Is it going to be, will it be from anterior, a lateral approach, or a posterior approach? And really, I think, what can we use? Microscope, endoscope, exoscope, tubular retractors. There's no such thing as the technology advances with us. And I think, this paper from Ted Schwartz's group from Cornell, you can see that they actually approached they did an extended endoscopic endonasal transclival approach to access a pontine lesion. In their study, they found that they can access both the pons as well as the upper portion of the medulla using an endoscopic approach for the resection of well-encapsulated lesions. And then, with the endoscope, one can also approach it transventricularly through the lateral ventricles into the third ventricle to approach lesions that are in the midbrain or in the posterior pineal region, whether it be a tectal plate tumor or some of these aqueductal tumors. As I shared earlier, with the technology, we've got the tubular retractor. This was approached from a posterior parietal approach. You can see the entry site, and then the tumor, and then following the resection of this benign grade 1 astrocytoma, all from above using a very small tube, whether it be the brain path or the Vicor retractor. So I think, just as I begin to summarize, really, does the extent of resection matter, or should we just do a biopsy and recommend treatment? I think, you know, when I reviewed the literature, looking at a retrospective review of the SEER database, it's really that a more aggressive resection results in a longer survival as compared to a partial versus a biopsy for your focal tumors. And you know, this held true at 5 years. And this is the near total, gross total. This is the partial. This is the biopsy of tumors in this. Looking at another meta-analysis of close to 1,700 cases, the majority of which were your diffuse tumors, but there was close to almost 100 tumors that had a focal appearance and underwent resection. Based on, and I apologize, based on age, the older children did better than the younger children. As one would expect, you're more likely to see your diffuse tumors in the younger population. But looking at this, looking at your grade 1 or 2 tumors with a resection, the grade 2 tumors did better than grade 3, and then did better than grade 4, as would expected based on histology. And the tumors that had chemo and no radiation, I think this is a selection bias, did better than the ones that required chemo and radiation. I think, your ones that had required radiation are the ones that really are your DIPGs. So there is a selection bias, and that there was really no treatment for your diffuse tumors that underwent hyperfractionated radiation therapy versus hypo versus regular. And then, I think for chemotherapy, it's still very questionable, since most tumors harbor the K27 mutant and they show very low methylation and are not, there's no, very little response to temozolomide. High dose myeloablative and stem cell rescue has been explored, but it still remains, unproven, and recent studies have shown no clear benefit, So I think, we do have to look at this. These are some of the studies for looking at radiation with Temodar and some other pre-radiation therapy for these tumors. There are some novel agents that are being developed, and there are some molecular targets based upon the promoter. And if you look at all these agents that are here, you can still see, that there is some benefit, but there's really no cure at this time. And so I think, just to close, I really want to say that, really for DIPGs right now, regardless of the histology, it's really the molecular subtyping that determines the outcome. There's no good role for aggressive surgery for these, yet we still advocate biopsy, not for that child, but for future therapies. And the prognosis is 1 year, regardless of the therapy to date. Typically, as would expect, it's the 5 to 10-year-old, and there's a 45% survival at 1 year, and close to 50% of them are going to be will succumb to the disease. And it's really, as I said earlier, your classic imaging here, regardless of what the histology may be. Looking at the two mutations, whether it's the 3.3 versus the 3.1, you can see that as the majority are 3.3 mutations, they behave like a high-grade tumor and have a worse prognosis than the 3.1 mutation. And then really, I think just to close, we'll share this other story of this young 16-year-old boy that I took care of. Now we're talking almost 7 years ago. Really had no history presented with a 12-month history, some double vision, motor weakness, and he was found to have a tumor in 2013. He underwent a biopsy. It returned as a polycytic. The outside team placed an external ventricular drain. They ended up putting in a shunt about a week later. And then 2 weeks later, they developed another cyst. They tapped the cyst and fixed the shunt again, and that they were considering more therapy. And this was the imaging when I saw him. And knowing that this is a polycytic astrocytoma, rather than recommending radiation, I recommended a surgical resection, and he underwent the resection. And this is him about 5.5 years later, and you can see that there is probably a small residual here. but here he is at that time. His extraocular muscles and facial expression. Sorry, I apologize about that.
Now please follow my pen light.
And here's his strength.
A little bit of nystagmus. Do you see that in the movie? Mm-hmm. Okay. And a little 6 nerve palsy. You also got that?
And there he is walking. You know, he's got a little weakness, but ambulating at 6 years and no other treatment. And he's done, you know, he continues to be tumor free. So I think really to conclude, I think, you know, we have the imaging technology, I think, you know, available to us that helps, allows us to better define these tumors. I think there is a role for surgery for all tumors that, aside from your diffuse midline gliomas. There one may consider a biopsy if that's going to allow them to enter a protocol. And then in terms of adjuvant, really radiation is the mainstay for these diffuse aggressive tumors. And then chemotherapy is still not sure. So hopefully I've been able to conclude that and be available to answer any questions. Thank you. Thank you, Naren and all.
Thank you, George.
Thank you, Richard.
Richard.
Hi, yeah, that was a fantastic talk, George. Thank you so much. There's a lot of food for thought there, but looking to the future, do you think that there is going to be a role for convection-enhanced drug delivery, in particularly in DIPG as a treatment modality, or do you think we're barking up the wrong tree, as we say in the UK?
No, you know, Richard, I think you all have great experience with the convection enhanced delivery for these tumors. I think there is going to be a role. I think what we have available to us today is not working. That I know. So there's got to be a role for new modalities. And I think, honestly, I think the local delivery is the best approach for these, whether it be a convection enhanced delivery, or let's really talk about, you know, consider laser interstitial therapy or a combination of options. But the traditional therapies are not working. Radiation and systemic chemotherapy, that, you know, it buys them some time, but it's not working. So I think, you know, it's finding the drug to deliver locally that's going to be the cure for these tumors, personally.
That's great. Have we got any other questions for Professor Jallow?
And I think if I may ask a question, George, in terms of the biopsies for DIPG without being in part of the research protocol, in that controversy, do you have any thoughts?
Yeah, no, I think it's highly controversial. And I'll tell you what I tell my parents. I said, you know, I would like to do this, but first of all, I would recommend a biopsy for anything that looks atypical. So if it's an atypical DIPG, I would recommend a biopsy because I think there, you know, it could be something else. As I shared in the first case, I mean, yeah, that was a focal tumor, but, you know, clearly it was in the pons. We knew, I suspected it was going to be a malignant, but I think it was critical to get a diagnosis, so we recommended a resection. For your typical DIPGs, I still would recommend a biopsy, but I'm very honest with the parents. I'm going to say, yes, this will give us the diagnosis. If there's an open protocol, it may get your child on that study. But what I do know today is that regardless whether we know what this is or not, it doesn't change the outcome, but it may help us in the future. And I think, you know, if we don't get tissues and look at this in the laboratory, we're never going to make progress for these tumors.
Thanks.
George, do you have any comment on using IMRI versus intraoperative monitoring? And I've found in my experience, particularly for some of the lower bulbar monitoring, actually taking out the electrodes and putting them back in for an IMRI isn't really they're not compatible. And you know, I've often moved more towards you just using intraoperative neurophys for these cases, with perhaps some DTI imaging to start off with to facilitate planning. Have you got any comments on that? Have you been able to achieve both using IMRI with neurophysiology, or do you choose one over the other?
Hey, Richard, that is a great question. You know, and I didn't address it. I will tell you, I am with you on that. I grew up using neurophysiology for these, and then when intraoperative MRI became available, I said, "Oh wow, this is great! I'll supplement the intraoperative neurophysiology." And I'll tell you, you know, years ago when I did the first case in the intraop, they're like, "Oh, you've got to take your leads off; they're incompatible." I'm like, "What do you mean?" You know, and again, I was like shocked. I'm like, you know, but they said they're compatible in here. Nope, you got to take them off. So we took them off. And then, you know, the MRI was helpful, said, "Oh, they're still low residual. Let's go back and do some more." And they're like, "Well, we've got to hook up the leads again." And I'm like, "Oh my God," you know. So I did it once, Richard, and then I've never used the intraop MR. I'm strictly a neurophysiologist, because to me, that's going to keep me out of trouble. I don't think the MRI is going to keep me safe with these tumors.
Yeah, I mean, I'm definitely in the same camp as you. I don't use IMRI for the brainstem tumors. I think the tractography I found to a degree helpful. Now it's got a bit better to resolve the tracts. I found it 10 years ago, it wasn't good enough to resolve the tracts in the lower brainstem, and I think it's improved a bit now. I don't know if your experience is the same.
Oh no, absolutely. I mean, I get a pre-op tractography to help, and then that's all I do. And then the neurophysiological monitoring during the whole resection of the tumor. And then, you know, I'll do if I've got the intraop MR, I'll do the be closed and then get a post-operative MRI. But I've never had to go back in. I've stopped for a reason. And if I leave residual, it's because something changed in the neurophysiology monitoring, and it's not going to change what I do. So I agree with you.
Very good. Thank you very much, George. I think now are we any other questions from the?
I think there are comments for you, Dr. Jallow, on the chat box. But thank you very much. And any questions for Dr. Jallow, please put them on the chat box. Thank you.
I think we're now moving to the free papers. Is that right, Naren?
Yes. Yeah.
And I think our first speaker is Professor Cingulotomy from Russia on the impact of intraoperative ultrasound on the outcomes in patients undergoing seizure surgery for focal cortical dysplasia. So, Dr. Cingulotomy.
Am I visible?
Yes, yes.
Okay, great. Great. I can get started.
Please.
Okay, so my discussion of today, my submission would just be on intraoperative ultrasound use, particularly in focal cortical dysplasia in patients who are undergoing epileptic surgery. I'm originally from Zambia, but I'm studying my PhD in the Institute of the First Medical State University in Russia with the Federal Center of Neurosurgery. Okay. This slide. So I do not have any disclosures. However, I would like to pay tribute to my supervisor and professor, Professor Albert Sufyanov. He's the director of the Institute. So coming to the topic of the day, intraoperative ultrasound has long been of interest over the years. Publications have been coming forth over the years, however, not that much. Most of the publications have been in 2018 and 2020. Without taking much from other forms of navigation, intraoperative MRI and other forms of navigation, the role of intraoperative ultrasound still plays a major role. This is because interoperative MRI and neuronavigation systems still have difficulties in recognizing lesions such as focal cortical dysplasia. This is due to the difficulties in identifying tactile sentinel differences between the dysplastic and normal adjacent tissues. Take this for example. Here we have a case of a 21-year-old male who suffered intractable epilepsy, intractable seizures. The MRI showed a lesion in the focal, in the right frontal lobe with some loss of gray-white matter. A lesionectomy was done. However, it was found post-operatively that the patient still had some residual tumor left. The patient went for a re-op and the residual tumor was removed. This is another case, but in this case, the patient, who was a 4-year-old with intractable seizures, underwent same operation, but with the use of intraoperative ultrasound. In your far right, you can see my cursor, a hypoechoicity showing the focal cortical dysplasia. Post-operatively, gross total resection was achieved, and the patient went to have an Angel 1 outcome. So we're going through the different types of focal cortical dysplasias. We have the standard classification of type 1, type 2, and type 3, where type 1 is mostly derangement of the cytoarchitectic structure of the cortex, while type 2 is where we have the presence of dysmorphic neurons and also the presence of balloon cells. But type 3, that's when we have associated lesions such as hippocampal sclerosis, gliomas, and also vascular malformations. So in our center, we use brain lab navigation system and the intraoperative ultrasound. So after a craniotomy, we basically do a preliminary check using our probes, our ultrasound probes at the frequency 3 to 10 megahertz. And after we open the dura, we repeat to identify the correct location of the lesion. Okay. So after gaining knowledge of the use of intraoperative ultrasound, you find that the picture is quite clear, unlike using an MRI, which is a bit on the time-consuming side. So considering brain shifts, considering time, considering different modalities that happen in the operative room, the ultrasound proves in our case to be much more effective and efficient. As you can see, a clear imaging of the focal cortical dysplasia around the normal tissue. And lower there is you have the falx embedded with the vein of Galen. A hypoechoicity showing the ventricles. On your right there, you have your MRI depicting the loss of gray-white matter junction of the lesion. Lowerly, on your lower left, there you have your focal cortical dysplasia lesion, which is clearly demarcated. And on your right is your MRI lesion of a tumor of your focal cortical dysplasia in your front right temporal lobe. Okay. Combining this data using intraoperative, preoperative MRI imaging together with brain lab navigation system makes it possible for one to have at least real-time imaging guidance, which is much more superior. Okay. Here is just basically showing an intraoperative ultrasound examination. In this case was a case of a histological focal cortical dysplasia grade 1 of a superior, which was located on the superior frontal sulcus. Okay. Post-operatively, you could, during the course of the operation, you could clearly see the region where you have done your resection of the lesion, okay, and ultimately make a correct adjustment on how much resection is needed and necessary. So in our study, we did a retrospective study of all the cases in our center. We had 24 at the time of submission, and also we did a literature review where there were 22 cases. Gross total resection in our center was about 97.3%, which was almost the same as that which was achieved in the literature that we observed. Of course, the major type of focal cortical dysplasia that we had histologically was focal cortical dysplasia type 2. Okay. So we made a single center study of the ability of consultants, senior doctors, and residents in the use of ultrasound or intraoperative ultrasound, and believably, it was quite impressive that most of the doctors found that it was quite easy to assemble. The application of it was easy, cost of acquisition, and also interpretation. However, the learning curve of learning on how to actually use the intraoperative ultrasound for this particular pathology was quite steep. So what are the advantages? The advantages are that if you use navigation with intraoperative ultrasound, you conserve on timing. You effectively use the road mapping to effectively resect the lesion. Cost effective, time efficient, and comfortable. However, the only downside is the steep learning curve which comes to it, because most of the doctors need to learn how to use the ultrasound machine. Thank you very much.
Thank you very much. That was a great talk. I think ultrasound's one of the most underutilized modalities in neurosurgery. Do you use it more widely in your unit for other indications as well? Is it a tool that?
Actually, it is a tool that we use not only for focal cortical dysplasia. However, we use it for other pathologies and Chiari malformations, tumor resections, spinal tumors. So it's used quite widely in our center.
That's great. Do we have any other questions from the participants? Well, thank you very much for joining us with that great talk.
Thank you very much.
I'd like to introduce the next speaker, Advances in Future Perspectives of Intraoperative Neurophysiology and Neurosurgery from Dr. Dimitris Kefalos from the UK.
Hello, can you hear me? Can you hear me?
We can hear you, but we can't see you. Do we need to share this screen share?
Yeah. Can you see my slides now?
Yes, we can. If you can go to the presenter view.
Perfect. First of all, I would like to thank the organizers of this wonderful webinar conference. I would like to thank the committee as well for accepting our abstract. and giving us the opportunity to present our work. Moreover, special thanks to Dr. Herma Perez Fajardo, clinical neurophysiologist, presentation. If we look the past and how the neurophysiology major steps, breakthroughs that helped to the development of intraoperative neurophysiology. The first one was the work done by Penfield, who stimulated the brain cortex of his patients. The work of Engler, who utilized somatosensory evoked potentials during scoliosis correction surgery, and the work of Taniguchi, who developed the motor evoked potentials and made them recordable under general anesthesia. Nowadays, we have several modalities and techniques that can be used to monitor and map the central nervous system or even the peripheral nerves as well. I'm going to talk about the most important and moreover about the potential future of the intraoperative neurophysiology techniques and equipment. The first part regarding the new methodologies, there is a lot of work done regarding the intraoperative monitoring of brainstem reflexes. The big advantage of brainstem reflexes is that we can monitor the sensory part of the cranial nerve, the motor part, their nuclei, and the connections between them. Nowadays, the blink reflex is recordable intraoperatively. The H masseteric reflex and the laryngeal reflex as well. And I'm also going to talk about spinal cord mapping as well. Professor Deletis and his group developed a method that made the blink reflex recordable under general anesthesia. This is possible stimulating the supraorbital branch of the trigeminal nerve with a short train of pulses, and the response is recorded by the ipsilateral oculi muscle. If the response is not recordable with a single train of pulses, then utilizing double train can make it recordable in all patients. The masseteric H reflex is elicited stimulating the mandibular branch of the trigeminal nerve, and the response is recorded from the masseter muscle. It's a straightforward technique, easy to apply it. The only thing that you have to consider is the appropriate insertion of the recording and stimulating needles and appropriate stimulation parameters. Probably you all know the laryngeal electrode, which is used to monitor the 10th cranial nerve during skull-based surgery, or the laryngeal nerve during thyroidectomies. The same electrode can be used to activate the afferents and record the motor response from the contralateral side. So with one single method, we are able to monitor the sensory part of the laryngeal nerve and the motor part of the contralateral laryngeal nerve. In the past, there were already a couple of methods available for spinal cord mapping, but they were not very easy to apply them, or they were not reliable. And Professor Deletis and his group developed one method that can do both. Before the myelotomy, the functional midline of the spinal cord can be mapped, delivering a double train stimulation, and we can identify the dorsal column looking on the responses, and in that case, only one response will be recorded after the first strain. During the resection, when we activate the corticospinal tract, 2 responses are recordable, and they are identical. Of patients that showed double response after dorsal column stimulation, but those patients the morphology and the amplitude. And those patients were the patients who had developed spasticity before the surgery. Another interesting and promising method, but not very widely used, is the cortico-cortical evoked potentials. They are recordable under general anesthesia, and they are used to map and monitor. Grid or strip electrodes can be delivered over the anterior language area, and the response can be recorded over the posterior language area or vice versa. Thus, with this technique, we can map the language cortex, monitor their subcortical connections, and it's very important that it's applicable under general anesthesia because not all patients can tolerate the awake craniotomies. Going to the future of intraoperative monitoring, we have nowadays more equipment with more channels, more stimulation outputs, and sophisticated software that is used to do more complex monitoring with more modalities. However, on the market, you will see some surgeon-driven equipment. And the limitation with those machines is that they have limited number of channels and a limited number of modalities. And this brings a risk because the interpreter decides to interpret neurophysiological recordings. And this risk may bring catastrophic results. And this is an example which is published. The authors claimed that they had a false negative monitoring of motor evoked potentials, but actually they had a true positive monitoring. They recorded the baseline, it's the black one, the black waveform, which was disappeared after the correction of the scoliosis. However, the surgeons were looking at the responses of the upper limbs, which were preserved. They thought that the response from the legs were preserved as well. However, the patient developed paraplegia because the responses actually were lost. And a lot of letters to the editor reached the journal after this publication. The gap between the surgeon-driven systems and the interpretation of the findings most likely will be filled by artificial intelligence in the future. It's a new technology and we can see it everywhere. Probably you can see it even on your equipment for neurosurgery. However, there are concerns regarding who is going to have the medical legal responsibility and if it's ethical to let an artificial intelligence system to do the interpretation. And moreover, if you do a simple Google search, you will see that there are millions of failures of artificial intelligence now, so far. So this technology is not mature yet. To conclude, there are a lot of advances and improvements on the neuromonitoring methods. Some conditions that were not treated with the aid of neuromonitoring. The new methods allow us to do real-time monitoring. For example, with the brainstem reflexes, we don't have to interrupt the surgery. We can perform them continuously. And regarding the future of monitoring, there is a lot of research to develop new modalities and allow us to monitor and map more structures and more pathways. Close collaboration between neurosurgeons and neurophysiologists will help us to identify and prioritize the future neuromonitoring research. And moreover, there are practical and ethical concerns regarding the surgeon-driven systems and the artificial intelligence involvement in intraoperative neurophysiology. Before I finish, I'm going to sacrifice just my last slide and a few seconds to let you know that the next European Congress of Clinical Neurophysiology will take place in France next summer. And for the first time on the history of this Congress, there will be an intraoperative neurophysiology course. I am organizing this course, and Dr. Hema Perez Fajardo will be there to teach the participants as well. Thank you very much for your attention. Please let me know if you have any question, or feel free to email us for further discussion about monitoring.
Thank you. Dimitrios, that was an absolutely fascinating talk and update on interrupted monitoring. I hope George Jallo is still here. My first question, I'm fascinated by the cortical monitoring option, and looking at the slide, it would looks as though that is with surface cortical stimulation. Do you think that some other pathways, may be putting sort of fine electrodes into the white matter tracts to sort of stimulate them intraoperatively, or is that something that's going to be too risky or hazardous or not necessary? I'm thinking things, monitoring IFOF or other sort of key tracts that might be difficult to pick up, just to monitor integrity.
I'm not sure if I understood well your question, but there is an increased interest in this method, not for this particular structures only. I mean, not only for language areas, but there is increased interest on the cortical potentials or axonocortical potentials. So I think that in the near future, we will have more methods for monitoring and mapping of areas and structures that we cannot monitor now under general anesthesia.
Yeah, I think it's say almost like placing a sort of depth electrode, but a very fine one into the tract you want to monitor it, intraoperatively. Is that something that's?
I think I saw a similar concept a few days ago. I didn't have the time to read the paper carefully, and it was something like axonocortical evoked potential. So actually, they were using a depth electrode to activate the axons they were interested in, and they were recording the response from the cortex. I haven't read the publication yet, so that's why I didn't include it on this review. But I'm quite sure that we will see a lot of development in this area.
The other thing I was going to ask you about is the bulbar monitoring, in particular with reference to the sort of glossopharyngeal nerve function, because we do get patients where we've been able to preserve vagal nerve function through intraoperative monitoring, but the patients have had significant issues around pharyngeal sensation and the sensory aspects of swallow post-operatively. And my understanding is that we can't stick needles in stylopharyngeus, and there isn't really a good way of directly monitoring for that. Have you got any comments on glossopharyngeal nerve?
Unfortunately, didn't hear well your question because of interruptions. So I'm not sure what exactly you're asking, but as a general comment, I think that we are going to see a lot of improvements with monitoring using the brainstem reflexes, or even mapping of sensory fibers of the cranial nerves using the brainstem reflexes.
Right, okay. Are there any other questions from the webinar participants? I don't see anything coming through. Dimitros, thank you very much. It was a very insightful talk. Thank you for bringing that to us. Our next speaker. Thank you. Our next speaker is Dr. Daniel Kenyatta from Kenya, who's going to talk to us about the determinants of early postoperative mortality in patients with high-grade glioma in Nairobi, Kenya. Thank you.
Okay, thank you for having us. Are you able to hear me?
Yes.
Yes.
And can you see my screen?
Yes.
Okay.
You have to, that's it.
Okay, thank you. Thank you for inviting us to this very illustrious conference. We are presenting on determinants of early postoperative mortality in patients with high-grade glioma in Nairobi, Kenya. I'm currently based at the Kenyatta University Hospital, and my two co-authors, Vincent Wekesa and Pamenas Okemwa, are from the University of Nairobi. By way of introduction, we all know that high-grade gliomas have a short natural history and high morbidity. The known determinants of survival include patient factors, tumor type, and treatment variables. Of the patient factors, age is an important factor of survival, and the performance status of the patient, or the Craniovertebral score, which is what we typically use. Of the tumor types in high-grade gliomas, the neuropathologists have a grade 3 and a grade 4, and to differentiate it, they usually use necrosis. So necrosis is a factor for grade 4 tumors, and it has been shown to have a poor prognostication factors. Of the treatment variables, supratotal resection has positive effects on prognosis, and also chemoradiation according to the STUP protocol, which is what we use in Kenya. So currently the WHO has introduced IDH1 mutations, or IDH mutations. It can be either 1 or 2, to predict prognosis, and they're currently used in the tumor classification. So in Kenya, we've not yet stratified our high-grade gliomas to IDH1 mutations, and we don't know what its effect is on our patients. So the objectives of the study were to describe the patient characteristics and clinical presentations of these patients with high-grade gliomas. We're also going to describe the CT and MRI characteristics. After surgery, we were to characterize the histology, first of all, then do the IDH1 mutation status, and we were going to use that to predict 3-month mortality, early postoperative mortality for these patients. The study was a case series between January 2018 and June 2019. It received the requisite ethical approval. Our patient selection were all patients being managed for high-grade glioma at the KNH Neurosurgery Clinic. So we would select patients according to their imaging findings, but some patients who had metastases who were excluded from this analysis. The consent was by the patients and the caregivers for those patients who had reduced mental capacity. We had we met the patient 4 times. So during the enrollment visit, we would screen for eligibility. Then we would tell them about the study and then get informed consent. At this point, we would tell them that it was an observational study. We want not going to change the the standard of care at our hospital. We would get the medical history and document the demographics of the patient. We would do a physical exam and note down the performance status of the patient, and also review the CT scan imaging and the MRI. So follow-up was 48 hours post-op, just to reassure the patients and see their performance status at 48 hours. At 2 weeks, during a review, either in hospital or in the clinic, we would discuss the histology and immunohistochemistry and refer to the oncologist for Stupp protocol chemoradiation. 3 months post-surgery, it will be a follow-up phone call and a clinic visit for the patients. These are our results. We recruited 17 patients with high-grade glioma. There are more males being afflicted by high-grade glioma, 70% of our population. And we found that we had 2 peaks in our sample size, the 30 to 39-year-olds and also the 60 to 70-year-olds. So 76% of our tumors were glioblastoma multiformes. 3 were, or 18% were anaplastic astrocytomas, and 1 tumor was anaplastic oligodendroglioma. So country of origin and time to presentation. If you can see this map of Kenya, we are located where my pointer is, around Nairobi. You can see most of our patients were from counties which were geographically surrounding Nairobi. So there's a large unserved population, especially in the north, where we have mostly pastoralists, and they have to travel long distances to access care. There are currently 3 neurosurgical centers in Kenya that handle neuro-oncology. There's one in to the east called MTRH. There's us at Nairobi. We have 2 centers, Kenyatta National Hospital and Kenyatta University Hospital. And in Mombasa, they also do some tumor surgery. Though, so a huge part of the country is unserved by, cannot access neurosurgical services. Most of our patients presented, we classified it, patients who presented between 2 weeks and 3 months, less than 2 weeks, and more than 3 months. And you can see the anaplastic astrocytoma and the anaplastic oligodendroglioma all presented after 3 months of presentation of the symptoms. So these were obviously more indolent tumors, and the patients thought they had time to get to the hospital. But of the GBMs, we can see that some of the GBMs presented within 2 weeks, or between 2 weeks and 3 months. And this is because of the aggressiveness of the tumor. Our presenting complaints, 12 patients, their primary complaint was headaches. And of these, 6 of them had seizures, 1 had hemiparesis. 3 came in with memory loss, or what the relatives call memory loss, but mostly aphasia and confusion. 2 of those had hemiparesis and 1 was incontinent. Only 2 patients presented with seizures primarily. Our pre-op Glasgow Coma Scale of the anaplastic astrocytoma and oligodendroglioma, they all had GCS of 15. Most of our GBM patients also had a GCS of 15. However, some had reduced consciousness prior to going to surgery. Our imaging findings, we found that most of our tumors are found in the parietal lobe, and laterality, most were in the dominant hemisphere. Although we are learning that now the right side is also has some function. So the tumor volumes, these were large tumors that we're dealing with, more than 100 cc. with a median of 96, ranged between 18 and 300. And this was not a volumetric MRI a method of getting the volume. We were using the ABC over two method there. So the tumor margins, 10 of them had well-defined margins, 4 were ill-defined, and there was surrounding edema in 13 of the patients. We had some missing data from the imaging because some patients go home with their imaging and they lose it or don't come back with it. So these are examples of some of the tumors we had. You can see they are large tumors. This turned out to be a left-sided anaplastic astrocytoma, and it didn't have much contrast enhancement. There are little nodules which were contrast enhancing, and it involved large portions of the temporal lobe and the orbital part of the frontal lobe. Second type was a glioblastoma, IDH wild type, and you can see it has the classic ring enhancing lesions. And this one was found on the left parietal occipital region. The third was a glioblastoma that was actually IDH mutated, so secondary glioblastoma. It had ring enhancement on CT scan. It involved parts of the temporal lobe and the parietal lobe, and this was our results for the IDH1 mutation status. The more indolent tumors, the anaplastic astrocytoma and oligodendrogliomas, were all IDH mutated. We only had 2 GBMs which were IDH mutated. All the rest, 9 of them, were wild-type tumors. And these are some of the examples of IDH mutation status. You can see the stain in the brown stain confers the specimen to be IDH mutated or not, and this was the anaplastic oligodendroglioma. You can also see the fried chicken appearance on histology that's been described as characteristic of oligodendrogliomas. We had the IDH1 mutated GBMs. You can see the tumor cell right there is taking up stain. We also had wild type GBMs, and this was an IDH mutated anaplastic astrocytoma. So early postoperative survival, we had 7 patients who are alive at 3 months. 8 had died, for 47% of them, and 2 are lost to follow-up, could not reach them. But we can see that most, in fact, all our deaths were in the glioblastoma multiforme group, and in that category, it constituted 61% of all GBMs were died by at 3 months of follow-up. This was a chi-square. I know our sample size is small. We shouldn't draw a lot of conclusions from this analysis. But what we found was that 76% of our tumors, high-grade gliomas, were GBMs. 18% of our GBMs had an IDH1 mutation. Our independent predictors of mortality within 3 months of postoperative period were presence of edema on imaging, the tumor grading, grade 3 tumors, the anaplastic astrocytoma and the anaplastic oligodendroglioma fared much better than the GBMs. And the wild-type tumor on immunohistochemistry predicted mortality. We also found that there was increased mortality in tumors of the parietal lobe, and since most of these were on the left, could be our surgeons didn't they didn't do full resections to preserve function. We also found that IDH1 mutation was associated with increased likelihood of survival 3 months postoperatively. So thank you for your attention. This is where I'm practicing neurosurgery. It's called the Kenyatta University Teaching Referral Hospital. And we welcome you anytime you're in Kenya. Thank you.
Thank you. It's a great presentation and good to get a global perspective on the challenges we all face, I think, in high-grade glioma surgery. I did note that the 3-month mortality was quite high. Is that, but looking at the tumors you were showing, they were very large. Do you think you have problems with late presenting cases as well, Daniel, in Kenya? Is that cause technical challenges for you?
Yeah, so our CT scan era has been only in the last 10 years, almost 10 years, yeah. So we still have problems with access to radiological services. And you saw that many of our patients come from the geographical area around Nairobi. So we still have problems with access to healthcare. And some of the patients, when they present, the tumors are very large, but we can't draw the conclusion that it's late presentation that is causing us to have such large tumors. I think we might be having a different type of disease in Kenya. We are seeing earlier presentations of more aggressive tumors than what is described in literature. And so we want to pursue this question further and you know, to see our demographics. Why are we having earlier presentations than what is described in literature? Yeah, so it could be the tumor dynamics. It could also be the access to healthcare. That's why we get such huge tumors. And also surgically, we don't have adjuvants to help us. We don't use neuro monitoring in our surgery. We don't use intraoperative imaging. So we have to rely on descriptions from the older masters on how to do resections. Like temporal lobe, Rasmussen has written extensively on the anatomical landmarks that you have to know when you're doing a resection of the temporal lobe. So maybe in the next few years we might join we might join you guys in our operative operative experiences.
We've had the privilege of having many of your trainees come over to our institution in Bristol, and I have to say they're very well trained, Daniel. So you know, I think there is a bright future for Kenyan neurosurgery going forwards.
Yeah, thank you.
Naren, are we ready for the final speaker?
Yep, Professor.
So I'd like to introduce a friend and colleague, Professor Andre Grotenhuis, who's the Professor of Neurosurgery in Nijmegen, former President of the EANS, and he has a huge wealth of experience in neurosurgery, and it's a real privilege to listen to him speak to us on third ventricular tumors. Andre, thank you.
Well, thank you so much, Richard. Good seeing you again. And I quickly start sharing my screen. And you see on the number of slides that I really have to go on forward. Indeed, I will address the tumors of the third ventricle, and then not only doing endoscopy, because people always associate it with me, but just discuss all the different surgical techniques that we have for those lesions. This is the outline. I think it is always wise to very quickly recapitulate the anatomy. and imaging. Some types of lesions that you typically see in different parts of the third ventricle, or to say different parts of the third ventricle. It's such a small structure, but then also in different age groups, and then the different approaches. So this is the outline. Anatomy is rather straightforward. I think everyone who participates in this course knows such pictures. We all know where the third ventricle is. But we usually see it when it is enlarged or when there is something happening with it. Usually it is a very small, more or less slit-like cavity. And the thalamus and hypothalamus are forming the lateral walls, and in the posterior wall and so here caudally, it ends up in the aqueduct. So here you see indeed how close everything is nearby. So third ventricle is surrounded by some really important structures. The roof that we not easily can see, but sometimes have to pass through, is formed by the pia and of course the ependema of the third ventricle. And that stretches between the two striae medullaris of the thalamus. And it's therefore it is the so-called dorsomedial border of the thalamus. Again, you heard me saying for the 5th time the word thalamus. That is really where we have to deal with and where we have to think of when we discuss the third ventricle. Typically in the dorsal parts, and more anteriorly, we have on both sides a foramen of Monroe. And that is between the column of the fornix and again, anterior part of what? The thalamus. That is third ventricle. So therefore we will have to deal with this. I think very briefly and quickly to say, because when I discuss tumors, vascularization is important. And that's not so difficult. Some people find it difficult, but it is not. Actually, you only have arterial supply coming either from the anterior part, so the anterior carotid artery, offspring of the carotid, internal carotid artery, or of the posterior and medial carotid arteries, and they come from the PCA. So this is a lateral aspect. It's more easily maybe to see it from the superior, so look from above, like we do in many surgeries. Then you see that this medial, so in the temporal part, that is where the anterior carotid artery goes and supplies the choroid plexus. And then the medial and posterior is supplying the more medial parts and posterior parts. I mean, therefore, the anatomist has named it not, and with a reason. And there are also, of course, some junctions here and also some anastomosis. So this is it's a quite good supply. But surgically, to be very honest, if you deal with this region, at least for me, that personally is the veins. The veins are even more critical structures when you deal with intraventricular lesions, be it lateral, fourth ventricle, or third ventricle. And also that is not so difficult. Laterally, so from the temporal horns, it all drains into the basal vein of Rosenthal. That's this one here. And medially, so from the septal artery, thalamothyrioid veins, they drain into the internal cerebral veins, two of them on both sides, rather medially located in the tila. And they all join here, the basal vein of Rosenthal, internal cerebral vein, they come here and join into the vein of Galen, the big vein over there. So if you just think of that, and laterally also, if you see here, I will discuss that later on, the anterior septal vein goes into the internal cerebral veins. That's from all of these veins that you can see in the atrium, occipital horn. The only difference is from the temporal horn, so hippocampal area, that drains into the basal vein of Rosenthal. So if you just catch these principles, that's not so difficult. So you can easily keep that in mind when you have to deal with lesions in that region. And here is the same a lateral view. So the anatomy, if you just dissect it in the anatomy lab, it's a kind of cutting it all off. In endoscopy, you start traveling through the anatomy. So if we do that in the anterior and middle portion, typically at the foramen of Monroe, what we see, where we have to look for, are the mammillary bodies. Not always so obvious as we hope that we will see, because some of these pictures are from anatomy, and so it is not an enlarged ventricle. If it is stretched out, it becomes more easily recognizable. So this is anterior part. Here you see the mammillary bodies, then the infundibulium. Here you see already the chiasm, and here the area of the lamina terminalis. That's not something you see easily in a patient. So again, if we look to that, this is what you see during your surgery. The mammillary bodies, typically you see the vascularization, especially in neonates and infants. The mammillary bodies are not so well recognizable, but at least you see the vascularization, so you know where it is. This whole area here is the tuber cinereum. So this is the infundibulum, so they did this actually the start of the pituitary stalk, and this is the infundibular recess that runs below the chiasm, and that is the pituitary stalk. These are the structures that you recognize or should look for when you use an endoscope. If you use a 30-degree endoscope, you see a little bit more. Again, we have here, because this is in a very young patient, the mammillary bodies, again, tuber cinereum. You see the infundibular recess here, the optic chiasm, but now you also see the lamina terminalis. And the lamina terminalis is also an important structure when we discuss surgery of the third ventricle. And above that, that's the anterior commissure. And if you go back, we look and we see one of the big structures here is the posterior commissure. But now I have to point to some just for you to think of that. Usually you see that in the surgery upside down. So if you go with an endoscope inside, the roof is upwards. Here it has changed. Here it is reversed. But then you see the aqueduct, you see the posterior commissure, then you see the pineal recess, and then the suprapineal recess. In between, we always, during courses, call this the third ventricular diamond, because it has a bright yellow color in the human. That's the habenular commissure. So that is brief, that's anatomy. And I hope that everyone ever considering attacking a lesion in the third ventricle is very familiar with this. Fortunately, we have good imaging techniques. I mean, the MRI scan will not leave any doubt where all these structures are, because if there is a tumor, they are displaced. But if you see this drawing here, this is more or less the same slice on an MRI scan. Take your time and really study that. See here, infundibulum here, the recess for the optic chiasm. Here is the anterior commissure, that's high. Mammillary bodies, aqueduct, so posterior commissure, pineal, and then here over the internal cerebral veins, below the corpus callosum, and here we have the velum interpositum, and you have the tila choroidea. So all these structures, and everyone knows the name, but they are recognizable in scans. So please study that carefully. That's always the first step in any surgical approach to the third ventricle, and in anything. So easily coronal, you see all this very nicely, the structures here. You see here the fornix where the asterisk is. And so this is really something you have to study. The floor of the subventral tuber cinereum. Again, this was a little bit widened infundibular recess here. So all these structures are visible. Now we come to it. It's amazing to see how much different kind of lesions can occur in the third ventricle. And therefore I said it is such a small structure, but nevertheless, just from a practical and surgical standpoint, you divide that in the anterior aspect, very front of the third ventricle, and very back part, posterior aspect. Then you should see if it is at or in or below the floor, or it is at the foramen of Monroe, which is a very typical location actually, or if it is just filling up that ventricle fully by itself, by the lesion. So anteriorly, if you really look to only anteriorly, these are, for example, a hypothalamic chiasmatic glioma, any cellular, supracellular lesions, a pituitary adenoma progressing into that area is always in the anterior part. Purely posteriorly, typically, we have the pineal lesions, and the lesions, the tumors of the tactile plate. But also, and I told you, the thalamus is there, so the inferior and also posterior thalamic tumors, or originating, for example, from the pulvinar, they can protrude into the posterior part of the third ventricle. So that already brings down the differential diagnosis. In the floor, at the floor, below the floor, typically think of, if it is a young child and has seizures, hypothalamic hematomas. It even could be an aneurysm bulging from below into the third ventricle. And classically, and I mention it here because this is a real treatable disease endoscopically, the suprasellar arachnoid cyst. At the foramen of Monroe and in the anterior roof, we see colloid cyst. We see the subependymal giant cell astrocytomas, which are typically associated with tuberous sclerosis, but also the subependymomas. So you see a lesion there, think of these three possibilities. And then filling up the ventricle could be, it could be a papilloma, it could be metastasis in adults, lymphomas can filling this up. It could be vascular malformations, could be cavernomas, it could be large intraventricular cysts, and actually any other kind of, there are much more possibilities. And then of course, you know the age of your patient, and then you realize that if it is a pediatric patient, think of a germinoma in the anterior part. Typically, if you see a lesion in the posterior part and simultaneously in the anterior part, very brightly enhancing on contrast, it's a germinoma. Pilocytic astrocytoma is more frequently in the pediatric age group, craniopharyngiomas. But also if it is in the infundibulum or extending from it, think of a Langerhans cell histiocytosis. In adult patients, could be metastasis, sarcoidosis, meningiomas growing in that area. I will show one example. So metastasis, adenomas. So you see in the different age groups, there are different diagnoses. So you have that age group and exact location in the third ventricle. Just some examples. So here, well, this is, I think this would not be a quiz. I mean, it's a colloid cyst. If you see this here, it is at the foramen of Monroe. This is a subependymal giant cell astrocytoma. You see other lesions here. This is a rather solid astrocytoma here. But this case with a young 32-year-old lady, this is a meningioma filling up the whole third ventricle. This here and below is a teratoma in a child. You see it in the MRI scan, that's a child. Teratoma. So you see different lesions on different locations. Such a lesion, no, that's not a typical colloid cyst because it is a little bit backwards. And also this is a 69-year-old, and this is what I told, this is the basal artery aneurysm protruding and pushing into the third ventricle and giving this obstructive hydrocephalus. So many other things. This is a pilocytic astrocytoma. You have most different lesions, cystic lesions, but it is not that difficult to already have an idea about what you are dealing with. In the posterior part, what I learned from the pineal, they all are much more alike. It is very difficult to see it only from the MRI scan, because this was a germinoma. This was a papillary tumor of the pineal gland. It's an intermediate grade. Glioblastoma, pineocytoma, again a teratoma, choriocarcinoma. It's difficult to only see it from the imaging. So now the surgical approaches. They are challenging. Why is that? Because if we have to approach the third ventricle, we more or less always need to use some kind of brain tissue incision, maybe with the exception of the lamina terminalis approach. You only have to open that membrane, or if you go to the pineal recess, which is, I only have seen such a case by Professor Konovalov from Moscow, operating a colloid cyst from posteriorly through the pineal recess. Well, then you don't go through the brain tissue. Usually that is necessary. And therefore, there are not always easy approaches, simply because I told you the structures around the third ventricle are very eloquent and critical structures. So how do you choose that? Of course, it is the site of the lesion, the extension. If it is only a smaller lesion posteriorly or anteriorly, that will give different approach. Also, it makes a difference if there is a hydrocephalus, yes or no. And therefore, I started with this whole list of possible lesions. You have an idea of the histopathology. And if you have that, that also can give a reason for a certain approach, yes or no. Think of the vascularization. If it is highly enhancing, think again of when it is located more laterally, it will have a supply from the anterior choroidal artery. If it is more medially, it will be from the PCA branches coming off. And of course, if we have to make incisions in the brain, we have to think of the hemispheric dominance. Open approaches, which are still the mainstay in lesions of the third ventricle. Typically, I divide them in three parts. So approaches anteriorly, posteriorly, or inferiorly. They are not very frequent, to be honest, but it can be. You can use it subfrontally, frontal-laterally, and go from below and from the side into the third ventricle. But anteriorly, typically, it is the either through transcortical or transcallosal. And posterior, the same. You can either go transcallosally or interhemispherically, occipital transtentorial, or go supracerebellar and infratentorially. So these are the typical surgical approaches. How do we select them? First of all, think of do no harm. So you have to think about the approach that will avoid as much as possible any injury. So that means not incising large amounts of brain. And also avoid as much as possible brain retraction. Because I told you, if you are working the third ventricle, if you retract, it is already damaging or possibly damaging the thalami on both sides. Think about the feeding vessels. So if it is coming from the anterior carotid artery or being from the posterior medial artery, this will, because you have to be able to access those arteries in case of very vascularized tumors. Shorter distance is a typical neurosurgical axioma, but that is not always necessary. Sometimes a somewhat longer approach will still give you better access to it. And think of it, if you presume that this is a malignant tumor, you better think first of biopsy to see, or if you think of a germinoma, sometimes it's not even necessary to do a biopsy. As I told you, the origin of the blood supply, the hemispheric dominance, we usually, well, in most patients, we will then use the right-sided approach, but there is a problem of so-called crossed hemispheric dominance, and about 20% of the patients have that. And especially if that is the case, transcallosal interhemispheric approaches should not be used, because this will have difficulty because there is a crossed dominance of damaging that. And of course, if the ventricles are very large, this often provides the best opening to the lesion itself. And the size by itself it can be important if it is very large or very small. And maybe that's always one of the things that is not mentioned very often in literature, but it's also about your own surgical experience and maybe even your preference in feeling comfortable. Don't underestimate that. As a surgeon, you should also feel comfortable dealing with the venous structures around the pineal gland. Many surgeons don't like that, but it is not so much more difficult than in the suprasellar area. So but it depends. It's a personal preference. Transcortical approaches, patient is always supine. Make sure that the head is somewhat flexed, and especially, well, you fix it in the 3-head-pin, but of course in infants you can't do that. It's a right frontal approach. We approach then, if you enter that's usually the superior frontal gyrus. You make a small cortical incision. What I prefer to do is first puncture with a needle or a catheter the front ventricle, but not releasing too much of CSF, and then follow that to get access to it. I don't like the very big portal systems that they have nowadays, because when they are finally in place, it's nice, but placing them is quite a damaging procedure. And of course, you have to identify the anatomical landmarks. Foramen Monroe, if you see that, we come to that later with the transforaminal approach. Transcallosal approach are still, for the third ventricle, a very, very frequently used approach. Positioning is more or less the same, although I know some surgeons who prefer a little bit more lateral turning the head to allow gravity to let the cerebral hemisphere fall down a little bit. But many others like exactly in the midline to more easily recognize the structures. That approach is a little bit behind the coronal suture, and it should be really exposing fully the sagittal sinus. That's the essence for me, at least. I make burr holes on the sinus, and not, as I learned, on both sides of them, but on. And with the Hudson perforator, you don't have to worry about that. And then I freed it, but I use a high-speed drill or a runger to to get small pieces of the inner table away so that I really fully, and for its full extent, see the sagittal sinus, because the dural flap needs to lift up also the sinus. If you have swollen brain, because it is a big lesion, therefore the lateral side should be at least 2.5 centimeters, because from your lateral edge of the craniotomy, you can then perform a ventriculostomy. And that's rarely I have had to do that contralaterally because it was impossible to do. You reflect the dura over the sagittal sinus and then have to look for the bridging veins. Fortunately, we have MRI scan, we have an idea where they are, and sometimes you have to make several cuts in the dura to leave a small sleeve of dura over the cortical vein to really cover that and not damaging them. Retraction initially will be necessary if you go to the corpus callosum. I learned this little trick of placing big cotton balls anteriorly and posteriorly between the brain and the falx to keep that space open. Sometimes the cingulate gyri are a little bit fused, so but don't think, and it's very easy to know that you are not at the corpus callosum, because the corpus callosum is bright white structure. It's not the creamy color of the brain. So if you still see that, that's the cingulate gyrus. And you have to see both pericallosal arteries. You can either choose, depending on their location, to move them both to one side or to the other side, or split them into two and put them to both sides. I'd never place a retractor there, not where the arteries are. Incision in the corpus callosum is about 2 to 3 centimeters, and sometimes you are not immediately aware in which ventricle you are, either the left or the right. But it's easy to find your way, look for the choroid plexus, follow veins, and then you know if you are in the contralateral or ipsilateral vein. And then again, you have to identify the landmarks, and the landmarks will guide you from the lateral ventricle to the third. We are now dealing with third ventricular tumors. So then the lateral ventricle still has normal anatomy, and you recognize that. So patient positioning a little bit elevated, this will relax already the brain. This is a typical incision for transcallosal, a little bit behind the coronal suture. And of course, if it is right-sided, on the right side, the incision is longer than on the left side, but it allows to anteriorly push the scalp about 4 to 5 centimeters. And as I mentioned, the arteries, you can split them and push them to both sides, but you see initially the retractor, you don't need a retractor if you have the cotton balls here when it is finally open and when the CSF is out. Then you don't have to have this problem. You look for, if you see the choroid plexus, it is following the choroid plexus and veins anteriorly, and you will always come where they confluent, where there is the foramen of Monro. Sometimes that can be a small foramen of Monro. If that is the case, you should be able to enlarge it, but we will come to that later on. So it is a small area. You don't have a lot of space, but you can, here you see the septal veins, foramen of Monro, and the tumor protruding out here with this possibility. If you want to enlarge that foramen, what I do is fenestrate first the septum pellucidum widely between the veins, or even coagulate one of the septal veins, because then you can see both foramina, and then you can also start enlarging them. And that is by, usually I really coagulate and divide the anterior septal vein, and then open the choroidal fissure, and that more or less doubles the size of the foramen and gives really a wide approach to through the roof of the third ventricle onto the lesion. It has been described that on the right side you can incise the column of the fornix, but I'm not in favor of that. That is, I'm not sure that that is without a consequence in all cases. I'm absolutely not sure, because we never know what the lesion already has done on stretching both fornices, for example. The transcoroidal approach is not really difficult. We know that the fissure is underlying, it is based on the name, the choroidal plexus. So it is between the fornix and the thalamus. And it is not difficult microsurgically. I also have developed an endoscopic technique, but it is technically more difficult to do so. And you do that, you open the attachment of the plexus to the fornix first. It's called, the attachment is called the tinea. So it is tinea fornicis. And you begin always at the posterior edge of the foramen. You will then come to layers, and sometimes compressed layers of the tila, which is the roof. And you then can push the fornix somewhat to the opposite side. Below the tila should be another arachnoid layer of the velum interpositum, but especially with tumors, it's not always recognizable. But you have to realize that immediately with the arachnoid of the velum, you will have both internal cerebral veins, and they are unforgiven. So really never, you can't sacrifice one of those veins, never. So the interphonicele I will skip because I never do that. And on drawings, it looks very nice to split both columns, and you see the drawings of the psalterium. But to be honest, anatomically, I think you will have a damage of both fornices more or less surgically. So that is the reason I'm not a fan of the interphonicele approach. So some advantages. In the transcallosal approach, we have a constant anatomy. The anatomy is very straightforward, and the distance is shorter than from a transcortical. And you don't make a cortical incision. However, at least in my hands, I don't like the transcallosal approach for very large tumors, filling up the whole third ventricle. If you divide draining veins, there is always a risk of venous infarction, and that has very severe consequences. And sometimes just only by compression in that area and your dissection and manipulation, you can have transient hemiparesis. Pericallosal artery injury is also unforgiven. That's a permanent deficit if you do that. So now the interhemispherical transcallosal approach, more from posteriorly, that's rather similar, but it is more posteriorly. And I do that for lesions in the third ventricle, also involving, for example, the splenium. If it is really involved in that, the interhemispherical transcallosal approach is a very nice way to do that. So furthermore, it is more or less the same as in the anterior. Approach of that is that in the posterior part, we don't see a lot bridging veins blocking our entrance. That's a good thing. And you have, if you use that approach, a good view of lesions that really involve the splenium. So if there is an upward growing of the lesion, this is a nice approach to do. But it means it is not an occipital approach, it is parietal approach. So if you have use a lot of retraction, you can cause neurological deficits, hemiparesis. If you do this very excessively, you can even damage a more anterior located bridging vein. They say that section of the splenium, and especially if you put this a little bit more forward to the posterior corpus callosum, you see hemialexia, or the so-called disconnection syndrome. And if you have thrombosis, you can even have a devastating blockage of the vein of Galen. So these have quite some potential risks, the approach. Occipital transtentorial approach, yes, that's, you can use the sitting position. In my country, the sitting position is not very much in favor because the anesthesiologists usually refuse to do that based upon the risk of pulmonary embolism, air embolism. But one of the other nice, and I will show one example, is the 3/4 prone position with the operative side down. Well, the skull incision nowadays that I make is a straight incision, so I don't make a flap like formerly did. But again, very similar here, you need to expose more or less the torcular, so the sagittal sinus and a little bit of the transverse sinus. So if you see that, then you know that you are really in the lower part, and that's important because in that area, after you open the dura, you will see that there are no bridging veins here. That's the good part of it. So you can easily, you follow the tentorium and the falx on both sides. And that's an easy orientation. Okay, people will say I use navigation so I know the direction of to do that, but anatomy guides you very nicely to that. And then you can open the tentorium from below, cutting it upwards. I don't never open it from upward and going down, because sometimes you have some aberrant venous sinuses, and it can be quite some torrential bleeding if you don't take care of that. And if you have then that medial flap, you can either use sutures to hinge that up, or you coagulate those flaps and they shrink away and open your view to the top of the cerebellum, and also more into the cistern. I usually start indeed the dissection near the cerebellum, because then you identify early on the precentral vein. That's the only small little vein that you can coagulate and divide without any problem. But after that, you can more easily retract the cerebellum or let that collapse and then give wider overview of the posterior pineal region. So for pineal region tumors, I like this very much. It is also for the surgeon is a comfortable procedure. You don't need a lot of retraction, maybe only in the beginning to expose the cisterns, but you have a really wide and nice exposure, as you will see in the video in a minute. The deep venous structure, however, can be displaced, vein of Rosenthal, vein of Galen, internal cerebral vein. So sometimes that can be a little bit difficult. And you should not have continuous retraction on the occipital lobe to avoid hemianopia. So some examples of this. So this is a 4-month-old boy with this lesion and a huge hydrocephalus. Well, I think when we discuss this is filling up the third ventricle, but it is protruding through the foramen of Monroe. It has a huge hydrocephalus. So this is easier to approach, especially in such a young child, not transcallosally, but through the widened ventricle. Let me see if the video will work, and we'll quickly skip this. So this is a micro. You see there was even a little bit septum of the cavum of the septum pellucidum, but this is a typical appearance of a quadriplexus papilloma. You look here. You see here after opening also the septum, this cavum. You see, this is typical. This was the plexus that you saw of the lateral ventricle. This is the appearance of the papilloma that you can see here. Let's proceed a little bit quicker. In such a lesion, it is about coagulating and shrinking. Shrinking the tumor. We will do that more and more. And then by doing that, you find your way around it. There is no reason to do this, to try to do an arm block resection. You want to do this piecemeal, but of course, therefore you need coagulation. Where is this coming from? Well, this has indeed the supply coming from the medial choroidal artery. So that is more, it is actually posterior located. This has no supply from the anterior choroidal. So you have to know where you will find that in maybe also the roof of the third ventricle. There will the supply come from, because this is choroid plexus in the third ventricle means it comes from the roof. It's not from the floor. And you see the structure, so that at one point when you know that was already, maybe I quickly do it again here. Here is the vascular supply, there it is. And then when you have divided that, it's easier to then finally to have the remaining part after some, you can remove it. That was with shrinking, partially removal, and then after cutting, coagulating, cutting the vascular supply in the roof, you have completely freed the tumor. You can check here, thalamus right vein, septal vein, and you look into here, aqueduct over there. So you check for complete removal and also hemostasis. Make it a little bit quicker. One of the difficulties is that by releasing so much of CSF, the brain collapses. It is very tough, but therefore the head is elevated. You try to avoid pneumocephaly, but that is not always easy to do in such cases. As you can see here, there's quite some air entrapment, but still the child was doing perfectly well. And this already proves the total removal of this lesion. And it was indeed a grade 1 papilloma. And it's amazing how these little children, these infants, do well. This is a discharge. You even can see here the scar it heals so amazingly well in smaller kids. And this is the boy at a control visit a few months later and doing perfectly well. The occipital transsensorial approach I want to show you, this was a growing lesion, and first it was 8 millimeters, then 9, then 11, and then 14. So this is not a benign pineal cyst, also somewhat blocking the aqueduct, but not yet really a hydrocephalus. So that's an easier approach. This is the 17-year-old. I will show you the positioning quickly. Yeah, come on. This is the approach. Oh, I'm sorry. We go back. This was not well done. This is the approach. 3/4 operative side down. So we approach this from this side here. So this occipital lobe will already fall away. You see here, I use a straight incision, and as we do in neurosurgery, that's here you see a retractor first to allow opening the arachnoid. It's a little milky, a little bit more sticky arachnoid than you see anteriorly. As I mentioned, this is you already see here this little bit opening in the lesion. Quickly do this, cutting the tentorium a little bit wider, and then you can, at that point, you see there is no retraction inside. So because of the 3/4 prone operative side down, the occipital lobe falls away and you have all this space here. So this is the lesion. We get it off here. This is tectal plate. You get the lesion off. And then we go a little bit more, let's say, laterally. So you dissect the lateral aspect of it. It's partly cystic, so it's just easier to empty it. And then here you will then come into the third ventricle. And because if you open that, you know you have reached the full lateral extent of the lesion. So all this is rather straightforward. I mean, this is not different from any other kind of dissection that you do, the superior part below. You don't need to split the splenium for this. Splenium is not even really visible here. It must be in this direction, but it is not necessary to expose it even in such a lesion. So this is then the tumor. As you can see here, this was indeed not a pineal cyst, but this was a pineocytoma. And this is all you need, and you see this is, you don't need retraction. Nothing happens to the occipital lobe, not even to this little vein here. We call it usually in this area, we do a thumb size craniotomy. So it is really the size of the upper part of your thumb. This is all you need. So this is the thumb. This is all you need to get this exposure. Well, closure is straightforward to you. So preoperatively, you see the lesion. Postoperatively, fully open aqueduct and complete removal, as you could also see from there. And the same here in axial views. If we now finally go then to the endoscopic approaches to end up this, an endoscopic approach is always a transcortical approach. If we think about endoscopic approach to lesions of the third ventricle, we rather discuss biopsies or partial removals. Very rarely we are capable of removing a tumor completely. And the handling, as you could see now microsurgically, is different when you do endoscopically. We don't have the same possibilities to do that. And we work, we don't remove the CSF, we work under the fluid, inside the fluid. So little bit of bleeding already diminish the luminance, the clear view, your image. So that really makes endoscopic management of tumors of the third ventricle more difficult. When could you consider that? Of course, only if there is hydrocephalus, at least for me. If you really have a lesion in the third ventricle, the hydrocephalus will help you in this. It's also easier if it is in the anterior part of the third ventricle, especially located at the foramen of Monro. Think of a colloid cyst, for example, or it could also be at the floor, an hypothalamic hematoma. And if the lesion is less than 2 centimeters, anything larger than that, I will not consider or even try to remove it completely with the endoscope. And at least it should be soft, preferably soft tumor, and hypovascular. We can't deal well with a lot of bleeding in tumors. And at least the majority of the tumors should be inside the ventricle and not protruding too much underneath the ependema. So these are some of the examples that you can see here. This is a subependymal giant cell astrocytoma. Actually, this teratoma that was completely avascular could be removed endoscopically, but the image will not tell you that it took 7.5 hours to do so. So colloid cysts are typical lesions that we can do. By saying so, these are not good examples of doing endoscopic approaches. And I think that that is rather obvious for all of you. I want to give you some tips and tricks for using an endoscope. Don't make it one of the first cases you do with an endoscope. You should already be comfortable with ETVs, with cyst fenestrations, with just the whole handling and tissue handling and doing this before you ever consider approaching a tumor. Planning is even more essential, the best possible approach. And often, if it is in the third ventricle, your approach with an endoscope is much more anterior than you would maybe think of, because then you have the good view into the third ventricle. So that is not at the coronal suture. That is typically more anteriorly. And for that reason, you should use image guidance to calculate that. And it is not a short procedure, I can tell you. Endoscopic removal of a tumor is piecemeal, little bits by little bits by little bits, and can take for very, very long. Biopsy, however, is not so difficult. That's, for example, in such a big tumor, we wanted to see if this is malignant, yes or no. You see already that the aqueduct is at least more or less filled. We already did the third ventriculostomy, because that is one of the advantages of the endoscope, that we already here we can deal with the hydrocephalus. But let me do this quickly, because everyone knows an ETV now, it's pulsating. But tumors, if you see the tumor, this is not very vascular. Nevertheless, if you see small vessels, then you should coagulate. But don't take the biopsy from the area where so don't pick the coagulated part. So you really go in, but now you go deep inside. You get the tissue out of the middle of the tumor. And what happens? It will bleed a little bit. Yes, it will bleed. You see the rinsing here? You see rinsing? You take more biopsies, because you think I have a chunk, but to be honest, these are still only tiny, tiny tissues. So this proved to be a papillary tumor of the pineal gland of intermediate grade. And you can coagulate it. It's not that easy, but you see it is somewhat blurred already, simply because all these little tiny bleedings can do that. But you want to see that here you see it, you have taken a real biopsy. So not a little piece, you have multiple pieces, and to be sure that you have the greatest chance of really having a good pathology, and that you know what you are dealing with. The last case then is a colloid cyst, which is, I think that everyone, these are rare lesions, strangely enough, but everyone likes them. Colloid cysts come from the roof of the third ventricle, so they push the choroid plexus out of the third ventricle into the frame of Monro. So you have to coagulate them here. This is on the left side sometimes, rarely. Look where the foramen is largest. We will coagulate the plexus. You see small cystic lesions in the plexus every time. That's not a big deal. But here, this is choroid plexus of the lateral ventricle. What we are now coagulating is already from the third ventricle that was pushed by the cyst into the frame of Monro. And after coagulating that, you want to divide that. So make it similar. Just a few same examples. Then you open the cyst, and one of the problems, you cut the choroid plexus. So really, because then you can scrape it more or less off the cyst wall. So then you have here septal vein, choroid plexus, and then with the cyst wall opening, in endoscopic approach, it is more or less inevitable that you will have some spilling, because this, you see, this is tedious. This is why it is called colloid. This is like, look here, like the glue. It's gluish here, and you open that. But sometimes you have to change for the instrument, and then it's inevitable to get some spilling of the content. And I think we will see that, yeah. Excision of the cyst wall is by a kind of, it is kind of arachnoid dissection. You bring it, you see some spilling here. That's the thing, but in more than 90 cases, only one case of a chemical ventriculitis. When you bring it into the foramen, so you bring the cyst into the foramen, you can coagulate this area here. You can coagulate the area and then cut it finally. So at the end, you remove the, probably, yeah, well, it's about the total removal. But afterwards you have to inspect the ventricles. Because I had one case of a hydrocephalus because of some debris blocking the aqueduct. So here we look into the third ventricle to ensure that the aqueduct, posterior commissure aqueduct, is free. Then I know it's fine. This is the roof. You see some blood clot here on the roof, but that's not a big deal. Always check, and if you are anteriorly, that's your straight way from your borehole looking to the aqueduct. So finally, you want to have a total removal. That's it's not leaving a remnant and only opening the cyst and removing the cyst. Solid tumor resection. I discussed it often with Mark Sudane. He has a lot of experience with that and already published his early experience on 14 years ago. Also, this is not the first case you should do. And indeed, you should have the smaller lesions. Very similar going to the aqueduct, that's possible. This is more or less, you would say, I expected this to be an ependymoma. And you see, if you plan this, look well to where it is. Do you see here? It is on the right here, on this side here is the attachment of the ependymoma. So this is really where you want to go. This is what you see, the detail. That is the area where you have to deal with surgically. And was indeed, as you could see here, a nice flow void through the fourth ventricle again, and it was indeed an ependymoma grade 1. So very nice. Some small solid tumors indeed can be removed with that. Rinsing is important, but please ensure that what you put into the patient is also coming out. Please, I had my difficulties with that. Hemostasis is not easy. It is time consuming and it takes time. Think of things like laser and also a balloon that can push on a bleeding point for some times as pressure. So these are the tricks. And always have a backup strategy when you think I'm lost. I don't know how to proceed further. But most of all in endoscopic procedures, don't hurry, be patient. That's my most important thing. So that was all I wanted to tell you about third ventricle tumors. That was quite a long stretch. So I don't know if there are any questions. I'm happy to answer them.
Andre, that's a great talk. Thank you. With the you've got a wealth of experience with endoscopy and with open surgery for third ventricular lesions. Are there any circumstances where you wouldn't use endoscopy as the first line treatment for a colloid cyst, or would you always? Do you think you'd always be able to access it? Are there any sort of radiological appearances that might put you off? You know, indicating thicker material in the cyst or something like that.
Strangely enough, initially, when you have a T2 image and the content of the colloid cyst is absolutely black, then you know it is a kind of butter, thick butter inside. And initially I was afraid, and now I actually more or less prefer those because with my suction device that I have, I remove as much as possible from it. And I can tell you that dissecting the cyst in itself endoscopically is much easier if there is still some, how should I call it, some substance. So if it otherwise is a floppy, thin membrane, that cyst wall, I have difficulty distinguishing it from the tila and from the arachnoid of the velum. And I think, is this an arachnoid or is it still cyst wall? And then you are not sure what to do. So that is the reason that also with this more softer content, I try not to fully empty the cyst in the first attempt. But there are instances. I had a case where they had placed bilateral shunts, but then the cyst over more than 15 years grew and was 6 centimeters. So then you have no ventricle and a 6 centimeter cyst. That's not an endoscopic case. That's a microsurgical case. And I always told my patients from the very beginning when I did endoscopy. So my first endoscopic case was 1990. And I told them, I had always a microscope draped. Now, not again, but you can easily and quickly drape it. I told him, I will remove your cyst. And I start endoscopically. And in the last, all the decades and so, I always succeeded. But I don't want to leave remnants because here we have a benign lesion. And when we remove it completely, this patient is not a patient anymore. If I leave a remnant, then the patient has to return every year on a certain day and have an MRI scan, and the patient thinks, oh yes, it's really, I still have something there. There is something. And for many, many years, because there are recurrences, but only after 10, 15 years or something like that. So that's a problem. This is one of the few lesions we really can cure surgically. So yeah, I want to do that. And certainly in the beginning, I switched to microsurgery. Yeah.
And with the other interesting was your thoughts on the pineal approaches, the supratentorial pineal approaches. And one of the problems I've encountered often is the thickened arachnoid and the vascular structures behind it, and can be quite intimidating. Have you any experience using novel techniques, ICG, fluorescein, to try and help identify vessels behind arachnoid planes? Or
no, I have not used it. No, not yet. I don't know if it's so well for the veins, because I'm more afraid of the veins. And that's the thing, of course, initially, and that is when I let my senior resident approach that case, they are so afraid. And of course, you don't want to take your scissor and think I open the arachnoid and then open the vein of Galen. That would be, no, it is, for me, the trick is it's always a milky, thick arachnoid. I open it laterally. So I open it from the occipital area and then widen this until I see the top of the cerebellum. I see the corpus callosum, and then I know, and I can lift it up a little bit. Still, it is tricky, but the more you release, the better you can see it. But I have to say that's one of the moments you have tachycardia during that surgery, when you decide to have your 2 instruments inside, and I think that now I take my diamond knife and cut here, make a first cut. That's always a little, yeah. But the
veins get less in the way with the infratentorial approaches, I think. That can get in the way in the supratentorial.
But that was one of the things. But I learned also because I told our anesthesiologists hate the sitting position. Later on we had an anesthesiologist coming from Germany, and he was comfortable with that, because I trained also many years in Germany, and I was very comfortable with sitting position. And then in the Netherlands, there was some anesthesiologists doing studies, and it was the Society of Anesthesiologists gave the guideline of not doing sitting position.
Wow.
But okay, but we learned to do prone, and I also learned to do not the infratentorial, but I always then do the lateral. The nice thing is, it's this way. It's this way. So if it is up here and you go in the midline, you have also the veins. On the lateral aspect, so you do a little bit more lateral approach here, you follow over the superior surface of the cerebellum, and that's also very, very nice approach, very nice and easy. A midline is, of course, mentally easier because you know that you are in the middle, and you know that should be in the middle, and that, so the vein springing off, that must be the Rosenthal. And so it's easier thinking, but coming from a little bit more lateral, you don't have you don't have bridging veins, or one on maybe on the lateral side, even not medial. So there are some different options here.
Yeah, no, I favour the paramedian approach to the supracerebellar. It's a great approach.
It's a great approach indeed. Yes.
Have we got? Do we have any other questions from you? We have a big but silent webinar crowd today. All of presentation.
Just comment from myself. Thank you very much, Professor Grottenhuis. It really is. Covered every aspect. It will be a great reference for the young neurosurgeons, as well as a good stepping for the residents. Thanks again for your always enormous support for the listserv. You are part of the pillar that the listserv works on. People think that I do it, but there are people behind who help me all the way along. So thank you very much for everything. Thanks.
Thank you, Naren.
And thank you, Naren, for organising such a fantastic session and really stimulating lectures from everybody. Thank you.
Thank you. Thank you very much, Mr. Richard Edwards, for fantastic chairmanship of this really very good, excellent session we had from Dr. Jalo, starting with great presentations from Kenya and from Dr. Dimitrios and Professor Grottenhuis. Really finishing it off nicely. Brilliant. Thank you very much. So just 5 minutes break before we go to our final session of today. We have got the first lecture will be from Professor Failings, and the session will be chaired by Mr. Gurish Solanki. He's the a neurosurgeon from pediatric neurosurgeon, senior pediatric neurosurgeon from Birmingham, and he's also now the current chairman of the British Pediatric Neurosurgery Society and has a great interest in pediatric spines and spinal cord injury himself. And also from Dr. Komar Prasad, he's a senior neurosurgeon from Bangalore. He also has a keen interest in spine. And we have got 3 major keynote lectures today from Dr. Michael Failings. I will let Mr. Solanki in 5 minutes introduce Dr. Failings, but Dr. Failings is also going to share with us some important new data that is on the press in Lancet Neurology. So that's a great privilege for us to have the hot of the press before it is published. And then we have another giant of spinal surgery, Dr. Rick Fessler, and then finish it off the master skull-based surgeon, Mr. Professor Lanningham Shaker. So 5 minutes break, and then we will convene. Thank you. Hello, Dr. Failings. Can you hear me?
I can hear you clearly. Thank you.
Excellent. Thank you very much. Thank you very much for joining us. It's a real pleasure and honor. Mr. Solanki, he's the senior pediatric neurosurgery consultant in Birmingham Children's Hospital, my boss, and he's the president of the Society of the Pediatric Neurosurgery and extensive pediatric spine surgery. And certainly he's the one who mentions to me every time Dr. Failings spinal injuries, Dr. Failings spinal injury. I thought I have to invite you. So it's going to be a very, very interesting talk. Lots of questions, certainly from me and Mr. Solanki. Thank you.
Hi, Michael. It's a real privilege to have you talk today. Can you hear me?
I can hear you clearly.
Oh, excellent. Okay. I think your introduction, deservedly should take 10 minutes, but I'll try and stick to 5 minutes if that's okay. Is there anything in particular you'd like me to mention? I hope nobody else is listening.
Everyone is listening. Dr. Komal Prasad as well here. Dr. Komal Prasad.
Right.
Yes, Naren.
Dr. Komal Prasad, everyone knows Dr. Failings. Dr. Prasad is a senior neurosurgeon in Narayana Institute in Bangalore, big neurosurgical institute. And we were going to have our conference earlier, annual course in Mysore, the most beautiful part of India, near to Bangalore. But because of COVID, we had to postpone it indefinitely. I'm sure we will go, but great to have Dr. Prasad for this session as well. Thank you.
Professor Failings. Good evening, Professor. So we heard a lot about Professor Failings when we were doing this WFNS. We had this thing consensus meet 2 years ago in Nagpur for our cervical myelopathy, spondylotic myelopathy. Devised this thing, that panel, and that's when most of our references were from you, Professor. So I don't think we have to look anywhere further apart from your work in cervical myelopathy. I'm glad to see you, at least virtually.
Indeed.
Thanks.
Well, hopefully we'll be able to, at some point in the near future, see each other in person, but I guess this is the best we can do right now. Thank goodness for virtual technologies.
Yes.
So I think we are now ready. As I said, Mr. Solanki, we will, after your introduction, I'm going to try to transmit the recorded video from this end. This is for technical, so there's no technical interruptions. And then Dr. Failings will take the questions. Is that okay? Great. Thank you, Professor Goel, for being here as well. Thank you, sir.
Thank you, Naren. And I'm very eagerly looking forward to what my dear friend, Dr. Failing, has to talk about and tell us all what he wants to say. And nice to see you, Rich.
Great. Thank you. So welcome back to the late afternoon session of the second day of the World Neurosurgery Webinar Conference 2020. We had an amazing day yesterday and equally amazing day today. We had fantastic papers from neurosurgeons from across the world, and we had a scintillating lecture from Professor Dufu. He presented us with his new data. And we had Professor Grottenhuis just gave his talk on opus on third ventricular tumors. And we had Dr. Jallo, who took us through the current state of art of pediatric brainstem tumors. So now it comes to the afternoon session. We have another absolutely, in any day, one of the speakers will fill a whole auditorium. So we have got a really superb session. So my pleasure to introduce Mr. Girish Solanki and Mr. Komal Prasad. As I mentioned earlier, Mr. Solanki is senior pediatric neurosurgeon and the president of the British Pediatric Neurosurgery Society, and Mr. Komal Prasad is a senior neurosurgeon at Narayana Institute. So Mr. Solanki, if I first of all pass the baton on to you. Thank you.
Thank you, Naren, and congratulations again on another fantastic webinar. I hope everybody can hear me all right.
Yes, we can.
I'm using a dictaphone speaker because I'm in my office, so it may not be very clear, so I do apologize. Great to see you, Komal and Professor Goel. And now it gives me great pleasure, really, to introduce Dr. Michael Fellings, who, of course, all of us have been following your work for many, many years. You are the vice chair of the research department of the University of Toronto, the co-director of the spinal program, and of course, you've got an amazing active practice, which you combine with your interest in translational oriented research, which you lead a team of multidisciplinary research scientists, I think unparalleled in the form of your clinical practice, your research publication activity. I believe you got more than 900 published in highly cited papers. Your work in spinal cord injury is well known and highly cited, as Dr. Prasad just mentioned. So I think, you know, we are all pretty much kind of eagerly waiting to hear from you. I think it would be remiss of me not to mention the numerous prestigious awards that you have received, like the gold medal in surgery from the Royal College of Physicians and Surgeons a long time ago, but you know, clearly an important one. You've been cited as one of the most influential scientists of the 21st century, the Lister Award in Surgical Research, the Leon Wilsey Award from the North American Spine Society for Excellence in Leadership, the Olive Krohn Award from the Karolinska Institute, which is also known as the Nobel Prize in Neuroscience, and so on and so forth. For the brevity of time and for not being criticized for going on and on, I'd just like to warmly welcome you to deliver your lecture on the acute management of spinal cord injury.
So I'm just going to share the presentation, then Dr. Fellings will take questions. So it will just be a technical, let me see. Good.
Hello, I'm Michael Fellings from the University of Toronto, and I'm very pleased to have been asked to participate in this World Neurosurgery webinar conference. And I've been asked to reflect on new developments in the management of acute spinal cord injury. And I've decided to focus specifically on the surgical management of acute spinal cord injury, and especially on the role and timing of surgical intervention. And some of what I'll be discussing with you has already been published, but much of what I will also be discussing will be new information that I hope will be clinically relevant. So thanks and appreciation to the World Neurosurgery webinar conference for the invitation. In particular, my thanks and appreciation to Mr. Narentharan. I have no relevant commercial disclosures. I do receive grant support as indicated, and I wish to acknowledge my colleagues and collaborators who are listed on the slide with a special shout out of appreciation to Dr. Jetan Badiwala, who's a neurosurgery resident in Toronto, and Jetan has recently completed his PhD under my guidance. This is where I work in Toronto at the Toronto Western Hospital, University of Toronto. It's a beautiful city. It's a shame that we have the current restrictions in travel, but when these are lifted, I would really welcome all of you to come to my beautiful city. I work with an amazing team. These are acknowledged on this slide, and I'm very grateful for their support. So here's what I'm going to talk about. I'm going to review some of the clinically relevant pathobiology of acute spinal cord injury, and then I'll talk about the rationale and the evidence for early surgical intervention for spinal cord injury. And I'll talk about the current AO Spine guidelines for acute spinal cord injury, and then I'll talk about the limitations of the guidelines. And then the latter part of the talk will present new data. I'll present novel data on the role and timing of surgical intervention for acute spinal cord injury. Then I'm going to revisit the concept of central cord injury, and I'll present to you that this is not a benign entity which should be managed non-operatively. In fact, this is a serious form of incomplete cervical spinal cord injury that does benefit from early surgical intervention. And then I'll provide some conclusions and take-home messages. So here are the learning objectives for this talk. The learner, at the conclusion of the talk, should have a working knowledge of the clinically relevant pathophysiology of acute spinal cord injury. The learner should have knowledge related to the current AO spine guidelines for the role and timing of surgery in acute spinal cord injury. One should acquire new knowledge which supports the concept of time as spine. And finally, the learner should have an awareness of the current knowledge gaps and future challenges around the surgical management of acute spinal cord injury. So let's consider these three different case vignettes in terms of the timing of surgery and how best to manage. And the reality is that spinal cord injury is very heterogeneous. So let's consider this patient with a thoracic spinal cord injury, 45-year-old woman, T6 burst fracture. She's a motor complete, sensory incomplete injury, Asia B with sensory sparing. Is there a rationale to decompress the cord? What about the timing? Here's a case that's maybe less controversial, but a 39-year-old man, diving-related spinal cord injury, C4-5 fracture dislocation, C4 level Asia A complete cervical spinal cord injury. Is there a role for early surgical intervention here? And what about this person with a traumatic central cord injury, 50-year-old woman, low velocity fall? She has a serious cervical cord injury, Asia C with a central cord picture. Is this a benign entity or is this something that should be addressed surgically? And if so, when? So traumatic spinal cord injury results in incredibly serious deficits for the individual. And this is related to the eloquence of the spinal cord. And of course, there's a level dependence on the impairment and disability that arises. And particularly crucial are cervical injuries because these result in loss of independence and are potentially life-threatening injuries. But nonetheless, injuries at other levels have profound impact on the patient. So when we consider the mechanisms of acute spinal cord injury, let's reflect on one of the cases that I presented. This is the young 39-year-old with a C4-5 fracture dislocation, serious cord injury. The middle panel is an image, fortunately, not from this patient. This is a deceased individual. This photograph is a gift from Wolfgang Rauschning. And this illustrates a fracture dislocation. And this shows the primary injury to the spinal column, to the spinal cord. And there's clear-cut instability, and there's ongoing compression of the cord, and there's a contusion within the cord with hemorrhage. So if we look at the site of contusion, and here is some animal work from a rodent that's received a clip compression injury of the cord, and we've microinjected the blood vessels. And one can see that the anterior sulcal vessels are intact, but the central arborization of these vessels have been traumatically disrupted. This is the effects of the primary injury, and there's a hemorrhage. And in this area, necrosis occurs. But surrounding this region is what's referred to as the ischemic penumbra. And in this region, nerve fibers undergo progressive degradation, as shown on these confocal images of nerve fibers stained with neurofilament 200. And then ultimately, this concludes with this chronic picture here. And this is a postmortem photomicrograph of the lesion site from the individual many years after spinal cord injury. So the hemorrhage has been resorbed. There's a cavity, and this is surrounded by the glial scar, and there's been retrograde and antegrade degeneration of the nerve fibers. And so we see the evolution of events, but if you can reflect on the top panels, I think one could readily see where potentially surgical intervention might have an impact on trying to mitigate some of these secondary injury events. And critical to these secondary injury events are the vascular effects of the acute injury, and these trigger macroscopic and microscopic changes within the cord parenchyma, including significant shifts of cations inflammation, and excitotoxic cell death. So I would argue that there's a strong rationale to consider early surgical intervention. We think about the primary injury, and then there's a component of the secondary injury. And then the hope is that with early surgery, one can attenuate the effects of secondary injury. Now, there's robust preclinical data to support the efficacy of decompression. This is an elegant meta-analysis by Peter Batchelor and colleagues looking at early decompression of acute spinal cord injury. And across 79 studies in the basic science literature, decompression on average improved neurobehavioral outcomes by about 35%. And the effect size was closely related to the duration of compression. So how early is early? And this has been a subject of considerable debate and discussion. In a systematic review of the literature, which my colleagues and I conducted about a decade ago, 24 hours was the cutoff most commonly used, although certainly there was a variety of opinions expressed in the literature. And then in a survey, which we reported right around the same time, about 80% of nearly 1,000 surgeons surveyed around the world preferred to decompress a spinal cord within 24 hours. Now, the current clinical evidence is mixed, and this does present challenges and limitations. So this is the systematic review that our group put together. This was published in the Global Spine Journal in 2017, and this was accompanied by guidelines. And these were the first guidelines around the surgical management of acute spinal cord injury. There were only 5 studies that were able to include in the guidelines, and all but 2 had a moderately high risk of bias. And unfortunately, it was not possible to pool the results in a meta-analysis because there was heterogeneity in the level of spinal cord injury, the timing of follow-up, and the types of outcome measures that were examined. So let's consider the sciatica study. This is a study which I led and reported on now over 8 years ago. And this was the first and is still the largest prospective multi-center assessment of the role and timing of surgical intervention. In this study, we limited the assessment to cervical spinal cord injury, and this was 6 centers in North America, 313 patients with cervical spinal cord injury. And we found that in patients that were decompressed within 24 hours of injury, the odds of having a major improvement in neurologic function, which is defined as a 2 or more grade improvement in the age impairment scale, was nearly 3-fold higher than controls. And this is still the largest and arguably the most convincing evidence in favor of early surgical intervention. So the resulting practice guidelines, though unfortunately, only were able to provide a weak recommendation based on relatively low quality data. And this is a summary of the recommendations that we suggest that early surgery be offered as an option for adult acute spinal cord injury, regardless of level. So this is the preferred option, and this has been largely well accepted, but I think we need to do better than this. There's a critical need for higher quality evidence. Does time influence the outcome for all forms and levels of traumatic spinal cord injury, including thoracic spinal cord injury? We hypothesized that early surgical decompression of all forms of spinal cord injury would improve long-term neurological recovery. Now, to achieve this goal, there are 4 key things that need to be in place. One needs to have a large sample size to derive precise estimates. One needs to have long-term follow-up of the data. One needs to have a precise examination of subgroups, and one needs to have uniform outcome measures in order to perform quantitative meta-analyses. And we've been able to solve this issue by combining 4 large prospective multi-center data sets of spinal cord injury. So one is the North American Clinical Trials Network, or NACTIN Spinal Cord Injury Registry. The second are data from our sciatica study. And the third and fourth are from randomized controlled trials examining neuroprotective drugs. One was a Cygen trial, and the other was the NASCIS-3 trial. And we were able to harmonize the data sets and to extract common data elements. And we specifically looked at acute traumatic spinal cord injury, Asia Impairment Scale A through D, all levels, and we assessed the effect of surgical decompression. We looked at a variety of baseline characteristics, including various demographic features. We looked at the injury characteristics, mechanism of injury, baseline Asia exam. We looked at the time to surgery, defining early surgeries being within 24 hours and late surgery beyond 24 hours. And we looked at the impact of the administration of steroids as a co-intervention. The outcomes that we looked at were those of neurological recovery, looking at the Asia or the INSCI scores at 1 year, the primary outcome being the changes in total motor score, and then looking at changes in light touch, pinprick, sensation, as well as Asia Impairment Scale grade. We did this through a one-stage meta-analysis using a hierarchical mixed effects regression. We stratified this to account for clustering of patients within studies. We looked at a variety of covariates, including baseline score, the age, the mechanism of injury, baseline Asia Impairment Scale grade, the level of injury, and the impact of the administration of steroids. And then we derived precise estimates related to the changes in total motor score, light touch, and pinprick scores, and we developed common odds ratios for changes in the Asia Impairment Scale grade. We undertook sensitivity analysis using a two-stage meta-analysis with treatment effects calculated for each data source individually. And these were pooled by random effects meta-analyses. And then we undertook a variety of subgroup analyses defined by various covariates, and we looked at interactions between subgroups and treatment variables. Importantly, we also modeled time as a continuous variable in a secondary analysis, and you'll be quite interested to see these data, I think. So this is the consort diagram of the 2,415 patients in the harmonized data set. We ultimately analyzed 1,548 patients. And these are the baseline characteristics that we examined, and there were slight differences in the relative range of cervical injuries between early and late surgery. So 80% in the cervical patients, late surgery group, a slightly higher proportion, the early surgery group. This was statistically significant and accounted for in the analysis, although truthfully, the actual numerical differences are actually relatively low. So I'll present the results initially in table form, so you can look at the numbers, but then I'll present it in graphical format as it'll be easier for you to follow visually. The bottom line here is that for total motor score, light touch score, pinprick score, and the changes in the Asia Impairment Scale grade, surgery and early surgical intervention had a strong effect on outcome, with p-values ranging from 0.001 to 0.002. So these are the resulting forest plots, which present to you the data for total motor score, light touch score, pinprick, and Asia Impairment Scale grade. I've plotted out the data for each study, and then we have the summary data here. So we see for total motor score, for light touch, pinprick, and Asia Impairment Scale grade, strong effects favoring early surgical intervention. And here we've plotted out the data for the changes in the Asia Impairment Scale grade in a somewhat different way, looking at the common odds ratios. And what this contrasts is the proportion of patients who end up with incomplete lesions as opposed to complete lesions for early versus late surgery. And we see that, that this trend does favor early surgical intervention and is statistically significant. Now let's look at the subgroups of injuries. Let's look at cervical and thoracic injuries. And for both cervical and thoracic injuries, early surgery results in improved outcomes. The cervical group, the main impact is seen in the upper extremity motor scores, and it just misses significance for the lower extremity motor scores. And for the thoracic injuries, we also see significant improvements in neurological recovery with early surgery. Now this slide just illustrates the impact of the various subgroups on the outcomes. And the bottom line is that none of these subgroups had an impact on the conclusions related to the impact of early surgery. Now, these are interesting data. Here we have modeled the timing of surgical decompression as a continuous variable. On the y-axis, we've plotted the changes in the Azor-Insky motor score, and on the x-axis, this has been plotted as a function of the time to surgical decompression. And you can see that within the first 24 hours, there's a very steep slope to this curve, indicating that there's a clear time dependency of the benefits of early surgical intervention, and that truly time is spine, and this seems to plateau out at between 24 to 36 hours. So decompression within 24 hours results in superior neurological recovery. The data for this are really quite unequivocal. For cervical spinal cord injury, early surgery preferentially benefits motor recovery in the upper limbs. And importantly, this is rated as a top priority for quadriplegic individuals. In the first 24 to 36 hours, there's a steep and continuous decline in recovery with delayed decompression. And this truly drives home the point that time is spine. And this is supported by studies showing a benefit for ultra early surgery and studies showing no benefit for longer thresholds beyond 72 hours. Now, what about the special consideration of traumatic central cord injury? And here I come to this patient, again, this 50-year-old woman, Asia C, cervical cord injury with a central cord picture. So this is quite relevant because the epidemiology of acute spinal cord injury is changing. And the case I've presented is now in westernized society and developed countries the most common form of spinal cord injury seen. And in this article in Lancet Neurology, we discuss the global burden of traumatic brain and spinal cord injury. So what's clear with spinal cord injury is that the overall incidence is stable, but patients are getting older. We're seeing more fall mechanisms and we're seeing more cervical injuries. And the reality is that the patients with the central cord injury picture are becoming commoner and commoner in our practices. And I would argue that central cord syndrome is rapidly becoming a major public health priority. Now here's the classical description of central cord syndrome by Richard Schneider and colleagues. And a number of these facts are still true today, but a number need to be revisited. So it's true that patients generally have this type of injury when they have a hyperextension mechanism with pre-existing spinal stenosis from either a developmentally narrow canal or canal narrowed by acquired degenerative pathology. Patients are defined as having greater upper limb weakness compared to lower limb weakness. And the natural history does generally seem to show some degree of recovery, although it's not always a good recovery. And I'll talk about this in a moment. But there are several concepts on central cord syndrome that need to be revisited. So there are four key assumptions, which I'm going to list here, and I'll sequentially deconstruct each of these. Firstly, it was assumed that the pathophysiology involves a central hematoma with a somatotopically organized corticospinal tract. That is incorrect. It was felt that the clinical course was universally favorable. That is also incorrect. We now know that surgery is safe and appears to have benefits. It was also assumed that central cord syndrome captures a relatively homogeneous population of patients. Again, this is incorrect, and in fact, these patients are very heterogeneous. So let's consider the first assumption. I've diagrammed on the right the classical theory where there's a central hematoma and it picks off medial fibers of the corticospinal tract, which were hypothesized to subserve hand and upper extremity function. In fact, this is incorrect. So firstly, central hematoma rarely occurs in central cord injury. In fact, pathology and imaging studies have shown diffuse white matter injury that preferentially involves the lateral tracts. Neuroanatomical studies in non-human primates have shown the absence of a somatotopic organization of the corticospinal tract. And in fact, the corticospinal tract is principally important for hand and upper extremity function. So let's talk about the clinical course. Is it really universally favorable? Well, in this paper from the EMSCI network in Europe, these authors concluded that the outcomes for central cord syndrome were in fact pretty much identical to other forms of incomplete cervical spinal cord injury. And in fact, it was really the baseline level of neurological impairment that defined the trajectory. So here are novel data from our combined data set. And here we've looked at 652 patients with a severe incomplete cervical spinal cord injury. We've plotted out on non-central cord syndrome patients, and those are the central cord syndrome. And we've looked at the trajectory of recovery of upper and lower limb motor strength, as well as light touch and pinprick scores. And the recovery curves between the two groups are pretty much identical. And in fact, the presence or absence of the central cord syndrome phenotype accounts for only 0.3% of the variance in the motor score. But now let's plot out the data differently. Let's plot out the outcomes for those with ASIA C versus Asia Impairment Scale D. And we now see that we account for a significantly greater difference in the recovery curves. And in fact, the Asia Impairment Scale grade accounts for about 40% of the variance in the motor score. So the clinical course, in fact, is very similar to other forms of severe incomplete cervical spinal cord injury. So we recognize from the Staskis study that early surgery for cervical cord injury can be done safely. And this is work from a paper which is now in press in Lancet Neurology, demonstrating again that early surgery does have a beneficial effect. And here we're plotting out the common odds ratios for the changes in the Asia Impairment Scale grade. And again, these are the data that I just presented, and this is in press in Lancet Neurology, as I've indicated. And finally, are central cord syndrome patients really homogeneous? Do they really all do great? Well, I've already shown you that the trajectory of the outcomes is similar to those with other forms of incomplete cervical cord injury. But let's have a look at this in our data set. Well, we recognize that spinal cord injury is heterogeneous, and so is central cord syndrome. Many patients are older, but not all. Many patients are also younger. Most patients don't have a spinal fracture, some do. Most are related to low energy mechanisms, but some have a high energy mechanism, and so on. And in fact, here are the data for the patients with central cord syndrome. And they're very heterogeneous. And we see that there are wide differences in the trajectory of recovery. Some patients making an excellent recovery on upper extremity motor scores and total motor scores. And in other cases, the recovery is not as good. And so we present a couple of cases. Here is a 60-year-old male, fall from a standing height, lower limb function preserved, upper limb a weakness. Here are the imaging studies showing a contusive spinal cord degenerative spondylosis. treated with a posterior decompression and instrumented reconstruction, has persistent paresthesia post-op, neuropathic pain, some residual upper extremity weakness. Here's a patient, almost identical age, very similar mechanism of injury. MRI, not that different. Significant upper limb weakness, distally, lower limb power relatively well preserved. Similar type of treatment. This man recovered to full function and is functionally independent. So we've essentially debunked these four assumptions, and there really is a strong impetus to revisit this so-called central cord syndrome. So there remain critical knowledge gaps today, though, in the management of these patients. So what about the safety and efficacy of early surgical decompression in this group? What about the outcomes in the modern era and the predictors? And what is the window of opportunity in these patients with an incomplete cervical cord injury? And so we hypothesized that the neurological outcomes in patients with central cord syndrome are heterogeneous and predicted more accurately by acute clinical variables and interventions, including early surgical decompression. And we aim to evaluate the effectiveness of early surgery, defined as less than 24 hours in this patient population, and to develop a clinical prediction model for neurological recovery. And to undertake this, we used three of the data sets I previously described: the NACTIN data set and the STASCUS data set. These were used to derive the clinical prediction model, and then we used the NASCUS-3 data set as a validation cohort. We focused on patients with Asia grade C or D injuries who had neurological levels C1 to C8, and with a difference in the upper and lower extremity motor scores of 5 or more points. And then we looked at a variety of baseline demographic characteristics, very similar to what I previously described before, looking at mechanism of injury, looking at time to surgery. Primary endpoint were the Asia motor scores at 1 year, and we developed the prediction model using multiple linear regression, the derivation cohort. The variables to be included were based on a priori based data from supporting literature, as well as from variables that we hypothesized that would be important. So previous systematic reviews have found that age and severity of injury are the strongest predictors of neurological recovery in patients with central cord syndrome. So the predictors that we modeled were based on systematic review: age, the baseline Asia motor score, baseline Asia grade, and also based on hypothesis. So hypothesizing that early surgery would have an impact and that there might be an interaction between the Asia impairment scale grade and early surgery. And this was undertaken through a stepwise variable selection process with multiple imputation. We did internal validation through bootstrapping and external validation using the external validation cohort. This was the NASCUS-3 cohort. This is the consort diagram, and ultimately in this, for this study, we analyzed just under 250 patients. And this shows the baseline characteristics for the derivation cohort and the validation cohort. And not surprisingly, the newer data in the derivation cohort are somewhat older than the NASCUS-3 data set. And these differences in age were accounted for in the analysis. Importantly, there was no evidence of non-linearity in the model development. And we found that the model that was ultimately developed had a very good predictive value with an R-squared value of 0.6448. And this is the model that was ultimately obtained. So the changes in the Asia motor score at 1 year are related to the age, which is modeled as a continuous variable, the Asia motor score at baseline, the Asia impairment scale grade, and the timing to surgery, where early surgery is defined as within 24 hours. Now, importantly, there's also a significant interaction in the outcomes based on whether the patients were in Asia grade C or D, with the most marked effects seen in central cord injuries of a more severe nature, like the patient that I presented with an Asia grade C. Now, this may likely reflect the sealing effects related to the Asia grade D, and this also shows some limitations in the Asia or INSCI classification. This is not particularly sensitive for detecting changes in patients who have an Asia grade impairment scale level of D. So in conclusion, for the central cord part of the talk, age and baseline severity of neurological injuries are important predictors of neurological outcomes in central cord syndrome. But these are non-modifiables, not much you can do about that. But early surgical decompression, which is a key modifiable a treatment paradigm, is associated with dramatically improved motor recovery in central cord syndrome, particularly for those with an Asia C injury. So here are the take-home messages and future directions. Surgical decompression for cervical and thoracic spinal cord injury within 24 hours of acute spinal cord injury improves neurological recovery. This is very clear. So there's now an opportunity to revisit the existing guidelines for the surgical management of spinal cord injury. There are many knowledge gaps which will define future directions. We clearly need a personalized medicine approach to optimize the care of spinal cord injury. These patients are very heterogeneous. The elderly patient with spinal cord injury and medical comorbidities does represent a challenge, and I recognize that many patients with central cord injury fit this phenotype, and it may not always be possible to operate on these patients within the 24-hour time frame. We clearly need better methods to evaluate and to assess the AGD spinal cord injury patient as well. And I think there is an opportunity to discern the effects of surgical intervention within this cohort. On that note, I'd like to thank you for your attention to this talk and for the privilege of speaking to you, and I'm very happy to address any questions.
There are basically 3 treatment options for them.
Sorry.
The first one, of course, is no treatment, observation only. The second is
Mr. Solanki, do you want to take the reins, please? Thanks.
Hi there. Yes. Can you guys hear me?
Yeah.
Somebody just spoke, but it was very soft.
No, that's okay.
Okay. So Professor Fellings, thank you so much for very, elucidating lecture. I think a lot of new information that we are going to need to digest. I presume this is published or being published?
Yeah, so the data on the large meta-analysis are currently in press in Lancet Neurology. They'll be coming out in a few weeks.
Fantastic. I think most of us suspected that early surgery is leads to better results, and I agree with you that we should be driving to operate on these patients earlier. And you made, I think, I think I probably should go in a more formalized fashion to try and attract comments as well. I haven't seen much on the chat. There is lots of thank yous, but if there are any significant questions, please put on the chat or put your hand up, and I'll be more than happy to pass the questions to Professor Fellings. If I may start, and Komal, do you have any questions? Perhaps I should give you, as co-chair, the opportunity to ask first.
Please go ahead with your, it looks like you have a query.
Well, complimentary, but the most important question that came to my mind is, yes, we can take these patients for early surgery, but I suppose the peri-management, the actual sort of management around the surgery is also critically important. And there are lots of guidelines coming out. And I just wanted to pick your brains on the importance of the initial cardiovascular stabilization of the blood pressure particularly in high spinal cord injuries, as pivotal to maintaining the good outcomes? Because I think there's a lot of studies coming out that if you don't keep the mean arterial pressure more than, say, 85 millimeters of mercury and a systolic blood pressure more than 110 in adults or older than 13 years, that all of your efforts might be in vain, because you would end up stroking the spinal cord, and spinal cord perfusion more than 50 millimeters of mercury is something that is desirable. What are your views on this? And is this something that we should put in guidelines now? Because, for example, in pediatrics, there's nothing. And I am constantly having to make an effort to convince people of the importance of this, because we are really talking neurogenic shock on the first 24 hours rather than spinal shock. And I think people don't recognize this. What are your thoughts on this?
Okay, Gurish, well, thank you. And again, thank you for the gracious invitation to speak today. So if I may, I'll perhaps divide your comments into three areas. The first point, you talked about hemodynamic management, and I'll maybe extend this a bit around critical care management of the patient in the acute setting. The second point relates to the techniques of surgical decompression that I haven't really talked about at all. The assumption is that every patient has excellent surgery and that the surgery is always uniformly done. That is probably not the case, to be honest with you. And then the third point relates to children and to pediatrics. Okay, so I'll make comments on each of these. So as many of you know, my PhD thesis was focused on the concept that's now known as a secondary injury. And some of the slides that I showed in my introduction were from my PhD thesis, and the concept of the hemodynamic management was originally very controversial. In fact, when I first came out with the work that we'd published on blood flow measurements, I remember I was presenting a lecture and someone had said that my data were wrong. And fortunately, that this has now been validated, and we now recognize that blood pressure management is critical. We lack data on the exact number. So you mentioned guidelines, which is useful kind of as a principle, but is it correct for every patient? And can we get more accurate with this? But certainly as a first principle, we need to have excellent hemodynamic management, and particularly with high cervical injuries, for sure, because the patients do not regulate their blood pressure correctly. The spinal cord is potentially ischemic, and this is where a strong collaboration with your neuroanesthesia team is important, with the critical care physicians. Absolutely, that's a fundamental principle. The second point relates to what I feel is one of the next knowledge gaps and unmet challenges. And this is like, okay, we now accept that surgery has a role. That is very clear now. There's no question about this. There does appear to be that there's a timing effect. That becomes a challenge because it's not always logistically so simple to do this. And the patients, you're having to balance the medical issues in the patients. However, what about the techniques of surgical decompression? Are all of the techniques uniform? How do we assess the adequacy of the decompression? In my own clinic, I always get a postoperative MRI scan, for example. This is something that I learned in Staskus to be doing this. And I learned many lessons on how to properly decompress the cord. Right now, some researchers such as Marius Papadopoulos are advocating potentially, duroplasty. The Chinese are advocating for this. I'm personally not doing this routinely in my practice. It's an interesting concept. Should we be using intraoperative ultrasound, for example, as an assessment to look at the spinal cord decompression, the hemodynamics? Could we perhaps use that as an inflection point? So I think this is really something that we really want to be looking at very carefully and trying to develop better management protocols for how to do the surgery correctly. The third point relates to children. And currently, the best we can do is to infer the results from adults to children. And many of us are parents, so we recognize that a 16-year-old tall, strapping boy, you could probably treat this person, like a young adult. But what about a 7-year-old child? Are the mechanisms of injury the same? Does the spinal cord behave the same? No, of course not. So we need to do better than this. So in fact, we currently are undertaking an analysis of our large data set in pediatric spinal cord injury out of Toronto. Fortunately, the cases are not as common as in adults. These cases are always tragic, but they do occur, and we have a large number of cases. And as I will say this also as a shout out, if anyone here in the WFNS has large prospective data sets, particularly in pediatrics, please let me know, because I think we need to have better data, and we need to have better management protocols to treat children. But in principle, I would think that the same general principles would likely apply. But of course, the nature of the injuries in children will differ, particularly for very young children, as we know.
Thank you. This is very helpful. I'm just summarizing some of the thoughts that he just put out, because some of the questions were also similar. There is a question, there are two important questions that have been asked in the meantime while you were answering. One was the use of methylprednisolone as a sort of adjuvant supportive therapy. What is your experience with methylprednisolone? And I think everybody is waiting to hear some of this from you.
Sure. So,
okay, go ahead.
I didn't mean to interrupt you. You want to finish your question, or do you want me to respond to the methylprednisolone?
Go ahead and respond to the methylprednisolone, and then I'll ask the next question after that.
Okay. All right. So, my position on methylprednisolone has been published, and I think I've tried to achieve a midline kind of balanced view. And, panacea, methylprednisolone is not the gold standard panacea that it was initially thought, nor is it, the evil death wish on the other side. The reality is it's in the middle. And, we're neurosurgeons on the call. We use corticosteroids very frequently in our practices. We're very well aware of the pros and cons of using corticosteroids and limitations. So the reality is that there is quite strong basic science evidence to indicate that neuroinflammation is a critical component of spinal cord injury. That's very clear. It's also known that an acute spinal cord injury results after the first 24 hours in relative immunosuppression of the patient. The patients are more vulnerable to infections. And so the time window to use corticosteroids is narrow, and one needs to use this very carefully and selectively. So it's an option. So which patients seem to be potentially the best candidates? Cervical injuries appear to have a particular response to corticosteroids. It may relate to some nuances with the niche in the cervical cord, and also the complication profile is a bit different in the cervical patient. So I tend to use it in younger patients and also in cervical injuries. I think there's probably little role for it to be used in a complete thoracic ASIA A injury. You're probably not having a great risk-benefit ratio. Now, in the future, we clearly need to have better protective agents. So I am actually later today giving a lecture to my American colleagues where I'll be presenting some of the initial results with our riluzole trial. But I can tell you that we've just had an interim analysis on our randomized controlled trial with riluzole. And I'm pleased to say that we have achieved a very strong signal with riluzole. So we'll have to see what the final results show with the RCT. So I would say right now it's an option to use steroids. I would use them carefully. I would not use them in older or sick patients, probably not thoracic ASIA A. Younger patients, particularly cervical injuries, I think it's a reasonable option.
Would you use it in Central-Cord syndrome, particularly because the data is suggesting that the Asia scores are more relevant?
Yeah, so I would, unless the patient was older with a lot of medical comorbidities. So if it was an older individual with diabetes and so on, I probably wouldn't use it, because there's also evidence that if you adversely impact glucose control, that can also have a negative impact. But say I presented the case of the young woman, 50-year-old, well, young for me, with OPLL. You saw it was an actually interesting case. I managed her posteriorly, by the way, with a laminectomy and insulin infusion. And I did use corticosteroids in her, and she actually made an excellent recovery. She recovered quite nicely and had no ill effects from the corticosteroids. But if that person, might have been, say, somebody in their late 70s with diabetes or various other medical problems, I probably would not have used it. Okay, so one needs to be selective. This is why I was saying that we need to take the issue with corticosteroids out of the lawyer's hands and into the doctor's hands, and it's an option. And I think, you're all, mature doctors, and you are aware of the pros and cons, and this is why you go to medical school. This is why you do your residency training, and so it should be up to you to decide when to use them. And, it's not the panacea, for sure, but it's also not the death wish, which has been, there's been some, I think, hyperbole in this regard.
And one final question was on stem cells. So I think there's quite a few stem cells been, at least in the UK, they are now recognized for treatment of spinal cord injury and knee surgeries and things like that. And there's a trial going on in the States on the fat stem cells and, of course, the hematological. So please tell us your feelings on this.
Yeah, so it's an evolving topic, and in fact, I'll just do a shout out to one of my former fellows, Mark Cotter, who's at University of Cambridge, and Mark's doing some very innovative translational work with stem cells. It's an evolving field. We're at an inflection point in the field of stem cell biology, and previously we were trying to use various cellular therapies because we didn't have the technology to develop neural stem cells. The reality is to rebuild the central nervous system, the optimal type of stem cell is a neural stem cell, and optimally from the patient themselves. And we now have the technology to do this. So the future is going to be with either what are called directly reprogrammed stem cells, or with induced pluripotent stem cells derived from the patient themselves, and then also engineered to be specific for the region. So it's very cool technology. And so we're about to see in the next year or two some very exciting clinical trials that could truly potentially have a big breakthrough. Now, in the meantime, for sure, so there are studies that are going on with mesenchymal stem cells. They appear to mainly have an immunomodulatory approach. They don't actually transform into nerve cells, but they do appear to modulate the inflammatory response. So in a sense, they're sort of like a cellular type of methylprednisolone, maybe without some of the systemic side effects of immunosuppression.
I'm going to pass the microphone to Naren. You've got a question.
Yes.
Professor Felling, there's a couple of questions coming up on the chat on spinal cord stimulation and other questions like collars and other things that perhaps you would want to look at. Go ahead, Naren.
Thank you. Thank you very much, Girish. Thank you, Dr. Fellings. I think the methylprednisolone is an old chestnut. You probably have been asked this question so many times, but I just want to come back to that because whenever there's a patient, whether it's old or child with a spinal cord injury, the big controversy in every hospital is, should you give it? Should not you give it? One doctor says yes, one doctor says no. So sorry for coming back to that point. In your opinion, is there enough data on methylprednisolone in pediatric spinal cord injuries? I know you mentioned young patients. And the second one is that one of the points is that the dose was in the initially calculated very high. Is that a justified criticism? And the third one, I'll come back to that. Thank you. Cheers.
So there are no data in children. So the data are all inferred from adults. In general, I would use it in anyone with an acute spinal cord injury unless there was a medical contraindication. And our concepts of what are Asia A is starting to evolve as well. So in Staskus, it was a big shock to people when we reported a 44% conversion rate of Asia A patients, and we have the new data on the thoracic injury. So I would use it unless there is a contraindication, recognizing that the effect sizes are going to be relatively small, but you're trying to look at additive effects, and smaller changes may not be important in a patient with a thoracic Asia A injury, but in a patient with a cervical injury, if you can recover hand function, that can be quite important. So unfortunately, the regulatory authorities impose severe restrictions on doing clinical trials in children. I think it's crazy, to be honest with you. I think it's actually harmful to society, but these are the legal restrictions. And so, for example, in our riluzole trial in acute spinal cord injury, we were forbidden by the regulatory authorities to take this into children less than 16. I was able to get permission to go to age 16 because there's just some arbitrary legal definition that a 16-year-old child should be treated medically like an adult.
And in terms of the dosage, Dr.
Oh yeah, so this is actually quite well worked out, and the basic science here is actually really good. And I know the basic scientists who did this, like Ed Hall, for example. He was at Upjohn at that time with Mark Brogler. These guys were superstars in terms of the science. Like the science was fabulous, and I've heard criticisms about this. Like this is. I'm sorry, but I object to that. The translation to the clinic is another thing that's more challenging, but the basic science is strong. The dose is really high. It's a really high dose. I know this. Every time we use it, everyone is like, oh my goodness, it's a really high dose. What can I say? This was a dose that was studied in the randomized trial. So you either are going to use the dose that's in the randomized trial, or you're going to start making it up on its own. Right. And, I sometimes get asked, well, can I use, say, dexamethasone? And we're more familiar with the use of dexamethasone, of course, in the clinics. And of course, you can use whatever you want, but there isn't really the strong evidentiary basis to support that.
Thank you. The third question is, I think a couple of people have mentioned it on the chat box as well. Certainly, we had lectures on decompressive craniectomy for brain, in terms of duroplasty or actually decompression for everything to settle down. Is there any evidence for it, or is there any movement regarding that? I know.
Yeah, so it's a hot topic. So of course, Mr. Papadopoulos in the UK is has been a proponent of this. In East Asia, some of the Chinese surgeons are kind of advocating for this. So Mr. Papadopoulos has got a small case series suggesting that potentially, there might be a role for this. So I think it needs further study. It's not being widely adopted. It's probably not necessary in all patients, but there might be a subset of patients where there's a lot of swelling. I think here, potentially the use of intraoperative ultrasound might be a very interesting imaging tool. So if you, for example, do a posterior decompression, you could image the spinal cord very easily, and then you could make a clinical assessment of whether it would make sense to do an expansile duroplasty. I mean, this is not unlike other types of, like I operated yesterday on intramedullary astrocytoma. I ended up doing a duroplasty because I was concerned that the cord was still swollen, right? So we do this surgically. The concern has been, I remember my teacher, Charles Tatter, told me, don't ever, ever, ever open the dura. The spinal cord will kind of come out at you and so on. So this is kind of stuck in my brain, but this may no longer be entirely valid. So what I would say is that currently I'm not doing expansile duroplasty routinely in my practice. I'm watching the literature quite with interest. And this kind of gets back to the point where I think that there needs to now be a lot of attention in terms of the actual techniques of surgery, and where do they work, and what are the optimal techniques, and trying to personalize the approaches for the patient. but also it's critical, and I really want to encourage surgeons to do this, image your patients after decompression. See what you've done. I do this for all of my patients with cervical myelopathy, and I've learned a lot on the techniques of decompression and what works and what doesn't work as well. And I would encourage people to do this in spinal cord injury as well.
Thank you very much. Mr. Solanki, back to you. Thank you.
Okay, so I think it's really exciting stuff. There was also questions coming out, I think probably not acute management of spinal cord injury, but the use of spinal cord stimulation in spinal cord injury. I think that's coming up more and more. I mean, we've been trying to encourage our physiotherapists, for example, to start using functional electrical stimulation from day one to try and improve the recovery of the grades. What are your thoughts on this?
Sure. So it's an exciting evolving area of technology. So I'll talk about upper extremity and lower extremity. So for upper extremity, the use of functional electrical stimulation is supported by small randomized trials. And in Toronto, we are routinely using this to augment hand and upper extremity function. Okay, so I would support the use of this. For the lower extremities, the idea, which has been mainly championed by the American group of Susan Harcum and Reggie Edgerton, has been the use of epidural electrical stimulation in the lumbar region to stimulate the lumbar central pattern generator to try to assist with the recovery of walking. And there are small case series which do suggest interesting results. So they had a series of 4 patients in New England Journal a couple of years ago, for example. So these are all very small case series. So I would not say right now that this is kind of a standard of care, but I do think that it needs to be examined, carefully. Does it require a randomized trial? I'm not sure it necessarily requires a randomized trial, but at least a very careful prospective assessment of the outcomes with perhaps a matched comparison cohort group would be useful. And it's certainly something that we are looking at very carefully in Toronto as well. So I think there is something to this.
Fantastic. Professor Guel, you have got some questions?
Yeah. Dr. Failing, this was indeed a wonderful, wonderful presentation. And there is no question that I have learned a lot from your work and from your various publications, which are in plenty. And the more important issues that you talked about is that the surgery for the cord damage is useful and early surgery is important. You see, when I was growing up in this subject of neurosurgery, my professor, who was more of a philosophical person from whom I have imbibed quite a bit, he used to tell me that spinal cord is like God, spinal cord. And the vertebra around the spinal cord are like temple or mosque or church, whatever you have to say. So if the temple is damaged or the mosque is damaged, you can repair the mosque or the temple. But if the God is damaged, there is no point in repairing the temple if the God is damaged. The other thing that he used to tell me, and which I follow and I believe, that you see, you can, if you have to do something, you can make the God comfortable. Don't make the God, don't try to be more than God or try to treat the God like you talk about, doing duroplasty and moving the cord here and there and removing the clot and all those things. So what he used to tell me is leave the God, it will repair. If there is God remaining, it will repair himself to an extent that is possible. At best, make the God comfortable. So what are your thoughts on these kind of philosophical tone which I am giving you?
Well,
do you think the question is, if the God is damaged or if the God is no longer existing, do you think it can come back?
Well,
that is one question.
Okay.
Do you think if the god is damaged, there is any point in repairing the temple or the mosque? If the god himself is not there, what is the temple doing? Third thing is, do you think we are doing surgery, if at all we are doing, to give comfort to our little god sitting inside the temple? What are your take on this kind of off-center philosophical note?
Well, Atul, it's great to see you, and I've also learned a lot from you as well. So very good. So we've had a good friendship over the years, and you've taught me a lot about operating at the craniocervical junction. So we're very appreciative to your innovations in that area. Well, okay. So I would say that one of the benefits of surgery is to facilitate whatever spontaneous recovery and repair can occur. And I think the balance is what is enough and what is too much. And so one of the potential concerns around doing too much is that you might cause harm. And so I was asked about duroplasty, and I have not been doing this in my practice. Now I'm trying to remain open to considering new data, new information, and I'm looking at this. But one of the concerns has been that, are you doing too much? And could you cause harm? And perhaps not. One needs to be open to this, but this has been one of the issues. One of the benefits of surgery, which has become clear, one of the benefits of early surgery is that it at least allows the patient to be more comfortable. They have less pain. You can reduce secondary complications like post-traumatic syringomyelia, potentially neuropathic pain, restoring a correct spinal alignment, having good internal fixation to allow the patient to rehabilitate and to recover are very important. So I think that, these, are perhaps your teacher would agree with these philosophical points that this is important.
Yeah.
The spinal cord has a limited ability to repair, but there is some reparative capacity. We have learned this. And so I would say that with a young person coming in with an AJA injury, please do not write them off and say nothing can be done, because some of these patients will convert. And if you only see 1 or 2 patients a year in your practices convert, you will make a huge difference in the life of these people. All right, and then allow the spinal cord to recover, then see what you're dealing with. And then allow other techniques to try to harness the endogenous plasticity in the spinal cord, electrical stimulation, and so on. So the role of the stem cells, now this is kind of pushing things, right? And this might be a philosophical challenge to your teacher, because here we really are, trying to use the the techniques of regenerative medicine to perhaps take a step beyond. So we'll have to see how that, where that goes. But thank you for the way you phrased these questions. It's
one small little question, which is also very clinically relevant. Like when a person comes with cord damage, when a person comes and he is not moving his legs, it is absolutely important for the clinician to know that whether the cord is completely sectioned or there is still some life in the cord. Now, how do you assess that situation, that cord is not completely sectioned, there is some life? And what are your early indicators that life is indeed there? What are your, we have read in the books, this reflex will come, that will come. But I want to know from you what you think about this.
The imaging is helpful. So we've learned from the imaging, in magnetic resonance imaging, that the cord what was previously interpreted to be cord transections. In fact, usually it's a severe contusion and compression of the spinal cord. Cord transection is quite uncommon. It does occur, but it's quite uncommon. So this can be assessed from the imaging. So one of the areas that I've been trying to advocate is with the use of magnetic resonance imaging to try to define, this. And I realize there are challenges with this, and I'm quite aware of the logistics and so on. But the reality is that we work in an imaging-based specialty. And the images give us data points, and they allow us to assess, the patient. So I think that's an important point. Clinically, a very careful examination is critical. Turn the patient over. Don't just assume that, the patient is Asia A. Look at the subtle changes that can occur that might be indicative of a partial injury. So that becomes important. I referred to the young woman, 45, with a T6 burst fracture. She was sent to me as an Asia A. I turned her over. She had sacral sparing. I operated on her. I didn't show her surgical results, but she recovered to an Asia D, and she's walking. She has a good quality of life right now. So I think that becomes important. And then the third thing I would say is that there are a couple of regions in the spinal cord where small changes in recovery can make a big difference. One is the cervical area. We recognize this because even if a patient remains Asia A, if they recover one or two segments of the cervical cord, that can have a big impact in someone's independence. The other area is the conus. So I recently operated on a gentleman with a T12 burst fracture. He was also labeled as Asia A and, no point. And he was actually operated at another facility. He was not decompressed. And then I decompressed him later, and he recovered substantial lower extremity function. And this has to do with the innate plasticity within the conus, which is a unique area as well. And the physiatrists, the older rehabilitation physicians, used to teach me about what they call root escape. And this is where you would sometimes see patients recovering some kind of proximal segmental function. So these are some of the things that I have, kind of some of the clinical nuances that I've learned over the years.
Thank you, Dr. Felling, and again compliment you for your wonderful work, for analyzing the various, your publications and your constant, persistent, and absolute great presentations in meetings and in publication has been indeed revolutionary and quite thought-provoking. Thank you very much.
Thank you very much.
Thank you, Professor Feldings. I will pass the mic now to Kamal.
Thank you. Thank you very much, Professor. Very great learning indeed. And the way you have tamed how to utilize statistics to create useful recommendation in the absence of solid data. So how we have brought the intricacies of statistics to make it useful to create recommendations is something which is to be extrapolated to various other fields in neurosurgery is what I feel. Thank you very much, Professor. It was great learning indeed.
Thank you very much. And shout out to my good friend, Rick Fessler.
Yes, we'll do that. Thank you very much, Dr. Felings. Most grateful. Look forward to having you in future meetings.
Thank you very much, everyone.
Thank you, sir.
Okay.
Thank you.
Great meeting.
Thank you. Dr. Prasad, can I ask you to, take the next talk, please, Dr. Prasad?
Happy to do so, Naren.
Dr. Fessler, we are slightly running late, Dr. Fessler. So I got few presentations. I think it's already 5 o'clock. Shall we? Can we go to Dr. Fessler? I will speak to the other speakers. Dr. Fessler, we'll jump to you first. Dr. Komar Prasad, you want to introduce Dr. Fessler, please? Thanks.
Dr. Fessler he requests no introduction. from Chicago University, and just a sec. And I would invite him to start his presentation right away on minimally invasive surgery for adult scoliosis. Professor Fessler.
I'll just get the presentation. I'll share the speaking with you. Just a second, please.
The host, Naren, you need to enable screen sharing.
Yeah, I just enabled it. You should be able to now, Dr. Fessler. Thank you.
All righty, let's go right here. There we go. Are you able to see that, Naren?
Yes, please. Yeah, we can. Yes, thanks.
Great. All right. Hello, everyone. It is morning here in Chicago. I'm sure it's afternoon and evening elsewhere, wherever you are. Have a nice day. We're going to talk about minimally invasive surgery for adult degenerative scoliosis today. And we're going to talk about who are candidates, when are they candidates, and why is minimally invasive surgery a good option for adult scoliosis. These are my disclosures. None of them are relevant to this talk. This talk is going to be based upon many papers that our research group has now published. These are just a few of them, but our minimally invasive research group for scoliosis probably is in the range of 60 or more publications at this point. And that's the data that this talk is based on. We all know that there are advantages of minimally invasive surgery, that there is less blood loss, lower infection rate, less stress response, shorter intensive care and hospitalization, less requirement for pain medication, recoveries are faster, there is decreased soft tissue destruction, but there are other questions relevant to minimally invasive scoliosis correction that we need to consider. For example, can we actually decrease the number of levels that have to be fused when we're correcting scoliosis? Can we lower the incidence of proximal and distal junction failure by doing it minimally invasively? And can we do it less expensively if we do it minimally invasively? And the other questions are, if we use minimally invasive technique, will it increase or will it decrease complications? And do we have the ability to correct sagittal deformity as well as we do when we do it open? And can we do complex cases minimally invasively, or are we really limited to the kind of the more simple kind of straightforward degenerative cases? So for example, here's a retired nurse with a nearly 50-degree, very rigid, not terribly rigid, in fact, she bends out a little bit, as you can see in these things, lumbar scoliosis, compensated by 21 degrees at the fractional curve and 13 degrees up in thoracic curve. You can see a bunch of staples here. She's already had a kidney resection for cancer, and that may influence the way we want to approach our surgical technique. If we are going to do correction of deformity using minimally invasive technique, we have to be able to do all of the techniques that we do when we do open surgery. Specifically, we need to be able to do lateral lumbar interbody fusions, or anterior lumbar interbody fusions, or transforaminal lumbar interbody fusions. We need to be able to do a posterior midline incision. The only thing we cut is skin, and everything else is done by dilating through the muscles. We need to be able to do percutaneously pedicle subtraction osteotomies, Smith-Peterson osteotomies, facet fusions. We need to be able to do percutaneous pedicle screws, and we need to be able to pass percutaneous subfascial rods. So we do this by starting in a lateral position for the lateral lumbar interbody fusion. We support the body with a beanbag. I use an arm support so that the weight of the arm does not cause the body to shift positions. And we tape the patient to the bed. And it's important to tape the, to tape the patient, not towels. What, the nurses are always concerned that, they want to put tape on the patient's skin, so they always put a towel down there. Well, that doesn't really hold the patient. It holds the towel, but not the patient. And very often you have to change the angle of the bed significantly in order to get a true lateral approach to the disc space. So I always take the towel and throw it on the floor and tape the patient. You can see the patient's taped here on the hips, on the shoulder, and there's also one on the legs as well. I position the patient over the crack of the bed so I can increase the space between their lower ribs and their pelvis. And if necessary, you have to turn the bed in order to get a good lateral approach. You want a perfect lateral approach at all times to the middle of the disc space. And that's what we have marked here on the skin. I then make my incision. It's usually about 3 to 4 centimeters long, depending upon the number of levels I'm going to do laterally. And I do the entire dissection bluntly. The iliohypogastric nerve is somewhere in the fascial planes between the external oblique and the internal oblique muscles. And you don't want to cut that because the patient then gets a flaccid abdomen and a burning dysesthesia in their scrotum and their penis or their vaginal area. So I do the entire dissection bluntly by piercing the fascia of the external and the internal oblique and the transversalis, spreading my mets. And then through that incision, I will put a stimulator down and stimulate my way through the iliopsoas muscle to make sure that I don't have any proximity to the femoral nerve. After I've stimulated and demonstrated I'm clear, I then push it into the disc space and replace that with a K-wire over which I do all my dilation. There are many different retractors you can use for this. They all work very nicely. They open the space up and allow you to see in very well. For example, here's a retractor in place, and here's what we're seeing at the bottom. Here's the discectomy that's being done. Here's the radicular artery coming right alongside it. And after the discectomy is done, I put in a cage with some hydroxyapatite, and I use a half of sponge of BMP at each level. And in this particular case, we did a 4-level lateral lumbar interbody fusion. To do that, I had to do 2 incisions rather than 1. But you can see we've already achieved a significant amount of the coronal correction just by putting those cages in. We then flip to a prone position, and I make a long midline incision, just cutting the skin. And I use a single midline incision because cosmetically it's much nicer than having 20 or 30 stab wounds going up and down your back. You then do what you need to do. This is a T-lift at L5S1. I no longer do that. What we found was that a single cage done through a T-lift below a long moment arm in a scoliosis correction isn't strong enough. And very often you will get a pseudoarthrosis there. So I now do an anterior lumbar interbody fusion at 5-1, and I'll usually do it at 4-5 as well. That way I get a very large cage in to give me a good base for that very long fusion that we're going to do. And I haven't had any failures since I started doing that. I'd also then do facet fusions at any of the thoracic levels that I need to do. And after that, I put in my K-wires, and you can do this using fluoroscopy or image guidance, however you're comfortable putting in your screws. After the K-wires are in, you dilate, put your screws in, and here are 2 different systems, both of which work very well. So we have this patient, which I just showed you before, and you can see what a nice correction she got. She has excellent coronal balance, she's got excellent sagittal balance, and a good lumbar lordosis. So when we looked at our early results, what we found was that using minimally invasive, open, or hybrid technique, we could get equal correction of the Cobb angle, that is the coronal scoliotic curve. However, our lordosis was not as good with the minimally invasive technique as it was with the hybrid or the open technique. Part of the reason for that was that to begin with, our sagittal balance was excellent in our early patients. So we really didn't have to correct it very much. Similarly, the pelvic incidence versus lumbar lordosis didn't change very much in these patients either. And our SVA, as I said, was essentially normal when we started. So we had essentially no change in their SVA. We were a little disappointed in our results actually with sagittal balance. And one of the criticisms that came very quickly was that with minimally invasive technique, we could not correct sagittal balance. Interestingly enough, though, when we looked at our clinical results for visual analog score for back pain, visual analog leg pain, and Oswestry disability, our results were equal to or better than either the hybrid or the open technique. So even though our sagittal balance wasn't corrected as well as it was with open technique, our clinical results were at least as good. Well, we looked at that a little bit further, and what we found was that when we were working with young patients, sagittal balance was very important. We had to really correct it to normal or near normal for them to get a good result. However, when we looked at our patients that were over 65 years old, sagittal balance didn't make that big of a difference. We only had to get close. We don't have to correct them to normal. And I'll point out that aging is a kyphotic event. We don't have to make a 70-year-old person look like they're 20. We need to give them reasonable sagittal balance, and clinically they do very well with that. Well, what about blood loss in these cases? What we found was that an average blood loss for a minimally invasive case was about 500 cc's. And in fact, I'm down to the point where my average blood loss is somewhere between 100 and 200 cc's for even a 10 or 11 level scoliotic correction. So we've dramatically decreased blood loss, dramatically decreased patients who require a fusion. I can't recall the last time I had to do a transfusion in scoliosis. Operating time turned out to be about the same as open surgery, and significantly less than the hybrid technique. Hybrid technique means you're doing ALIF and lateral lumbar interbody fusions, but your posterior technique is open. Well, what about the question of whether we can create shorter constructs or not? What we found was when we looked at our patients, on the average, we were correcting 5 levels of scoliosis using minimally invasive technique versus 10 for open. Now that may mean one of two things. It may mean that we're choosing easier cases to do in minimally invasive technique, or it may mean that because we're not dissecting the muscles off of the spine, we don't have to cover as many levels in order to get a good result. Because even though we were doing only half as many levels, our clinical results were not significantly different. Well, what about PJK and DJK? Well, what we found out was that when we looked at our long-term results, there was no difference in the frequency of proximal junction kyphosis, whether it was done minimally invasively or open. That was a little disappointing to us. However, when we looked at the distal junction, that L5S1, if we stopped at L5 and then looked long-term and whether the patients required reoperation or not, we didn't quite reach statistical significance because there weren't enough patients, but we were on the verge of it at 0.8. So it looked like, at least for distal junction kyphosis, we may be decreasing the incidence of requiring reoperation. And in terms of cost, when we looked at our hard costs at one university institution, we found that we could minimally invasively decrease the overall cost of surgery and hospitalization by $120,000. And it came at every single thing in terms of length of hospital stay, whether they required blood products, whether they required cardiac ancillary services, in other words, consultations, intensive care nursing, imaging, labs, everything was less expensive going up and down the line. And it was a huge difference in cost. Okay, so what about the questions we were asking? Can we decrease the number of levels fused or instrumented? Yes, it looks like we can. Do we lower the incidence of proximal or distal junction kyphosis? That's the answer isn't in yet. Proximally, it looks like yes. Distally, we're not sure. And can we decrease cost? Dramatically we can decrease cost. Well, what about those other questions we asked? Are we going to increase or decrease complications if we do minimally invasive deformity correction? Can we correct sagittal deformity well enough? And can we do complex cases, or is minimally invasive technique limited to the easy cases? Well, in terms of complications, in a typical open case for scoliosis, the major morbidities are roughly 45%. When you include all morbidities, it's closer to 80 and 85%. When we do minimally invasive technique, we've decreased major complications to 10%. So we have a dramatic decrease in complications. Who is a candidate then for minimally invasive surgery? What we found when we looked at this closely was that there was a significant difference in our correction between minimally invasive and open, and that kind of brought up the question of who can we do and who is a good candidate. So when we looked at it closely, although minimally invasive surgery was used frequently, there were some patients we weren't getting as good of a result in. So we created an algorithm for use to try and decide who can be done minimally invasively and who should be done open. The biggest thing we look at, first of all, is the spine rigid or is it mobile? If there's greater than a 5-level fusion, we feel that should be done open. That's an extremely difficult case to do minimally invasively. However, if it isn't rigid and your SVA is less than 6, your PT is less than 25 degrees, your mismatch is less than 10, and your coronal cob is less than 20, that maybe doesn't even need correction of the scoliosis. It might just be a decompression or a fusion. If any of those aren't true, it kicks you into this middle category where lumbar lordosis and pelvic incidence mismatch is less than 30, thoracic kyphosis is less than 60, and thoracolumbar kyphosis is less than 10. In most cases, depending upon your experience level, probably that needs to be done open. However, if in fact you're quite experienced in your surgical technique, many of us are now going to multi-level minimally invasive decompression, and I'll point out a few of those as examples. So what about correcting sagittal deformity? When we first started this, we didn't have two things that have dramatically changed our ability to correct sagittal deformity. One is that we did not have hyperlordotic cages, which we now have. And if I'm doing a patient who has, for example, 11, 12 or more centimeters of sagittal imbalance, I will use somewhere between a 25 and a 30 degree cage put in through an ALIF at L5S1, and again, a 20, 25 or 30 degree cage at L4-5. And then I will use hyperlordotic cages laterally at 3-4 and 2-3. And with that, we get a dramatic increase in their sagittal plane correction. The other thing I do is we devised a technique called the push-through technique. So after I've got all my screws in place, I will take a very long rod and give it a gentle lordotic bend. The reason we do a gentle lordotic bend is because if you do the hyperlordotic bend that you need in order to get a good lordosis, you can't pass it through all of your towers. The space for the rod to go through the tower is only between 6 and 8 centimeters. And with a very hyperlordotic curve, by the time you get to the 4th or the 5th tower, you can't get it in. So by doing a gentle curve, you can get it through all of your towers. And then I push it out the sacral end so that it comes out of the patient's wound. I will then take either a French bender or some free benders, and I'll put in a very hyperlordotic curve, because then you can pull it back into the towers very easily and then slowly lower it down until you get everything in place and locked down. With those two techniques now, we can correct virtually any sagittal plane deformity. Here's a good example. This patient in the sagittal plane was 14 centimeters off. And by doing that technique and using hyperlordotic cage, we brought her down to normal at 6 centimeters. Well, what about a rigid thoracic kyphosis? Here, for example, a 32-year-old male. He teaches people how to drive buses. And he's just at the point now where he is extremely in extreme pain and can't do his job. And he's got a very rigid thoracic kyphosis here. But using these techniques, we were able to give him a very nice thoracic kyphosis and a near perfect correction of his thoracic scoliosis. Similarly, this is an 18-year-old male who has this rigid thoracic kyphosis. He is a collegiate level basketball player, and we were able to correct his curve very well, and he was able to continue his career as a collegiate basketball player. What about a rigid double major? This is one case that we initially thought were going to be impossible for minimally invasive surgery. Here, for example, is a young 16-year-old girl. She's got a near 60-degree curve here at her thoracolumbar junction, compensated with a rigid 56-degree curve up here. You can see that these don't bend out at all. These are very rigid curves. But we gave her a near perfect correction, completely minimally invasively. Here is another. This is a 48-year-old male, obviously very severe double major curve. And again, really excellent correction with excellent sagittal balance, completely perfect. Rigid thoracolumbar kyphosis. So rather than a lordotic problem, we've got a rigid 35-degree thoracolumbar kyphosis, and he is 9 centimeters off sagittal balance because of that. We gave him, using hypolordotic cages at all 4 levels and facet fusions up above, we brought his sagittal imbalance perfectly in line at 2 centimeters and completely reduced that kyphosis he had. So can we decrease complications in deformity using minimally invasive technique? Yes, we can decrease them dramatically. Can we correct sagittal deformity with the new hyperlordotic cages and the push-through technique? Yes, we can easily correct sagittal deformity now. And can we do complex cases such as major double majors, etc.? Yes, they can be done minimally invasively as well. So in summary then, correction of deformity using minimally invasive technique is a reality now for most types of scoliosis. It depends upon the surgeon's experience, however. If you are an experienced scoliosis surgeon, then you need to learn how to do minimally invasive technique. If you are a neurosurgeon who is familiar with minimally invasive surgery, you need to understand scoliosis before you tackle these. And if you are not familiar with either of them, you need to learn both in order to do this. And it's a long learning curve. The technology and the experience are still early in development, and the anticipated benefits, however, are clearly proven now. So although the results are still quite early, they are very encouraging for the future. At this point, we can do most scoliosis using minimally invasive technique. Thank you.
Thank you very much, Professor Fester. It was an amazing talk, very futuristic for most of us. And it's really amazing to see minimally invasive surgery is getting into really being minimally invasive. It's highly impressive to note that we can limit the levels fused. That was a big take home for most of us, that if we can really limit the number of segments fused using totally minimally invasive with real reduction in complications, it's really amazing and very interesting presentation. Thank you very much, Professor.
You're welcome. As a neurosurgeon, I never thought that a major part of my practice would be scoliosis.
Can I ask?
That's really amazing. Yes, Naren.
Thanks. Thank you, Dr. Fessler. You mentioned that from going from neurosurgery in UK, many of pretty much the scoliosis surgery is done by the orthopedic spine surgeons. That's why I have been keen to have lectures from you and Professor Zileli on scoliosis, because not for neurosurgeons to let it go. What's your advice for a neurosurgeon who's now a spinal neurosurgeon, if he wants to, what's the motivation for going into scoliosis correction for a neurosurgeon, and how best to compete in the orthopedic spine world, which is well established? Thanks.
Well, yes, so there's two questions. Why would you want to do this as a neurosurgeon? Well, if you're a neurosurgical spine surgeon, what we're finding is that as our population ages, we're seeing more and more patients who have scoliosis. And doing a simple decompression on them will make them worse rather than better. So if we really want to take care of this population of patients, we have to know the basic tenements of scoliosis and how to treat it. And in terms of competing in the orthopedic world, if we do scoliosis through minimally invasive technique, we dramatically decrease complications. I mean, just that alone is going to make a patient want to come to you. If a patient says, I can go to surgeon A and have a 45% major complication rate, or go to surgeon B and have a 10% complication rate, who is the patient going to choose? They're going to choose the lower complication rate.
I think it's as Dr. Komar Prasad said, it was amazing to see what you have done with minimal invasive for such complex cases. Any questions for Dr. Fessler? It's one of those topics, when we are talking about ICPs, head injuries, spinal cord injuries, everyone can ask questions, but with these exceptionally complex spinal cases, it's always a challenge to ask. Mr. Solanki, if you are there, I'll see whether Dr.
Can I ask a question?
Sure, please.
Yeah.
Please.
So I always wonder with segment fusions, do you aim at having bony fusion, and how do you achieve it for extensive long level fusions? Like you mentioned about BMP in lower levels to get a stable fusion, but what about those cases in which cervicothoracic are also included, and how do you achieve a bony fusion there?
So in L5S1 and L45, I do anterior, and that's where we get our bony fusion. And I don't use you don't need to use a lot of BMP, just a little bit, because all you need to do is initiate the fusion. At 3-4, 2-3, and sometimes 1-2, I'll do a lateral. So again, my fusion is occurring anteriorly. Everything above that I do through a facet fusion. And what I will do with that is dilate down, or I actually use nasal specula, because it's so easy. You just dilate through the muscle with the nasal specula. I drill out the facet, and I just put in a quarter sponge of BMP. And I was afraid when I started doing that I would not get sufficient fusions. But when I went back on a few patients to take the rods out or do an extension or something like that, I found that the bone had actually grown up and fused over the top of the screws. So you get abundant fusions by doing facet fusions in thoracic spine. And that turns out to be very easy and fast to do.
Thanks to BNP, that's a very potent this thing. It creates a very solid fusion, even with the small quantities, is what you are saying. That's nice to know.
Exactly, yeah.
I think, Dr. Fessler, this is a common question, certainly for pediatric neurosurgeons. We get it from our spinal scoliosis surgeon. In terms of, I think I asked the same question to Professor Zileli yesterday, so I just want to get your thoughts. If a patient is referred to you for scoliosis and referred to me with syringomyelia but no Chiari, would you go ahead and still do the surgery, or would you look at and there's no Chiari and there's no tethered cord? What would you do? Would you go ahead with a scoliosis correction?
If they do have syringomyelia?
Yeah, if they have syringomyelia but no Chiari.
I don't think there is a right answer for that, because sometimes when you drain the syrinx, their scoliosis resolves. And sometimes if you correct their scoliosis, the syrinx will resolve. So I'm not sure what the right answer is, but I think I would try the smaller operation first, and that would be to drain the syrinx.
Thanks. Thank you. Thank you very much, Dr.
I have
Fessler.
a question then.
Sure, please, Professor Kananjali.
Hi, Richard.
Good to see you.
Hi. You look always younger. That's.
I wish that were true.
Yeah,
it's true. It's true.
And no, my question is a general question about the cervical spine, because now there is the tendency to go from the anterior approach for a degenerative disc or of course, the degenerative disease. But I'm quite confident, and I found very good results in just doing a posterior approach, some modification with minimal invasive of the oldest Scoville approach.
Yeah.
What do you suggest? The posterior approach is still with minimal invasive, of course, approach without the, destroying muscle, etc. Is a good alternative to the anterior approach in cervical spine.
I think it is. And I think it is particularly a good approach when you have to do four or more levels. You know, I'm fine doing 3 levels anteriorly, but I found that particularly in older patients, that if we do 4 levels or more, there's a high percentage of permanent swallowing difficulty, which you don't get if you go posteriorly. So I'm comfortable doing up to 3 levels anteriorly, but I would much prefer to do it posteriorly if I have to do 4 or more levels.
Thank you.
Thank you very much. If that's sure, Professor Grottenhuis, please. Thanks.
Second comment, and
sure.
Again, Rick, it is great seeing you. Well, seeing you here.
Good to see you, Andrew.
Our meeting in Orlando last year, but one of my difficulties in this whole is the lack of a uniform, let's say, outcome measurement for adult spinal deformity. It's very, therefore, if I read literature, it is so difficult to compare. You are very strict in this whole, but many others are not. So it is so difficult to compare the results of the different treatments.
Yeah, yeah. You know, it's interesting. So with our research group, the International Spine Study Group, we uniformly collect VAS back, VAS leg, the SRS score, Oswestry disability, and then all of the parameters that we look at for balance and all of that. Recently, we
sorry, Dr. Fessler, you can come back. Thank you. Dr. Fessler, you have to unmute your mic, please. Thanks.
On the left lower angle. Yes, you are muted.
So recently, we looked at our data and we looked at the best 20% with the outcome on the Oswestry disability, and then the worst 20 on the Oswestry disability. And we looked at all of the other parameters to see if we could predict preoperatively who's going to be good and who's going to be bad. And we couldn't. There was no obvious predictable variable.
And that is, recently I was the opponent at the defending of a thesis of a young orthopedic surgeon defending his PhD thesis on outcome measurement in adult spinal deformity. And the interesting fact is he asked worldwide from all 5 continents, many people on more than 100 issues on what they would think is important, like breakage of an implant. And the interesting thing is that all these specialists didn't consider returning to job, being able to do their hobby, and so being of any importance for the outcome. And that was interesting for me, because I think patient-related to the prompts that we always say, the patient will consider this extremely important. Can I do what I did before I developed over years this deformity? So this is, I think we should go also more to these, and the few prompts that are there are too simple, to be very honest. But I think it should much wider in this respect to see what we really do, because the imaging looks perfect, and but it depends on how the patients are really doing.
You know, you're absolutely right, Andre. And another thing we looked at, we just took the one question from the SRS 22, and the question is, would you do it again?
Yeah.
And a surprisingly high number said no, and it was not correlated to their outcome.
Wow.
There was an equal number that said no if they had a great clinical outcome, as there was who did not have a good clinical outcome. So we're trying to put our heads around this and figure out what the heck is going on.
Now, it is, I think, the whole experience around the surgery. For other humans, I mean, for us, it is a daily business, but for the others, it's a life-altering event undergoing this.
Yeah.
And the whole experience in the approach from the doctor, the approach from the nurses, how they experience waking up from surgery, how the first days of stepping around again, and especially what I noticed in many outcome, I once delivered a lecture on what is a good outcome in neurosurgery generally.
Yeah.
I think there is a general fear when the patient is discharged to his home again, and nowadays that is within 1 or 2 days max. In former times when we were trained, they were in the hospital for 3 weeks.
Right.
But then the good thing was, the doctor was always available, and he could also always answer the questions. And now the patient is back home, feels a little bit aching there, feels a little bit there. The wife is saying, "Oh, but that is looks swollen," and the anxiety is amazing around. And I think if we can tackle that we what we do at our department, every second day they get a phone call from our physician assistant and asking how they are doing. It's amazing how well they perceive that, and how well all of a sudden when we measure this now, and this was not actually spine surgery, it was for subarachnoid hemorrhage, but how well they think, how much better they feel everything went. It's incredible. Incredible.
I think that's very important. I agree. And now that you mentioned it, I don't think we don't do enough of that in my practice.
Because it is time consuming. You need somebody to do that.
Yeah.
And we have,
expensive.
Yeah, it is. But it is worthwhile, I can tell you. Okay.
Now,
Thanks a lot for such a great lecture again
great to see all my friends.
Yeah, for me too.
Thank you very much, Dr. Fessler. Great, thanks again for your support. Look forward to your continued support. Thank you very much. We are going to go through a few free papers and then come to Dr. Shakers as the last lecture. I had told Dr. Shaker that he will follow you, Dr. Fessler. I know that you are both with that book. You are both joined by the book. So first of all, I'm just going to ask Albert Allen to give his oral presentation. Albert, so he's going to talk to us on hippocampal RNA expression, gene sets and biological pathways with prognostic value for seizure outcome following anterior temporal lobectomy with amygdalohippocampectomy. Albert Allen, he's from Arizona. Albert.
Hi, thank you so much for having me. I just wanted to double check, can everyone hear my microphone?
We can. You need to share your presentation for us, please.
Perfect. Perfect. Can everyone see the presentation with my?
Absolutely, yes, absolutely.
Perfect. All right. Well, thank you so much for having me. I would like to start off by saying how thankful, honored, and humbled I am for being selected to give this oral presentation at the World Neurosurgery Webinar Conference. I would also like to thank my mentor, Dr. Martin Winan, and the Neurosurgery Research and Education Foundation for awarding me the 2019 Medical Student Summer Research Fellowship. Without them, this research would not have been possible, so I would like to thank them for their sponsorship. Okay, so approximately 1% of the US population suffers from epilepsy. 30% of these patients are medically intractable and potential candidates for epilepsy surgery, most commonly AH with or without ATL and temporal lobe epilepsy. Unfortunately, even with these surgical treatments, 35% of patients still remain with persistent seizures. Thus, there is much need to develop and improve prognostic value of selection criteria in order to decrease the percentage of patients that have persistent seizures after AH. Identification of sequence RNA biomarkers will establish gene expression profiles in patients with different seizure outcomes. Furthermore, sequence RNA biomarkers will help elucidate the pathophysiology of the neuroinflammatory response of temporal lobe epilepsy. And we're slowly going into the era of precision medicine, and there's going to be a lot of exciting things in the future. So this is a very nice project. So we performed whole transcriptome sequencing to test the hypothesis that hippocampal tissue RNA expression differs between patients when they're seizure-free SF and non-seizure-free NSF to establish predictive prognostic biomarkers based on gene sets and biological pathways following ATL-AH. So we had a total of 14 patients, mean age 33.1, ranging from 16 to 56, with 10 males and 4 females with intractable TLE that have undergone ATL with a 1-year minimum follow-up dichotomized into seizure-free and non-seizure-free. Logistic regression analysis of next-generation sequencing hippocampal RNA expression data reveals sufficient statistical power in this cohort for prognostic value of the hippocampal tissue RNA expression. So here we have a diagram I designed that highlights the pathophysiology of temporal lobe epilepsy based on the neuroinflammatory response that the breakdown of the BBB inside the brain. So once the pathological sequence starts, some form of pathology starts in the the brain, you go ahead and get an essentially, sorry, I lost my place here. You get an increase in the innate immune system, complement system, and adaptive immune system, toll-like receptors, interleukin-1 beta, interleukin-6, tumor necrosis factor alpha, prostaglandins, platelet activating factor, cyclooxygenases, and phospholipase A2 and chemokines. And these are part of the arachidonic acid pathway, some of these metabolites. So just want to just kind of walk through. This is the blood-brain barrier, as you can see, and we've always talked about how it's immune privileged, but as we learn more, we're starting to realize that may not be the case. So these inflammatory mediators essentially decrease GABA-mediated neurotransmission, which increase the release of glutamate and increase extracellular potassium concentration. The increase in extracellular potassium concentration raises the NERDS potential, resulting in a higher resting membrane potential, increasing the chance of ictal firing. This all leads to neuronal hyperexcitability. These constant insults increase vascular permeability in the breakdown of the BBB. So you see the breakdown here. And then unfortunately, with further upregulation of adhesion molecules such as P and E selectins, vascular cell adhesion protein 1 on the luminal side of the endothelium forming the BBB are seen in the epileptic brain during seizures. This results in trafficking of leukocyte adhesion and transmigration across the vascular endothelium, creating leakage and infiltration of inflammatory cells into the hippocampus. So there's the trafficking there. Likewise, the leakage of serum proteins such as albumin through a disrupted BBB is hypothesized to bind to astrocytic receptors, which impair buffering of ions and neurotransmitters at the cellular level. All these components perpetuate this neuroinflammatory insult, which leads to neuronal cell death. So I would like to take a moment here to focus on this particular pathway that contributes to the pathogenesis of the blood-brain barrier in TLE. Activation of matrix metalloprotease degrades the extracellular matrix, disrupting the blood-brain barrier, increasing leukocyte communication and increased neuronal hyperexcitability. As you see in the figure, this pathological sequence can go in multiple directions, ultimately leading to a perpetuation of epileptogenesis and increased seizure onset. So we have found that there are we have found that there's upregulated hippocampal RNA expression gene sets profiles in seizure-free outcomes compared to the non-seizure-free cohorts in these sets of patients. To be clear, patients that express these hippocampal RNA gene expression values and biological pathways result in seizure freedom, a desirable effect that we hope to achieve as a positive indicator for improved prognostic and selection for surgical candidates with medically intractable epilepsy. The first biomarker is UGT2B17. It's a protein coding gene that is involved in glucuronidation and phase 2 conjugation of steroids. Neurosteroids derived from cytochrome P450 may be neuroprotective against neurodegeneration, ischemia, epilepsy, and hippocampal structures. Likewise, increased P450 expression is associated with longer status epilepticus latent periods, while inhibited biosynthesis of neurosteroids produces more rapid seizure onset. Neurosteroids have been suggested to modulate the expression of GABA-A and NMDA receptors, which may play a role in regulating anti-epileptogenesis. Elevations in hippocampal UGT2B17 expression may be associated with a decrease in neurosteroids, perpetuating seizure onset. Increased expression might modulate hippocampal neuroinflammation and perpetuate TLE pathophysiology. Likewise, increased testosterone glucuronidation affects seizure activity by decreasing the conversion to neurosteroids in the brain. So we already discussed the pathological sequence in the previous slide regarding the matrix metalloproteases that has a neuroinflammatory response in the BBB. As you can see, it's upregulated in the MMP8 and MMP13. Furthermore, KCNU1 encodes a voltage-gated ion channel, allows the outward flow of potassium ions in the plasma membrane, resulting in the hyperpolarization in sperm. In my animated diagram, we saw how an increase in extracellular potassium concentration raises the Nernst potential, resulting in a higher resting membrane potential. Remembering back to our neurobiology, this increases the chance of ictal firing and neuronal hyperexcitability. Lastly, SPAM1 expressed in our resected hippocampal tissue is a multifunctional protein that enables sperm to penetrate oocytes. Upregulation of SPAM1 is involved in microglial activation during the neuroinflammation and degradation of the extracellular matrix, contributing to the pathological sequence seen in the neuroinflammatory response on the blood-brain barrier. So to be clear, in this figure, that express these hippocampal RNA gene expression values and biological pathways results in non-seizure freedom, which is not a desirable effect, as these patients express these genes, sets of persistent seizures. So essentially, thus patients that express these biomarkers will guide selection of temporal epilepsy surgical candidates. So as you can see in this table,
Albert,
it's very...
Albert, you have got 5 minutes, Albert. You have 5 minutes to wrap up.
Okay, perfect.
Thanks, Chair.
So, just to, this diagram, definitely, it's one of my last ones, and we're next on to the conclusion here. So as you can see here, there's a lot going on in this diagram here, but just the take-home message, we've seen an increase in patients that unfortunately, after the surgery, the seizures didn't stop. We saw an increase in immunoglobulins and the activation of the innate and adaptive immune system, and stuff like NF-kappa B and all these things that unfortunately complement system that disrupts the BBB even more. So all in all, the exploration of the cellular and molecular mechanisms associated with neuroinflammation are of crucial importance in understanding the pathocellular physiology of TLE. In the era of President Obama's precision health initiatives, I speculate that genetic testing will personalize medicine, heading our approach into the era of neurosurgical genomics, thus enhancing selection of temporal lobe epilepsy surgical candidates by establishing a predictive prognostic biomarkers for successful outcomes, as every patient deserves state-of-the-art world-class care. Furthermore, I would like to take a moment to thank a couple of individuals that have made a difference in my life. While spending 3 years on the streets as a homeless teenager in America, Dr. Martin Wine and Shauna Wine have paved my path and to turn my dreams into becoming an academic surgeon into something I can grasp. They have become the family I've always longed for those hard times of homelessness. By putting God first in everything I do, He has protected, directed, and opened doors to a life filled with an opportunity to serve my community through the practice of medicine. As I think over all the awards and achievements, like being named Tucson's 40 under 40 most influential in my city and state, fills me with joy, because I am remembering that boy who used to sleep under makeshift shelters, navigating the fragility between life and death as a homeless teen in America. The shame that I felt back then has definitely been replaced with joy, but this joy is tempered by a sense of responsibility. I decided to become a doctor not only to pour my passion and tenacity for life into something bigger than myself, but also because I genuinely want to help people both in and outside the hospital. As I remember and reflect and humbly try to model myself after my mentor's footsteps, I remember in the words of our founder that a physician is obligated to consider more than a disease organ, more even than the whole man. He must view the man in his own world, a world where warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. These are all the mentors from around the world that have helped me along my path. You know, it takes an army to create a neurosurgeon, but it takes even a bigger army to create a neurosurgeon from homelessness to where I am now. With this year, I've added even more mentors now from the Mayo Clinic, as I'm starting a research collaboration and position with them. Furthermore, I know Dr. Nathran from a while back in the Hershey, Pennsylvania International Neurosurgery Residency course. Great neurosurgeons from around the world have talked about a lot of philosophies and quotes, and I found a kind of a similarity between all of them. I wanted to bring them up here really quickly. You can look at them because, what's neurosurgery without philosophy? Also, this is Dr. Jimmy Van Kuppel's 10 Rules of Success that he gave to us in the sub-internship at the Mayo Clinic, Rochester, one of the greatest institutions for neurosurgery and the practice of medicine. Furthermore, I've spent so much time working on this, but better than 1,000 days of study is one day with a great mentor. Lastly here, Mayo Clinic, one of the best hospitals in the world, all started with a simple handshake between Sister Mary Alfred Mose and Dr. William J. Mayo. Simple but well seated on core fundamental values from a vision from God that this place of practice will be the best hospital in the world. The core values of faith, hope, and science, treating and looking at all patients like they were Jesus Christ. Regardless if you are not part of the Mayo system, I firmly believe if you humbly commit yourself to these values, we as a union of forces will be able to build multiple clinics like these that will outreach the four corners of the world, having one mission, the mission that the best interest of the patient is the only interest to be considered. And in order that the sick may have the benefit of advancing knowledge, union of forces is necessary. Last but not least, it's a great quote. Would like to put it in here. If you can look at it here, it's a very nice quote by Harvey Cushing. This is a quote that I learned from Dr. Daniel Barrows. This is what we strive, fortunately, with the typical neurosurgical square, the professional career unfortunately takes the majority of life, but it's also important to remember your family and social obligations. You can get, you can't get a C+ here. You need to get an A in family and spiritual and physical. But yeah, thank you so much for your time, and that's it.
Well done, Albert. Thank you very much for your talk on the epilepsy and how this is not just taking the lesion, but there's more to it than that. Thank you very much, and I look forward to great things from you. Keep with your studies and your research. Well done. Congratulations. For the sake of time, I'm just going to move on to Dr. Khalil ID. Dr. Khalil ID, do you want to share your presentation, please?
Yes, sir. Can you hear me?
Yes, I can. Yeah.
Okay. Well, can you see my screen now?
I think you are starting to share screen, yes. So Dr. Yes. Khalil IID from Tunisia, he has been very very industrious, well done, young man. And you have to, for all the delegates, you have to also see his posters. If you go to the conference website, I'll give it at the end of the meeting. You can go and see the posters, and the posters go to the YouTube, and you can put the comments below it for questions. So Dr. Ayadi is going to present on rachisis, a case report. Thank you.
Thank you, sir, for your kind presentation. My case is about rachisis. It's about a case report of a newborn baby boy with no parental consanguinity history. He was due to a pregnancy that was not monitored at all. So at birth, we discovered a red mass located in his back. We were scared. So the boy was paraplegic. CSF was pouring from this lesion, so we had to patch it up with a sterile towel. Unfortunately, he developed meningitis. We treated him with antibiotics, and unfortunately, he died at day 15 of life. These are some pictures of the boy and the mass and the MRI of the baby. And we know that the baby has a brain, so there is no anencephaly. So what is rachisis? Well, it is Greek. The word has a Greek origin from rachis, which means spine, and chaisin, which to split. So it is a developmental birth defect of the neural tube. It occurs in utero around the 3rd or 4th week after conception, when the posterior neuropore of the neural tube fails to close. As a consequence, the vertebrae overlying the open portion of the spinal cord do not fully form and remain unfused and open, leaving the spinal cord exposed. It is a multifactorial etiology and is most typically accompanied by other defects, especially anencephaly. It is a severe condition, and survival rates of fetuses are extremely low. Fetuses with this condition often spontaneously abort, and when they arrive at birth, babies are born with, they have high mortality rates. If a sibling in the family has rachisis, there is an increased risk that another child can develop the condition, and there is slightly higher chance that females develop the anomaly than males. Initial diagnosis is typically done by ultrasonography during pregnancy monitoring. Fetus affected typically show cranial abnormalities and deformities. After the suspicion with ultrasonography, we do an MRI, a fetal MRI, that confirms the diagnosis. In fact, the lesion can appear anywhere from the cervical region to the sacrum and can affect all the spine. Well, we advise medical termination of the pregnancy when diagnosis is confirmed by the MRI. In conclusion, rachisis is a rare and severe condition. Due to poor prognosis, we focus on prevention of the disease. Folate supplementation is recommended before conception and throughout the pregnancy, and pregnancy should be well followed up, especially in low-income countries, and termination should be advised when the condition is diagnosed. And thank you for your attention.
Thank you very much, Dr. Ayadi. A tragic case, but I don't think there's much you could have done. If Mr. Richard Edwards there, Mr. Edwards, do you have any reflection on that case? Have you seen anything like that? Mr. Edwards? Okay. Is any of the pediatric neurosurgeons here seen anything, any rachisis yourselves? I think it's a very rare case, certainly in UK, as you said, intrauterine fetal diagnosis with ultrasound and probably in most cases leading to termination. But thank you very much for that case.
Thank
Thanks
you,
for
sir. Thank you.
Thank you. The next presentation is from Dr. Gabriela Ferreira Calkman from Brazil. She's going to talk to us about Cingulotomy to non-oncological pain literature review. Dr. Calkman, thank you.
Hi, can you hear me?
Yes, very well. Thank you very much. Thank you for joining us. Thank you.
Okay. Hi, I'm Gabriela Kalkman, and I will present the flash presentation Cingulotomy to non-oncological pain literature review. And this study was performed by me and my colleagues, Sonia, Isabella, Laura, Milena, and Dr. Tanya. The objectives will be present a systematic review, analyzing the relationship between the role of cingulotomy and non-oncological pain. And the methodology was performed with a bibliographic review, and the term cingulotomy and the term cingulotomy and pain was put in the base PubMed, Cielo, Science Direct, Lilacs, and Trip database. Articles with a period from 1987 to 2090 were selected, a total of 7 articles that met the inclusion criteria, taking into account their citations and their respective impacts. In a quantitative somatic sensory test and functional image of response to painful stimuli before and after cingulotomy for obsessive compulsive treatment, it was shown that cingulate lesions inhibit the ipsilateral paracilium cortex, indicating the functional connectivity between the cortical areas, a strict characteristic of network modulation of pain. In a study with 42 patients undergoing bilateral cingulotomy, to treatment of pain, depression, and mood disorder of these, 80 in the postoperative period were without the initial symptoms, not need a medication or psychiatric support. This is the image of computerized tomography, and we can see tomography cystic areas of bilateral encephalomalacia. These are symmetrical lesions and well-defined in the cingulate gyros. And these lesions have approximately 5 by 7 millimeters, but the cingulotomy does not present surgical mortality or permanent morbidity, may be related to transient confusion, subtle cognitive impairment, such as attention deficits and mild gastrointestinal bleeding. In the conclusions, cingulotomy can be proposed as a treatment for non-cancer pain. And in the areas of the cingulotomy was performed, we can see encephalomalacia during the postoperative follow-up neuroimages. And the cingulotomy can be considered a procedure with no neurosurgical mortality or permanent morbidity. That's how. Thank you.
Thank you. Thank you very much, Dr. Kalkman. In terms of, do you do cingulotomy in your department yourselves?
No, this is just a literature review, and in my department just have oncological neurosurgery, and some surgeries in the awake patients, but we don't perform the cingulotomy.
I think it's the same thing in many places in UK, because functional neurosurgery doesn't have that, it doesn't, usually the pain doctors take over much of the pain. So the functional neurosurgery of pain is not that advanced. And if anyone here does cingulotomies, please type in the chat box and I'll bring you in. But this is one of the areas that neurosurgeons once again have to do more. So thank you very much for educating us on cingulotomy, and I think for patients it's very, very useful. Thanks a lot.
Thank you. Bye.
Thank you. So now I'm going to introduce Dr. Julio Martin. She's from Cobora, from Spain, and she's going to speak to us. I'll just get it. She's going to speak to us about anterior temporal approach for tumors of the temporal lobe. Have I got that title right, Dr. Martin? You have to unmute yourself, please. That's good.
Can you hear me? I cannot share my screen.
Okay, just a second. That's my side.
It's disabled.
That's okay. Okay. You are good. You can take your time. You are slightly running ahead now. So well done.
Okay. So, hello, good afternoon. My name is Julia Martin Colón. I'm a third-year resident from the Reina Sofia University Hospital in Córdoba, Spain. And first of all, I would like to thank you for this opportunity. So I'm going to talk about our experience in anterior mini-temporal approach for tumors of the temporal lobe. First of all, we started doing minimally invasive surgery because it has proven some benefits in reducing comorbidities and having better aesthetical outcomes. So the aim of this study was to analyze our results in temporal lobe resections through anterior mini-temporal approach. We do a retrospective observational analysis of our 7 patients, and we look for the grade of resection, site of craniotomy, survival time, complication, and hospitalization rates. So first of all, for the patient positioning, was supine position with the head rotated until the temporal fossa was parallel to the floor and the head was a little bit angled downward. We made a little skin incision. First, we located the root of the zygoma, and 1 centimeter above from the tragus, we made a 3 to 5 skin mark. We tried to preserve the frontal branch of the temporal lobe. After that, we made the craniotomy. It was tried to make as close to the floor of the middle cerebral fossa as possible, and the average size of the craniotomy was 3 centimeters. So we were able to successfully perform all the resection of all of the tumoral resections. After we did it with the microscope, we used the endoscope in order to obtain a greater view of the resection cavity and of the surgical field. So for our results, we checked with immediately postoperative MRI, and all of the resections were successfully performed. There wasn't any postoperative surgical bleeding. The average size of craniotomy was checked with also with a CT scan, and there were no infections and no damage of the frontal branch of the facial nerve. And the average hospitalization rate was 3 days. So as a conclusion, this anterior mini-temporal approach for temporal lobe resections has proven to be feasible and safety. We had a similar survival time with patients treated with standard craniotomies and with benefits like reduced operative time and stay time in the operation room, less hospitalization rates, less risk of infections. We diminished the soft tissue manipulation and with better aesthetical outcomes with less temporal muscle atrophy and less chewing pain. So thank you very much for your attention.
Thank you very much, Dr. Martin. That's a very nice presentation. Good to know that you are doing having an effective operation with a mini temporal craniotomy. Dr. Prasad, do you have any comments? Dr. Prasad?
Yeah. So it's a good presentation of minimally invasive approach. The anterior temporal area is definitely amenable for minimally minimal amenable, and shown examples of how to utilize it. Congratulations.
Thank you.
Thank you very much, Professor. Professor Groton-Hughes, do you have any? Have you done? How do you do temporal lobectomy? Do you do small craniotomies as well? Professor Groton-Hughes is there?
I'm still here, but I have to check on my...
Thanks.
We do a smaller craniotomies, let's say, than we did 25 years ago. But it depends, of course, on the side, the right side or the left side. We only do that if in the MRI scan is a structural lesion. And that is simply because of the fact that in the Netherlands, the pure epilepsy surgery is concentrated in only 2 centers. So if you find something, you find a lesion on the MRI scan, we can do it, considering it is because it is a lesion. So I have limited experience in that, and I prefer to send them to this to Utrecht, to the center that has more experience in pure epilepsy surgery. Although they don't use any minimally invasive access. No.
Excellent. Thank you very much, Professor Groton-Hughes. Thank you very much again, Dr. Martin. Well done to all the speakers from the late evening session. Well done, the residents. Well done, Albert. So fantastic. So we have now come to the main event from my point of view, personally, with Dr. Lalingam Shekhar's lecture. It gives me immense pleasure and privilege and honor to introduce Dr. Shekhar. Dr. Shekhar, can you hear me, sir?
Yes, I can hear you. I'm here. Yes,
Fantastic.
I can hear you.
Thank
Okay,
you.
good
Thank you very much.
Yeah, good morning. Good morning. Yeah.
Good morning. Dr. Shekhar doesn't need introduction to any neurosurgeons. I will say my words, and then I'll ask Dr. Groton-Hughes to introduce him as a neurosurgeon. For me, Dr. Shekhar is a great hero. We come from same part of the heritage. He's from South India. My family left South India about 1,000 years ago. So when I came to Britain, it was always nice to see that someone from my heritage is top of the game, and it gave me a lot of confidence. Now we have got the Vice President elect also sharing our heritage, so we have few people. So that's my personal thing. Thank you very much. And I had been a medical student, elective medical student in Seattle before Dr. Shekhar came to Seattle, and then it was an honor to have been an adjunct assistant professor in his department for several years when I was in my senior registrar in Southampton. As I said, just how I met Dr. Shekhar was I was at a AANS conference. He was seeing some posters, and I went and dragged him and showed him my poster on an aneurysm calculator, and that was back in 2004. So that was the great things about good old day conference. You can meet people. So thank you very much. But may I ask Professor Andre Groton-Hughes to introduce Dr. Shekhar as a neurosurgeon? Thank you, sir.
Yeah, well, thank you, Naren. But I think you already said he doesn't need any introduction. That's only your hero, but also one of mine. And I consider Dr. Shekhar as a good friend. I know him for over 25 years. His palmares of achievements in neurosurgery are numerous. So do I have 30 minutes for this introduction? Or
absolutely, as long as you want. I always keep Dr. Shekhar's talk the last.
It is way too much. Maybe I think that everyone who ever in neurosurgery was reading something about skull-based surgery came across, actually also together with the other great Indian neurosurgeon Atul Gur. If you read that, you know this is very, very special. Maybe like you, I will add a personal comment to that. I very vividly remember my visits to to Dr. Shekhar when he still was in Washington at the George Washington University, where we performed already in the mid-90s an endoscopy course. There was an Austrian ENT surgeon assisting in the lab. I also assisted in some surgeries. There was an amazing experience. And over the years, we met several times. And one of the times I remember I traveled to India. Last year, actually, when I was in India, the Indian embassy congratulated me for my 25th visa. So that means I didn't even realize that because they have my passport, but they are counting that. And they say, oh, congrats. So I never counted that. But one was in Chennai. And actually, Shekhar was also supposed to be there, but he couldn't. And he asked me at that time to visit his parents and his brother. And of my many travels to India, that was certainly one of the most memorable visits I ever had. So you can see how close friendship can go also in just in a specialty. And from being together, I have learned so much from you, Shekhar. Adopted most of your techniques, and I really feel honored that I can introduce you. You are one of the living legends and giants in our specialty. So with all of us here present, we just look forward to your presentation.
Thank you, Professor Grotenhuis. I have to ask Dr. Goel to give an Indian perspective of the impact of Dr. Shekhar for Indian neurosurgery.
See, the most important sentences made by Andre were the last 2 or 3. He's a living legend. He's one of the giants in the field. I consider him as the father of skull-base surgery, father of cavernous sinus surgery. I consider him one of the most, you see, during those times, 30 years, 35 years ago, cavernous sinus surgery was very, very primitive. To whatever level it is existing today, I will say the most contributory papers, the most contributory work, and the most astounding work, multiple papers on the subject were introduced by Shekhar on pituitary meningiomas, on chordomas, legendary work on foramen magnum tumors. So in general, I have to say that I am going to witness this legendary talk today by a legend in our field and in our business of neurosurgery, and a living legend by no means, Dr. Laligam Shekhar.
Thank you very much. Thank you, Dr. Shekhar.
Thank you. Yeah, thank you very much. I think are we going to play the lecture, Narayan?
Sure. So for technical reasons, so for technical reasons, in case there's an interruption, Dr. Shekhar has already recorded the lecture for the WN's World Neurosurgery Conference. So I'm going to play it from this end, and then Dr. Shekhar is going to answer the questions. So let me get this right. Let me go. Okay.
While you're doing that, okay, go ahead. Yes, it's good.
Yeah. Okay, happy? Okay, so I'll start it now.
In this presentation, we'll discuss a modern approach to vestibular schwannomas. There are basically 3 treatment options for them. The first one, of course, is no treatment, observation only. The second is radiosurgery, and the third one is microsurgery. In terms of no treatment with observation, this is generally employed for tumors that are small in size, and older patients or patients with physiological problems in whom we're not sure about the rate of tumor growth. When the tumor is outside the internal artery canal and also something that starts to grow towards the brainstem, treatment is always indicated. If the tumor is less than 2.5 centimeters in size, radiosurgery with gamma knife is always an option. The patients need to be told about the pros and cons of radiosurgery. Microsurgery, of course, is recommended for the majority of the cases, and we'll discuss how we select the patients for different approaches. Neuromonitoring is important during vestibular schwannoma operations, and this is very critical to achieve good results. So my approach in 2020, again, for very small tumors and tumors which are mainly intracanalicular, I prefer to observe the patients unless they start to have hearing loss, in which case it may be advantageous to treat the patients. If the patient has a tumor that is less than 2.5 centimeters in size, these patients are offered the option of radiosurgery. Of course, we should tell them that the tumor growth is controlled in somewhere about 80 to 90% of the cases over a 10-year period, and some of the patients will still require microsurgical removal. And if microsurgery is subsequently needed, then the cranial nerve results may not be as good. Also, one can think about treating small residues or recurrent tumors when they're small in size. The majority of patients are treated by retrosigmoid, microsurgical, and endoscope-assisted surgery. And for giant tumors, more than 4 centimeters in the CP angle, and especially when the tumor is very large in the tentorial notch, and patients who have very small posterior fossa, a transpetrosal approach is recommended. My tumor treatment philosophy today is remove all the tumor if feasible. However, if it is necessary to save the function of the seventh nerve or the cochlear nerve, the surgeon may elect to leave a tiny remnant on the nerve. Now, in regards to the retrosigmoid approach, the following are the key steps that are followed. The patient is placed in the lateral position. I don't like to use the semi-sitting position that other surgeons employ for a couple of reasons. I think that there are potential problems for the patient in regards to the neck position and also the potential for air embolism. Secondly, it's also not easy on the surgeon. We like to monitor SSCPs, motor evoked potentials, cranial nerve 7, 8, and 10 continuously. We like to see facial motor evoked potentials when present, and we employ in-field stimulation of the cranial nerve 7. Mannitol, steroids, and antibiotics are given at the beginning of the operation. And if hearing is present, one can use a calcium channel blocker such as nimodipine. There's some evidence that it helps preservation of hearing. We employ a curvilinear incision behind the ear. We like to elevate the muscles and layers to reduce the amount of pain. A craniotomy should be adequate down to the floor of the posterior fossa and up to the edges of the transverse and sigmoid sinuses. And we do perform a mastoidectomy to partially unroof the sigmoid sinus so that we can rotate the sinus laterally to permit a more lateral approach. These set of drawings show some of the key steps of the operation. One can see the position here and how we find the position of the transverse sinus, which is a line normally drawn from the root of the zygoma to the inion. And then the sigmoid is oriented along the long axis of the mastoid. Of course, if you have navigation, which is rarely employed, one can also use that to localize them. We make a single burr hole medial to the sigmoid sinus and inferior to the transverse sinus. And in some cases, we make 2 burr holes and connect them with a craniotomy flap. We need to perform additional craniectomy, as we discussed, down to the floor, as well as laterally to include the sigmoid sinus, edge of the sigmoid sinus. The drilling of the mastoid is normally performed with the help of high-speed drills. The last portion should be done with a diamond drill. there is often an emissary vein which needs to be cauterized. And the exposure to the edge of the sigmoid sinus allows the dura mater to be rotated laterally. The first step, which is not shown here in these drawings, is to go down and low and drain the CSF in the lateral cerebellomedullary cistern, which relaxes the cerebellum. You can also go down pretty low if you want to, if the brain is swollen, down to the foramen magnum area, to the cisterna magna. When the tumor is exposed, the first structures that will be seen are the tumor itself, the petrosal vein superiorly, and the anterior inferior cerebellar artery, oftentimes with the subarcuate artery going laterally towards the internal aortic canal, or the IAC. Once the tumor is seen, we stimulate the posterior surface of the tumor to see if the facial nerve is there. This is very rare. We will perform some arachnoidal dissection. If the ICA is stuck to the posterior surface, it'll need to be dissected, and a subarcuate artery can be cauterized and divided. For small and medium sized tumors, I start first by drilling the petrous bone to expose the tumor inside the internal aortic canal. When the tumor is large or giant, I would normally start by debulking the tumor and then exposing the tumor inside the canal. The first step, of course, is to enter the tumor and debulk it using various tools, and then sparing the capsule. So here you see the steps of opening the internal aortic canal. This opening is normally done using a high-speed drill. If the jugular bulb is very large, it may intrude on the lower portion of the IAC, so one must be cognizant of that. If you do get into it, you can pack it with a piece of gel foam or Surgicel and cover it with some fascia and glue it down with some fibrin glue. Normally, we drill the internal aortic canal to a maximum lateral distance of about 8 millimeters from the IAC, but this can also be judged and measured on the basis of preoperative CT scans. Here we see the steps of internal debulking of the tumor. And then once the tumor is internally debulked, we then dissect the tumor in all directions. In order to find the cranial nerves 7 and 8, we can find them either laterally in the lateral aspect of the canal, or more often we find it inferiorly. The 7th and 8th nerves are generally related to the ICA as well, and the 9th nerve, which will be right in that area. The tumor is further debulked. It's very critical to protect the arachnoid plane and arteries, and the nerves 7 and 8 can be preserved by gentle, sharp dissection. I like to use certain specific Roton instruments like a 3 or 9 or 16, and Spechler microcurettes, as well as micro scissors and forceps. The most difficult part in regards to the 7th nerve is as it enters the internal aortic canal, and dissection should be done with constant neuromonitoring. The course of the 8th nerve is unpredictable other than the cochlear nerve. It usually remains inferior and then inferior anterior to the tumor. We did talk about some of the instruments, mainly fine hooks and dissectors. So these are additional steps that show the dissection of the tumor from the inferior aspect, from the cranial nerves, the medial side away from the brainstem, and then finding the 7th and 8th cranial nerves. The 7th nerve is generally anterior to the 8th nerve and a slightly more grayish appearance on the 8th nerve. In addition, it also generally has distinct fascicles that one can recognize. And the 7th nerve, as it enters the internal aortic canal, has the most difficult course or portion right in this area. The 5th nerve is just superior to the upper aspect of the tumor. So when you're dissecting the 7th nerve, particularly in its most difficult portion, it's better to dissect it lateral and medial, and then get to this part where this dissection can be done very carefully by rotating the nerve. And I do not hesitate to leave a tiny piece of tumor on the nerve if necessary to preserve it. And then finally, when we close the internal aortic canal, it is important to put some either muscle or fat up against the bone, because there may be some air cells. I will often use an endoscope to visualize the lateral aspect to see if there are any air cells. So the endoscope in these cases is used as an adjunct to microsurgery to look around corners, etc., and to look in the lateral aspect of the internal canal, also to visualize air cells. Now we see a few patients. This is a small tumor, mainly intracanalicular, but just projecting into the CP angle. One can see on the CT scans where is the posterior semicircular canal. So coming from this direction, we know how much one has to drill. So this will be roughly, this amount is a maximum. So these static images show you first, here you can see the exposure of the tumor. Here are the lower cranial nerves. And this is very likely the 8th cranial nerve. Here we have debulked the tumor, but also we have opened the IAC. And finally, we removed the tumor completely, and this area being the facial nerve. Now in the same case, when we use the endoscope to visualize, we can see a tiny remnant of the tumor, which is then removed. You can see the cranial nerve 7 and 8. And also we can see a small air cell with a 70-degree endoscope. This was an analysis of about 219 tumors which had operated before 2005. I've operated on approximately 500 tumors. And I think my results have improved in time because of the policy of leaving tiny remnants of the tumor on the facial nerve, which don't seem to matter because these remnants rarely grow. And if you are concerned about anything, then you can give radiosurgery. Now, what you can see here is I've categorized the tumors according to their size, small, medium, and large tumors. For the majority of the cases, retrosigmoid approach was used. And in a few patients, we used a transpetrosal approach, and a few a translab approach, and a transmastoid transpetrosal approach only in some other patients. The facial nerve function was categorized according to the recovery of the face. A house grade 1 or 2 facial function, which is optimal. Less optimal is grade 3 or 4, and least acceptable is grade 5 or 6, which means that there was no recovery at all of the face, in which case there was some need for reanimation procedure. That happened only in one patient in the series. 79% had house grade 1 or 2, and of course, much better in small and medium-sized tumors as opposed to very large tumors, more than 4 centimeters in size. In terms of hearing preservation, once again, it was determinant on the preoperative hearing and the size of the tumor. One can see when preoperative hearing is class 1 or 2, based on the Gardner-Robertson classification, about 53% of smaller tumors and only about 22% of medium-sized tumors, and none in the case of very large tumors. What sort of complications were encountered in this series? CSF leak was the most common. It happened in about 14%, and 9 of these patients required some kind of a reoperation. You see aseptic meningitis, wound infection, lower cranial palsy, 1 patient with cerebellar brainstem injury earlier in the series, and 3 patients died 2 were due to medical complications, both unexpected cardiac infarction in the postoperative period. And 1 patient had an unexpected hemorrhage from a ruptured PCOM aneurysm that was unrecognized prior to the surgery. And there have been no deaths in the last 15 years and no strokes in the last 15 years. So this, of course, is a series that predates that period of time before 2005. So we'll see a couple of cases by video just to look at the steps of the operation. This is now a very small tumor, 36-year-old woman who presented with tinnitus and mild hearing loss. And the hearing test revealed pure tone average of approximately 50 decibels and speech discrimination of 56%. And the tumor extends well to the fundus. And some might say that this should be operated by a middle fossa approach. But I find that in every one of our cases, using the endoscope and microsurgery, you can remove all tumors. So here's a patient with a right-sided operation. And basically what we'll see is that with the use of microsurgery, we will be able to see the tumor, and then we use the endoscope to visualize the lateral end of the canal. You can see the internal artery, cochlear nerve, and the facial nerve with the endoscope. Here is this is a 3-dimensional video, and we can see here the opening of the dura mater, and the arachnoid has been opened. And we are seeing here the subarcuate artery. And in this patient, a small branch to the cerebellum was cauterized to avoid traction on the artery. And we are dividing the dura mater, and the internal artery canal is being opened with the help of the diamond drill as well as Sonopet ultrasonic aspirator. Once the dura mater is opened, we can find where the tumor is located. The posterior aspect is generally safe for dissection because both the cochlear nerve and the facial nerve lie anteriorly. Once you identify them, you can actually use a very sharp hook to deliver the tumor from the lateral aspect of the internal artery canal. And here we can see the tumor was arising from the inferior vestibular nerve that's being softly sectioned so that we can remove the tumor. So that's that. And then of course here we are using the endoscope. One can see how there is, you can see the fundus of the canal and the fact that there's no tumor residue. You can see the facial nerve in the superior aspect and the 8th nerve in the inferior aspect. And you can see the cochlear nerve as well. And then we are using a muscle graft to close the air cells of the petrous apex so that the patient does not have any CSF leakage, because CSF leakage through this area is difficult. Postoperatively, the patient did well. She actually had improvement in her hearing by 6-week follow-up, which one can see, and her discrimination score was also increased, and she's had no recurrence. So the next patient is someone who had a very large tumor, 3.9 by 3.6 by 3.3 centimeters, just under the 4 centimeter mark, which I consider the tumor to be large. However, the patient also had a fairly prominent tumor in the tentorial notch. You can see that. So because of this, I had planned initially a a transpetrosal approach, that is a combined retrosigmoid and subtemporal approach. However, when we opened the dura, we found that there were two very prominent draining veins under the temporal lobe, which you can actually see retrospectively on the CT angiogram preoperatively. So we went back just to the retrosigmoid approach. In this patient, interestingly enough, the facial nerve traveled directly up superiorly and then made a turn into the internal artery canal. And this can also happen in some patients. So here you can see that temporal craniotomy has been done and mastoidectomy, and we are ready for a pre-sigmoid approach by drilling the bone over the sigmoid sinus. And when we opened initially, we are draining CSF, and now we're opening the temporal dura, and temporal lobe is slack. However, this is a pre-sigmoidal opening, but I found a very prominent and large vein here. You can see that, and I didn't want to damage them. And they perhaps could have been taken, but there's a risk of brain infarction. Therefore, I decided not to use that pre-sigmoid approach, but completely operate by a retrosigmoid approach, knowing that if we had to, we could go in the pre-sigmoid approach. Here we see the arachnoidal dissection over the lateral aspect of the tumor. The lower cranial nerve are being dissected, as is the inferior cerebellar artery, and we are debulking the tumor, and then we are dissecting the tumor from the brainstem, as you can see here, and further debulking using the ultrasonic aspirator. And the 7th and 8th nerves are displaced inferiorly and laterally, and one can employ the nerve stimulator. And here we are opening more of the internal artery canal using both the drill and the sonopet, ultrasonic aspirator. And the tumor does extend into the IAC. And in such cases, you can drill as much as you need. In this case, hearing preservation is not a consideration. So one can drill. The only thing about drilling that you have to be cautious is that you should not have any cottonoids very close to the spinning drill because it can catch it. So we are dissecting the cranial nerves inside the internal artery canal, and using these curettes, and then further debulking of the tumor, and then starting again at the inferior and lateral aspect. This is just superior to the tumor. The trigeminal nerve is well seen and dissected. And here we see the tumor invaginating the brainstem. Further debulking. So at the end of the resection, you can see the facial nerve goes up and is turning into the internal artery canal, and we see the fat graft being utilized to close the IAC, and this is a patient with a complete resection and also a house grade 3 function after 3 months. Initially, he had a house grade 4, but we recovered within 3 months, and he's working full time. So this patient had also a large tumor, but a fair amount of tumor inside the tentorial notch. So I ended up using a transpetrosal approach. This 25-year-old woman lost hearing in the left ear about a year ago. And this case, you can see the map of the facial nerve. This is also a left retrosigmoid and temporal transpetrosal craniotomy. And here is ligation of the petrosal sinus with the temporal lobe exposed here, and the retrosigmoid area. This is the presigmoid region. And the tentorium is divided and the tumor is exposed. The nice thing about the petrosal approach is that you can readily push the tumor up and away from the facial nerve, which is always the best, both for the facial nerve and the eighth nerve, if you can push the tumor up and away. And of course, here we are dissecting the tumor from the brainstem. And here is tumor well in the tentorial notch area. So don't have much of a retraction there. And I'm also stimulating. And we brought the tumor down now from the superior aspect. You can see the trigeminal nerve there. And further tumor debulking. And then going inside the internal artery canal and drilling it. As I mentioned earlier, I don't always drill the IAC at the beginning of the tumor resection, but in patients who have very large or giant-sized tumors, we just do that later on. So here the IAC is, and in this case, since the patient has no hearing, we actually open into the posterior semicircular canal and the vestibule so as to get a very lateral exposure. And the tumor is being removed from inside the IAC, and we are using Sonopet ultrasonic aspirator to remove the bulk of the tumor. And then we are going to dissect the tumor away from the facial nerve and the brainstem. You can see that once we have isolated portions of the tumor, we debulk it further, and there's a facial nerve stimulating. And later on in the surgery, you see the facial nerve stimulating. There's a little bit of piece of tumor left on the nerve, which we're going to remove as much as possible. That was actually a vestibular nerve that we were cutting the tumor from quite sharply. And the facial nerve stimulating quite nicely in this case, and a fat graft. This is the closure toward the end. We rotate the temporalis muscle as a vascularized flap. And we can also close the dura using temporal fascia. You can see here 5 years after the surgery, no recurrence. She did develop a pseudomeningocele, which resolved with lumbar drainage. At follow-up, her facial function was House grade 1. And of course, she had no hearing preoperatively. So the last case, we'll see some other details of tumor resection. This is a 2.1 by 2.1 by 2.9 centimeters tumor. Once again, 2 years of hearing loss, slight gated taxid imbalance with poor hearing. So here, preservation of hearing is not a goal. So again, here you can see the initial exposure, and this patient had a very prominent loop of ICA going over the tumor, and that was hidden inside the internal aortic canal. So I had to open it and then divide the subarcuate artery and divide it. And finally, we left a tiny piece of tumor up again. So here we see the opening of the arachnoid. This is a left-sided operation. And we are drilling the IAC. You can see that this ICA is looping inside the IAC. And I'm just checking using this Roton 17 instrument, how far we have to go. Now we can start to see where is a subarcuate artery, which is cauterized and divided, which allows the artery ICA to be retracted medially. So we are stimulating the pulsionary aspect of the tumor. We don't find anything. There's the ICA. So I'm looking for the 7th and 8th nerves, although we know that in this patient, hearing is quite poor. Once you have determined that there's no nerve, you can remove large amounts of tumor using curettes and bipolar cautery. And then we can start to dissect the tumor sharply. You can see that arachnoid plane, which is very important to preserve. That's a branch of ICA going to the tumor. And then we are looking for facial and cochlear nerves, in this case, mainly the facial nerve, further debulking of the tumor. So there we start to see the brainstem. Facial nerve is not going to be very far. Superiorly, we should see there it looks like a facial nerve. And ICA. Facial nerve is often related to ICA. So once we see that, we can debulk a little bit more of the tumor. So there is the facial. Here we see that they're intermittently stimulating facial. In this patient, we did not have a good motor evoke potential from the facial nerve, so we could not use it as a guide. However, sometimes you get abnormal activity from the facial nerve. That means that you may be putting some stretch on it or using cold irrigation or something like that, something of that sort. It forces you to stop and reevaluate what you're doing. Now we are kind of rolling a tumor from both sides. There's the facial nerve. So we are nearing the end. There's tumor inside the internal aortic canal. You could see 7 just superiorly. There's 7. And that's the 8th nerve. In this case, we preserved the cochlear nerve, but it's not of great importance because the patient has very poor hearing. Facial nerve is very important, stimulating quite well. Now comes the tedious part of removing as much tumor as possible, at the same time preserving that corner area that I told you about, where the facial nerve makes an S loop. That's actually the cochlear, and the facial nerve is right here. And there, we are stimulating the nerve, and I am electing to leave a very tiny yellow portion of the tumor. A little bit more we were able to remove. There is a muscle graft we are using, and then that's going to be glued on here. So this patient has a complete removal of the tumor, full facial nerve recovery, return to work. Now, what are some of the tricks for preserving the facial nerve? The location is always constant at the brainstem and the distal IAC, but it is variable in between, most vulnerable as it turns into the internal artery canal. Always it's better to work with a thin piece of tumor when you're dissecting the nerve. Monitoring is very helpful. And as I mentioned again, you can leave tiny bits of tumor at the most thinned area. If the nerve stimulates at less than 0.2 milliamperes at the brainstem, or the facial EMG is better than 50%, the patient is assured to have a House-Brackman grade 1 or 2 recovery. Over that threshold, it's hard to predict. It's also important to preserve the blood supply to the nerve. And in some rare cases, there could be delayed paralysis. The exact reason for this is unknown, but I think it's a viral phenomenon, reactivation of virus. You can employ steroids and antiviral agent. Facial paralysis, if the patient has it, most are short-term. They may last 3 to 6 months. You should reassure the patient. You can use a platinum weight or Botox injection and careful attention to the eye. If the trigeminal sensation is also reduced, it's better to perform a lateral tersography to protect the eye from corneal damage. Always ask the patients to keep the nails short to prevent scratching while asleep. And after 2 weeks, transcutaneous stimulation of cranial 7 may be of help. This is not proven by randomized studies, but there's some evidence that it happens. And once the recovery occurs, it's helpful to do facial exercises in front of a mirror specific to muscle groups, and this prevents synkinesis. If the patient doesn't have house grade 1 or 2 recovery, frontalis function may not recover, and such patients may need eyebrow lift surgery. In terms of facial reanimation procedures, if you find the nerve interrupted during surgery and both ends are present, you can do either a 7-to-7 direct resuture or a 7-to-7 graft. If the brainstem end of the 7th nerve is not visible, then I perform a partial hypoglossal to facial anastomosis extracranially, with most of the patients having a House-Brackman grade 3 recovery. One can also employ 2 different branches, trigeminal motor to the lower facial branch and 12-7 for the upper branch. And finally, temporalis muscle sling or neurotized muscle transfer can be used in late cases. In terms of hearing rehabilitation, if good hearing is present in the other ear, one can use a crossover hearing aid. If the cochlear nerve is preserved in continuity, a cochlear implant may be beneficial. And of course, in an NF2 patients whom we didn't address in this lecture, and bilateral hearing loss patients, a brainstem auditory implantation can be useful. Thank you very much for your attention.
That's great. Thank you very much, Dr. Shekhar. Fantastic lecture. Looked so easy, but very comprehensive. Questions for Dr. Shekhar. while we look for questions, can I've got a couple of skull-based surgeons from around the world here. Professor Maurizio Iconangeli from Ancona. Dr. Angeli, do you have any questions to Professor Shaker from what your practice is, what is his practices? Any questions you want to clarify? Thanks. You have to unmute.
First of all, I thank you, Professor Shaker, for this outstanding and comprehensive lecture with enriched by some tips and tricks. That is what every one of us needs from such a big experience. No, I have always some concern about in retrosigmoid approach opening the internal acoustic meatus, especially in the very small tumor located at the fundus of the meatus. What is some tips, some tricks in dealing with this, beside the endoscope, of course, but how can recognize really how much bone we can take?
I think the key, can you hear me now? Yes,
yes.
I'm unmuted. Okay. The important thing when you have an intracanalicular tumor is to have a thin section CT scan to see where is the posterior semicircular canal. That's a main concern with many patients. Very rarely the labyrinth may be also more posterior. And also another concern in some patients is a very high riding jugular bulb. So these are the major concerns. Generally, I remove 7 to 8 millimeters laterally, but if the posterior canal is not closed, then you can go up to 1 centimeter. That is really the outer limit. Another trick to employ is to drill in an angled fashion. Instead of doing more like a funnel, go more angle. And that, by the way, can be really helped by using very small diamond drill, like 2 or 1 millimeter. And also one can use the Sonopet ultrasonic bone curette. So these are all some tricks. And very definitely, I find the endoscope more and more useful in this situation. And if you have a very good quality endoscope and an endoscope holder, then you can operate with both hands. I think that this is a very important indication for endoscope assisted surgery because you can go pretty far laterally. The trouble that I have with the middle fossa, I also used the middle fossa approach in some other patients in the past. There are two problems. One is the facial nerve, which is sitting on top of the tumor when you come by middle fossa. The second is that, you're also retracting temporal lobe. And of course, the ENT surgeons always say it's not a problem, but we know that any retraction of temporal lobe can create some problems, So I'm more partial to retrosigmoid, but I find really the endoscope very, very useful for this situation. And you can also use endoscope. I didn't show it during, sometimes you can look under the tumor and so on in the CP angle, but we have many ways of doing that. But in this situation, I find it very, very useful.
Thank you.
Thank you.
Sorry, we have with us Dr. Grotenhuis, who has been my friend for a long time. Of course, Dr. Goel, many people. But Dr. Grotenhuis is one of the pioneers of endoscope-assisted surgery, along with Axel Panetsky, whom we all remember now, although he didn't use it, I don't think, for acoustic neuromas. So we have to remember these great people always, so.
Great.
Very nice to remind that, Shaker, that's true. And indeed that Axel Panetsky was great in many skull-based procedures using it. oddly enough, he never wanted to use it for pituitaries and not for vestibular schwannomas. So this was one of the discussions I often had with him at home in Bingen, with this beautiful view of the Rhine, and then with the many evenings along. But I'm so happy to hear that you are still using that, but also good to see that what people sometimes mistakenly think is that if you have an endoscope, you don't have to drill the meatus. That's simply not true. Furthermore, sometimes you need maybe a 45-degree or even 70-degree endoscope, and it's simply impossible, at least more or less in my hands, to then properly dissect. If you don't have a holder system to hold that endoscope with those, 30-degree is possible, because in 30-degree, you still see your instruments that you move straight ahead. You still see them, either in the upper or lower level of your image. 45, you're lost. 70, it's even worse. But sometimes 70 is needed. So you bring in the instruments and somebody holds that and tell you when the instruments are there. So it's not that easy, but I saw this in your beautiful videos, how well you managed to do this. And this also points already to the fact that you do this for 25 years. So this also has a learning curve. Don't forget that. It sounds easy. Oh, I just take the endoscope. And as you mentioned also at the beginning, in let's say the grade 2 or 3, if you look in the superior part and the inferior part, you more or less immediately can recognize, if you turn the 30-degree in the right axis, where the facial nerve is. So before you even stimulate, before you even do anything, you move between the tumor and the fifth nerve, you look downward, and you go from the jugular foramen, look upward, and then more or less you have already localized the facial nerve. For me, always that made it so much easier to start the debulking, because even without stimulation and EMG, I knew where I had to watch out. And then, of course, still, I fully agree that is the main point. The thinnest part is there where the facial nerve turns into the internal meatus. So it runs on the tumor, and then all of a sudden it makes a turn and runs into the meatus. There it is thin, it is grayish, it is nearly translucent sometimes, especially in the bigger tumors. That is the part where you maybe will lose it. Difficulty is that's always at the end of the surgery. So when you more or less have done the whole debulking, the whole removed everything, even from the brainstem, where it is actually dissecting it from the brainstem is way easier than this. And this is still something that you know that when you visited Nijmegen, we already had developed this technique of coating the nerves with fibrin glue, so that they were stabilized, that they were a little bit more resilient to all our manipulations. That is, so this is the way, but I really congratulate you, and I loved your presentation. Such an beautiful example of all your experience, your long time, and also to see it's there. You still can lose the function. We do everything what is possible. It's all about function, but still sometimes it is simply, it's out of our hands. That's true. Again, wonderful lecture.
Dr. Shekhar, you have got a few questions. I'm going to ask a question on behalf of Dr. Adriana Baricci. She's from UK. Problem, she couldn't come on the audio. She says, first of all, thank you very much for an outstanding talk. And what she wants, she has a couple of questions. I will ask you. The first one, for patient on active monitoring, when do you decide to operate? Thanks.
Predict preservation here. Okay, so I think that, hearing preservation is very, very tricky. I have been able to preserve hearing in like 4 or 5 centimeter tumors in a very few cases. And I think that what has happened in those patients is that the cochlear nerve is extremely stable in those patients. And whatever we do, we do the same amount of manipulation. It is not possible to destroy the nerve in those particular cases. In the people, of course, with the smaller tumors, both the auditory brain response and the vascularity of the nerve are important. And of course, we use various medicines such as steroids, nimodipine. Some cases you can coat the nerve with papaverine or nimodipine or nicotipine, etc. In those cases, what I find is that when the preoperative ABR is relatively good, it is better or easier to preserve the hearing function. When you don't have any or very poor ABR when you start, it is very, very difficult. Of course, you have no guide as to how to preserve. However, having said all this, I think that this is an area, both hearing preservation and facial nerve preservation, we are going to see tremendous advances in the next 10 years because of our researches and insight into stem cell technology. We think that stem cell technology is important for, recovery of, people with stroke and neurotrauma and everything else. But it is going to give us more information and insight about how to preserve neural function during our existing operations, because we have the same problem, for instance, with the third nerve, when we're working at the third nerve or sixth nerve, etc. And we need something to stabilize the nerves or even improve their function during our surgery. And I think that we will see. So let us not give up on that. It's important to preserve microsurgery. It's important to, of course, radiosurgery is important. I also do radiosurgery, but we should not give up on microsurgery. We should try to improve. And where the improvement is going to come is techniques which are going to help the brain in addition to what we're doing already. The other question she asked is, if you leave some tumor behind, how do you follow them up with MRI scan? And believe it or not, very frequently the bit of tumor left is very tiny, and it's possible that it undergoes infarction. And I've not seen anyone with a growth of such tiny remnants. Of course, if you leave a larger remnant, then you may need to perform gamma knife or repeat surgery. But those little tiny remnants, they don't seem to grow. And I've talked to some other surgeons, they feel the same way. So MRI, immediately after surgery and then follow up.
Can I get Dr. Andreas Servio to ask his question? Dr. Servio from Argentina.
Yes, thank you very much. Congratulations.
Sorry, I'm on.
Great pleasure to hear stunning presentation. I would like to know your opinion on tractography, because there are many neurological departments which are that maybe tractography it's really a useful tool in vestibular genoma. I think we use a lot for glioma surgeries. This is for corticospinal tract, but we made a little experience in grade 3 and 4. We didn't get a very useful result. Which is your opinion? Do you use it?
Well, we have not used it for vestibular schwannoma cases, although I know the best tractography I've seen is from Japan. They're always so far ahead in imaging. I've seen some beautiful tractograms. We don't have that quality. We do have very good tractography in the brain, but in terms of nerve function, I just not seen it. It may help the surgeon to know ahead of time where the nerve is. There are most of the cases, as we saw, the nerve goes straight up to the canal and then makes a turn. But there are patients in whom the nerve goes along the brainstem and then turns in. So in those patients, maybe it can be very useful. The problem during vestibular schwannoma surgery is that everything is shifting. So once you remove the tumor, we are actually shrinking the tumor and then shifting the images. So it'll be very difficult with the navigation to know that this is where the tumor, the nerve is all the time. So that's why we are somewhat reliant on stimulation. Now, one thing I wanted to mention along these, in regards to this with neurophysiology and stimulation, I think that there is room for more improvement in that area. I mean, we have good neurophysiologists. I know my former fellow, Dr. Ryojo Akagami, is a real expert in this. He's in Vancouver, Canada, and I think Narain and Andres and some of the other people know him very well. But I think that there is more, there is a lot more that can be done to give a surgeon real-time feedback, you know, so that we know that when we are close to the nerve or when we, you know, maybe creating some damage, whatever, both in respect to the seventh nerve and the eighth nerve. What is your experience with that tractography?
We've made a little experience, you know, try to do tractography for grade 3 and 4, but apply the same findings during the surgery. Maybe because some displacement of the nerve, but we couldn't reply the result of the Japanese physician. I agree with you. Can I make another question, Naren?
Sure, of course.
Yes. My other question is, do you in the postoperative period for rehabilitation stimulation of the face? And in this case, how many times do you use it in order to avoid the synkinesis or the hemispasm because of the anomalous reinnervation?
So I mentioned that in my lecture, maybe it went by very quickly. Two things. In people with paralysis of the face, we wait a couple of weeks and then we do perform stimulation. There is really no randomized trial to show that it actually works. However, the patients feel subjectively that it is doing something. Now, there are more recent studies where they are, for spinal cord paralysis patients, they are doing some stimulation of the spinal cord and even the muscles distally, and they are reporting that there is improved or enhanced regeneration. So stimulation of the facial nerve may have some value, you know, of the distal, but also even, you know, transcranial stimulation of the nerve itself. But we need more studies. The second point is about the facial synkinesis. What I find is that it is very important for the patient to practice in front of the mirror. So they have to become actors. You know, our movie actors, very good actors, they can move the facial muscles this way and that way, and you know, they can smile, they can laugh, they can cry. So the patients must practice a lot, and that practice seems to make a very big difference. In fact, there are some studies out of Canada that show even after years of facial paralysis, you know, patients who've had House-Brackman grade, you know, 4 or 5, and then they recovered, when they do these exercises, their facial function actually improves. So it is quite possible that our brain can relearn somehow. Neuroplasticity is maintained. So when we do all these practices, somehow it, you know, it can improve the function.
Dr. Goel, you are a master surgeon yourself, but is there any points that you want to put to Dr. Shekhar, sir?
I would like to say something, first of all.
Sure.
Dr. Goel is such a big and master surgeon and with a huge experience. Mm-hmm. I'm so proud that he was actually my fellow for 2 years in Pittsburgh.
Wow, really?
And he also has a very big experience with semi-sitting position, which I don't use at all. I know that a number of surgeons in India are still using that. So he may want to comment on that as well.
Yeah. So there is no question. This was a wonderful lecture. Acoustic tumors are done by everybody. I don't know of any single neurosurgeon who will say that I don't know how to do acoustic. To give small tricks here and small tricks there and to show these things were a very important part of your lecture. Now, one issue that you raised is about leaving a small tumor behind along the facial nerve. I think it is absolutely wonderful message that you gave, that there is no point in teasing off the last bit of tumor from the facial nerve. I will go a step further and I will say that tumors 3 centimeter or more than 3 centimeter, one should never even try to remove that last bit of tumor along the facial nerve, because it is more, facial nerve, as we know, is the identity of the person. Is everybody loves his own face. To take the risk and try to tease the facial nerve of the tumor in more than 3 centimeters should not be even tried, and small bit of tumor should invariably be left, except in rare situations. This is my personal feeling. The other thing that you said about sitting position, my feeling is, and I'm absolutely convinced, that sitting position should not be relegated to historical domain. It is an absolutely wonderful position. And with that position, you know, over my experience of acoustic in several hundred, means more than 1,200 cases, I have never ever.
Sorry, just a second.
Do again what, baby?
Sure.
What game?
I think that's a
very young acoustic neurosurgeon, budding
exactly,
one.
Exactly.
Shekhar, as Professor Sami has also said, that sitting position is an absolutely, you know, we should learn to respect that position. I know we are hesitant to do because of course, if you're, you know, if you're going to do the surgery for 8 hours, 7 hours, then your hands may not be stable enough. But if you are rather quick surgeon, as you are, I know, sitting position should be used, and you can avoid petrosal approach, you can avoid middle fossa approach, you can avoid all that mastoid drilling, you can avoid all that petrosal, you know, handling of these sinuses and all those things. My feeling is that sitting position is wonderful for a number of cases. Even petroclival meningiomas can be removed by sitting position if we have a nice hang of this position. So these are small little points which I wanted to mention, but on the whole, what little small bit tricks you gave were wonderful as usual. And I actually am a little bit, you know, not very comfortable in commenting to your great lecture, because you are you and I am I.
Thank you very much. Thank you very much, Dr. Shekhar. That was wonderful lecture, and I'm sure it's a great inspiration to many people. What, you know, you can always study from books, but it's nothing like having direct communication, and particularly in these COVID times. It's still nice to get that, you know, these are memorable events. I think people don't realize that when we go to conferences, courses, you know, probably we could learn more sometimes staying home and studying, but it's the things that you pick up that you don't realize that you pick up, the inspirations. And so I think, thank you very much. I'm sure the residents and young neurosurgeons and even others will be very grateful to you. Thank you very much.
Naren, I wanted to say something, few
Sure.
words, because this is in response to the introduction. First of all, I wish to thank you for coordinating these beautiful courses. You've been doing them for years. And if you may remember, last time I had mentioned to you, can I do a tele course or a tele lecture? You said, no, I want you in person. But it just so happened that we are doing now so many tele courses. And I actually find, you know, these tele courses have one advantage, that everybody is comfortable in their own environment. And you have a different set of audience that cannot go to a meeting, you know, because going to a meeting means you have to pay registration, you have to stay in a hotel, so on and so forth. So that's number one. And I really like to thank you for being a pioneer and leading educator. And I want to amplify something for people that may not know, that I am of Tamil origin. Tamil actually is not Tamil, it's Tamil. You know, it's very hard for other people to say. I am from Tamil Nadu, and Naren is originally from Sri Lanka, but is a Tamil part of Sri Lanka, northern part. So we are connected. However, having said that, all of us are connected. Every single one of us is connected by an invisible thread. So it is an amazing thread that connects everyone. Why? Because we are engaged in the care of patients. We are not doing, we're not politicians stealing money from others or denying elections or taking bribes. We're not there killing people. We are helping people every day, no matter what. We have complications, but this is our intent. So we are, and we also have a very special connection, that is neurosurgery. Neurosurgery is a very unique and very special family, because everybody knows this is difficult. Many years of training, constant education, constant practice, and so on. So I am so honored and privileged to be a part of this group. And also, for having met all of you. And, I hope to see many of you in person again. God knows when that'll happen, but, eventually. So eventually, yes. Thanks very much. And really a privilege and honor to be in this meeting.
Thank you very much, sir. Thank you very much indeed. Just to bring the day to its close, I have put a link for e-posters. Many of the abstracts, I had to put it to e-posters, and congratulations to all those people who did the e-posters. I have put them in the, if you go to the, I put the link, I think I'll put it again. And if you go to the website, conference website as well, then you will, so I've just put the link on the chat box, and then you click it and you go to YouTube, and I have put the slides as a video. So it takes 45 seconds for every slide, but you can stop it and go through, and any comments you can put it in the video chat box. So, then authors can answer it. When you put the your questions, I have to approve it, so there's a bit of a delay, but I had to do that so that people don't put something else. So please have a look at it. And tomorrow we have again, quite unbelievable day. To be honest, as I mentioned earlier, that just Dr. Shekhar is enough for a conference, and so tomorrow we have got seven keynote lectures, everyone on the top of their field. Professor Maximilian Machdon is going to give us an update on the surgery for Parkinson's disease. I know all of us came into neurosurgery to operate on the brain itself, and what you will get from Professor Maximilian Machdon, where we are at the moment. Miguel Ares, Professor Miguel Ares from Malaga, he's going to talk to us about adult brain stem tumors. Then Mariano Sokolovsky, he's a neurosurgeon in Argentina. He's a chairman of the peripheral nerve section of the WFNS. I tell you, if you haven't heard his lecture, you have to hear it. He's one of the, although English is not his second language, he's a fantastic orator, and he can sell what we call cauliflower to a cauliflower farmer. It's absolutely, and he will convince you that everyone has to be a peripheral nerve surgeon. So please don't miss it. Then we have got the pleasure of privilege of having Professor Fred Gentili. I think pretty much most of British neurosurgeons have been a fellow of Professor Gentili from Canada. He's going to give us lessons learned from a career of 35 years in skull-based surgery. Professor Iacanangelo, he introduced me at his course in Ancona. Then we have got Professor Gus Alusi. He's from London. He was a former colleague of mine, but more importantly, he's someone who actually treated me, and I don't think I'll be here without him. He's going to give us a talk on advanced and extended endoscopic surgery. He's an ENT surgeon, but he's a skull-based surgeon and a fantastic personality. He's like my brother. And then we have got Robert Harbour. He's going to give us a lecture on unruptured intracranial aneurysm. Anyone with vascular surgery, you will get this every time, and Professor Harbour is world-class on this. And then we'll finally finish off with Dr. Frederick Boop, the president of the ISPN, the Pediatric Society, International Pediatric Society, on the molecular biology of brain tumors and how it will affect. So we have got a great day tomorrow as well, starting at 8:30. So I wish you all a very good evening. thank you very much for all the senior panelists. Thank you very much all for all the participants. And as I mentioned, all these senior people and the chairmen, they have taken their time on a weekend because it matters to them what they give to you. So thank you very much. See you tomorrow.
Thank you so much, Naren. It was a great day.
Thank you, sir.
Enjoyed it immensely.
Thank you. See you tomorrow, Prof.
Ross, good seeing you. Maurizio, bye-bye. Ciao.
Ciao.
Thank you. Ciao, ciao, Andrea.
Ciao, Maurizio.
All.
Thanks, Maurizio.
Best.
Thank you.